Со временем наши коллеги будут присоединяться. Приветственное слово хотим предоставить вице-президенту нашей больницы Амангалиеву Данияру Бахтичу.
Здравствуйте. Алло, слышно меня, да? Здравствуйте, уважаемые коллеги, наши зарубежные гости.
Good morning, dear colleagues, our overseas guests. On behalf of the administration of the clinical hospital, I would like to thank you for the presence at this very important for us forum, which characterizes the beginning of a state-of-the-art direction, neurovascular directions. And I would like to wish to this very important form of fruitful work. We are one of the oldest clinics in the country. At the same time, we are one of the best clinics which implements the state-of-the-art directions like neurovascular direction, which is related to neurosurgery and neurology, and which is trying to address very severe forms, very severe conditions. Sometimes they are incurable conditions. So we start neuroetics today, and I believe that this will be a very serious direction in stroke management. We are pretty much inspired by the fact that a part of the leading specialists, leading global specialists, have responded to our invitation. We hope to develop some methodological solutions, and we would like this forum work on a continuous basis. And I hope that your decisions and your resolutions at the end of this forum will give us an idea how to move on. I would like that all the objectives set before this forum, like scientific, creative, would be a success. I hope that the questions that will be raised, my colleagues will give an impetus to further efforts, so that we should have better idea of how to prevent and to manage such serious condition like stroke. Thank you very much, and I wish you success.
Следующее слово предоставляется руководителю.
The next floor goes to the leader of the Republican Cardiology Center. The floor goes to the manager of the Republican Cardiology Center. This has been translated. So the welcoming word goes to the Republican Cardiology Center dealing with stroke issues to Adilbekov.
Stroke problems.
Okay, dear colleagues, dear friends, I would like to welcome you at this scientific forum. It has become a tradition to hold a forum in our Hospital Neurovascular Surgery, and on behalf of the chairman of the National Neurosurgery Center, Akshulakov, I would like to extend the gratitude for your participation here, because here we have the neurosurgeons from all the regions of Kazakhstan, and the farm is very well represented by our colleagues from the farm away overseas countries that will, as I hope, identify a new state-of-the-art methodologies. Well, I wish you success and scientific success. Dr. Naiman. The welcoming word goes to our supervisor, Dr. Shimon Maimon, who is the person who taught Kazakhstan how to use microcatheters and intravascular instruments.
For me, it's closing a circle. In 2007, I arrived first time in my life to Kazakhstan to open the first center of neuroradiology, interventional neuroradiology in Astana. I was given 6 doctors to choose from them 4 which will build the first intervention unit. One of them was Majalenka, and now after 10 years I'm seeing him organizing a meeting which we spoke a number of years ago about how to organize and how to do it. And for me to see this country, which was a real desert in the field 10 years ago, having now around 3 or 4, if not more, center, doing cases and doing high quality cases, it's like a magic to see. And this was a dream which we built slowly along the year. We discussed how to spread the knowledge in the country, how to develop center in the country. And I see Majalenka and his friend doing it. Now there are 3 groups, but it doesn't matter. They are doing the job, they are saving people's life. So this is for me one of the best, and thank you for coming for this.
Okay, Dr. Maimon, I think we could start with first lecture. Спасибо за предоставленную слово.
Thank you very much for the floor given to Dr. Maimon. He is our teacher, our tutor, and our colleague, Serjan Barambavich, from a cardiology center. It's very, I'm sorry that Sergey Andikich has left with the government committee to Petropavlovsk, because he was pretty much willing to participate in this forum, but order is order. And so he has given his regards through Serjan Barambavich. We really hope that as a result of this work, as a result of this forum, some issues that were of concern to you or probably were of interest to you will find their answers. We have devised some live cases. I hope that they will be of interest to you. The forum format is free. Our foreign colleagues are pretty much accessible. You can freely come up to them and communicate with them. At 11 o'clock there will be a coffee break. From 10 to 11 there will be the first surgery. At 2 o'clock we will split the hall into 2 parts. There will be a lunch. The hall for the lunch is very small. So the lunch will be in 2 rounds, and then there will be a bus waiting for us. So we will see the city. Thank you, Czechia. Czechia has created this forum, and
we are changing our mind. We're changing our experience from all over the world, from Turkey, from Israel, from United States, from Germany, from Malaysia. and it's very exciting. And hope our Neurodic chat will help to improve healthcare and stroke service in Kazakhstan. Thank you.
So good morning. I was asked by Majalenka to speak about aneurysm, and I asked myself what I can teach, what I can give you. It's not so simple today. And I will try to show you my way. It doesn't mean that it's the right way. It doesn't mean that it's the wrong way. This is my way. This is what I did along the years. This is the experience that I get along the year. And this is what I believe, and this is why I'm doing it. Sometimes it's not as acceptable by others, but this is a life. So I will try to show some of the cases and discuss some of the points that we have debate in the Neurodic group concerning treatment of aneurysm. Why is it doesn't go? Oh. So, first of all, how do I plan the treatment? Because one of the things that I have seen that people are going to the treatment without a plan. At the time of the treatment, they start to build the plane. And this is a mistake from my point of view. You don't decide if you are going to put a stent while you are inside the room doing the case. You have to decide before you arrive to the room, before you touch the patient, before you puncture the artery. If you are not doing this, you will have complication. So first of all, you need the data. My data today is only from CT angio and MRI. I don't do diagnostic angio anymore for organizing or planning a treatment. No, I don't need it. We have beautiful images in CT angio today, which, from my point of view, give you all the data that you need to plan the treatment and to do the treatment. And then I ask myself, what is the type of aneurysm? Which I sometimes see people speaking about aneurysm without defining the pathology. Because dealing with dissection aneurysm or bony aneurysm is not the same. It's not the same goal sometimes. The location, the size. We are speaking about ACAM aneurysm, but sometimes this ACAM aneurysm is compression in the chiasmatic apparatus. It's not the same, because the chiasmatic apparatus is not it's not a nerve, it's a brain. It's reacting differently to pressure than third nerve. So we have to know this. Partial thrombosis, we have or not, it's a lot of influence of the result. If you have partial thrombosis and you are putting coil inside, you know that in 1/2 year and 1 year, all the aneurysm will be reopened again. So this data, which I sometimes don't find when people put in Neurodic cases, it's very important and you have to know it before. Bled, did not. Patient age. We cannot react to 80 years old guy with aneurysm, ACAM aneurysm that bled, same like we react to 30 years old guy. It's not the same. You don't have the same goal. And how many aneurysm? How many you are going to treat? 1 or 2 or more? And if one of them rupture. And then, after this, after I have all this in my mind, I plan the goal. And I think that in everything in life, and this is also what we did when we started in 2007 to build the idea here, you have to put a goal. If you don't have a goal in the beginning, how do you know if you fail to succeed? You build your goal while the time of the treatment? It's not. So you have to decide what is the goal. Only to prevent bleeding, what we do in many cases of rupture aneurysm, reduce mass effect, anatomical cure, yes or not? All of them or part of them, what is acceptable level of risk? And this is most important from my point of view. What is the risk you are going to take in the treatment? And it depends on your skill, on your complexity of the treatment, and many factors. And I don't like the idea that some people quote the number from the literature when they are speaking to the patient. How can you say it 4% when in your hand you didn't do more than 50 aneurysm in your life? It's not 4% in your hand. It's far more than 4% if you did only 40, 50 aneurysm in your life. So this is for me the way I work. All this gives me the type of the treatment I'm going to treat, and then the selected approach, and then the tool. Sometimes people are wrong, I think. They are choosing a tool and then they are putting the goal. No, the tool are coming the last. They are only tool. You can play with them as you want. If you know the goal, then you have to decide with your skill, with your knowledge, what approach, and then what tool, and not vice versa. Sorry to say it. Not because you have been in a lecture or you have been in a conference, you see someone do double balloon treatment for every aneurysm, you do it by yourself. It's not the right approach, sorry to say to you. You have to think, to ask yourself if you can do it in the same level of skill that he can do it. No, it's not the same. So this is why sometimes in the neurodics ask people some questions. So then you ask yourself if with one guiding catheter or more, long sheath, 6 French or more, only microcatheter, with, without balloon, with, without stent. All of this have to be planned before. And I can tell you, this is what I'm doing in the last 15 years. I never go inside a treatment without a plan before. And in most of the time, I have 2 plans. The first one and the second one. If this I will fail, I cannot do it, I will go to the second one. I will never go inside to a treatment and build the plan inside the treatment. It's a mistake. So, from my point of view, and this is why I try to teach the group here, simplest is a safe. Do it simple. Don't try to do it complex. If you do it complex, you have complication. So, let's see some cases, and I'll try by this to explain my, I think, philosophy, way of thinking, which is maybe wrong. So this is a patient with unruptured right A1 and left A1-2 aneurysm, 55 years old, healthy female. So if it's an unruptured, I have to ask myself if I'm going to treat these 2 aneurysms in the same session. If yes, which first? And if it's ruptured, the same question. So first of all, this is something that's raised up in the neurodict. Yeah, I don't like to treat 2 aneurysms in different territory in the same session, surely if it's rupture. Also if it's not rupture. If this aneurysm was here, and this was rupture 1, and the patient is Huntington's 1 or 2, which have success to, which there is chance that you will survive, I will treat the 2 together. But if it's a patient with Huntington's 1, there is any option that this is a picture will be here? No, not my picture. Excuse me. Mister, could you put this here? The images here? Because I cannot, it's far from me. So, if it was a ruptured aneurysm, this one, and this aneurysm was in the left side, and the patient is in Huntington's 1-2, good clinical condition, and have chance to leave the hospital, I will consider to treat them 2 in the same session. But if the patient is Huntington's 4, and this bled, and there is another aneurysm here, why to take the risk, any risk, to damage it more and to kill him at the end? Because we have to remember, patients with ruptured aneurysm are very fragile. Any small change can cause very severe morbidity. So this is an unruptured. For me it's simple. This is a bigger one, this is an unregular one, so I decided to start with this. And what to do? I have to plan, and the plan was simple. Coiling with remodeling. Remodeling and balloon are a marvelous tool. I like them, I use them, but when I need them. And then I'm going to, I don't see anything here. So I'm going and treating, but I don't need. If I'm going to treat a patient without a stent, why need a double lumen balloons? I can do it with a single lumen balloon. It's less stiffer, going easily up, so I use a device according to the plan. If I don't going to put a stent, I don't need a double lumen balloon, sorry. If it's rupture aneurysm, it's something else also. I will treat the one that rupture, and then the second one in the later phase. So the second aneurysm here will be treated in 3 months, and in this case, this is a classical case for half T. This is a A1 aneurysm. This is not carotid bifurcation aneurysm. Most of them are A1 aneurysm. So this, for me, is not balloon treatment. It's one catheter in N1, one catheter in aneurysm, partial deploying of a coil, partial deploying of the stent, filling the aneurysm with one coil, deploying the stent, and finishing without a balloon. This can be done without any balloon, and I will show you cases. So balloon is a tool, no more than this. Use it when it's needed, not for every case. So if you have this, two aneurysms in the same territory, surely if it's an unrupture, why not to treat the two on the same? They are the same artery, the same territory, and don't have any problem. And surely if it's a rupture aneurysm, if this was a rupture aneurysm, and I have treating this, if the patient is in a good clinical condition, I will think about treating the other one. But you know, all this came from the past, when neurosurgeons were treating more than one aneurysm because they was afraid that the triple H will cause bleeding of the second aneurysm. But we know that it's not true. No one saw a rupture of second aneurysm at the time of subarachnoid hemorrhage. No. So we know that it's not true. So why to rush and to treat the second one if you are taking risks which can change all the history of the natural behavior of the disease at the same time? So you can see here, this is a rupture, this is not rupture, so in this case, we treat it with two stents. No balloon, only stent. Two baby Leo telescopic. You can see that the patient has another two aneurysms that was treated. This one, the MCA, was the one that was bleeding 1 year ago. Due to the fact that the second aneurysm was in the same area, wow, you make me crazy what you're doing to me. In the same area, so we treated the second one at the same session. So you can treat 1, 2, or 3 aneurysms in the same session, but it depends. The case, the location, rupture, not rupture, the patient condition. No reason to do two aneurysms in a patient with Hunt and S5, which you know that the chance that he will leave the hospital is less than 10%. So why to take the risk? But this is my philosophy. Another point which I put more and more because I saw people doing very dense packing in aneurysm while they are deploying baby Leo. Baby Leo have a flow diversion effect, and also with not so much dense packing, you get very nice result in curing, and I will show it in a few minutes. You can see the result, the follow-up of this aneurysm, which is cure after 1 year. So let's go to another one. This is a rupture ACAM aneurysm, day 6 of bleeding. You can see the vasospasm, wide neck. We have 3 vessels. So, if we have 3 vessels, we are going to take 3 balloons. According to this idea, if you have 2 vessels, you have to take 2 balloons. If you have 3 vessels, you are taking 3 balloons. No? So we are going to put 1 balloon in every branch? Why not? So 3 balloons, 2 balloons, 1 balloon. We have to choose. So I'm sure that some people would choose 2 balloons because they like it. But for me, if I can do something with 1 balloon in safety, I will do it with 1 balloon in safety. I will not rush to 2 balloons and 3 balloons. I know to do it, but I don't think that there is a reason. And the other question will be, what is the goal? This is a patient with Fisher 4-3, Hunt and S4. His survival rate is very low. Chance to leave the hospital is very low. So I have, on the acute phase, I have to only prevent rebleeding. So this is my goal. So to go to clipping or endovascular. I will tell you something that I'm sure that the neurosurgeon will not like me in the room. But in the last 15 years, I sent only 2 patients with subarachnoid hemorrhage to surgery. I don't find any reason today, with the tools that we have, in a skilled hand, to send any patient to surgery. In a skilled hand, the rate of complication in coiling of aneurysm is less than 3%. Less. I don't think that you can reach this result with neurosurgery. I'm sorry to say it. But I know that some other people don't think like me, and every MC aneurysm going to clipping. But in the last 15 years, 2 patients, no more than this. But this is a kind of attitude which is not acceptable in all the places. So, for me, This is a case for coiling, not for clipping, so that we have a wide neck, 3 branches, and surely it's not simple to clip while you have vasospasm at the day 6. So 2, 3, 1, where to put them? And this is also a question, where are you going to put the balloon? And this for me is simple. I want 1 balloon to protect the 3 arteries, which will give me the option to protect the aneurysm and not more than this. Not more than this. I'm not going to cure the case. I will see if the patient will survive, and then I can do T stenting. This is not for half T at all. So 1 balloon and 1 catheter. And you can see that I'm not inflating the balloon till the maximum. I give freedom to the catheter when I push the first coil. And one of the things that I saw people doing, and I will show you a case, while they're deploying the first coil, when they're doing remodeling, they are forgetting that the balloon is holding the catheter. The catheter don't have any space to move. And they're putting the catheter in the middle and sometimes in the wall of the aneurysm. And they are pushing the coil, and they are surprised to see that there is a rupture. You forget. You are holding something and pushing through it something. If there is a resistance, it will rupture the wall. But if there is no, you don't hold it. You inflate the balloon partially, it can move. So you can fill the first or deploy the first coil without any chance that you are rupturing the vessel, and then you inflate the balloon maximally and continue your work. So this is what I'm doing. You see, the first is with not complete inflation of the balloon with some free space for the catheter, and then I'm feeling that, yeah, this is not complete occlusion of the aneurysm. This is not a angio image marvelous one, but I don't need more of this. I only want to protect the patient from rebleeding. And 2 months later, as you can see, he didn't improve. He will not improve. His chance to improve is 0, so we are not going to change his life. This is a small basilar tip aneurysm, unrupture. Clipping of a rupture carotid bifurcation aneurysm in another hospital. You can see the multiple clips they put here in the acute phase of hematoma and bleeding, and huge bleeding with the patients that arrive with herniation. A different doctor from another hospital advised them to do the treatment with 2 balloon and stent. Why? How? First of all, this patient is going to schedule for bone implant. If you are going to put a stent, this may mean 1 year of aspirin. So what about the bone implant? You cannot put it. So this is not good advice. And 1, 2 balloon. If the aneurysm is involving only the P1 on the right side, why you need 2 balloon? Enough is 1. So do it simple. 1 balloon, catheter, and finish it simply. It's a simple aneurysm. Why to make it complex? It's a really simple aneurysm. So in this case, the best result can be get by remodeling with a balloon, no need for stent, simple and safe. And this is example, and I have 2. I'm not sure that I will have time to show you the 2. Example, how we can kill a patient easily. And I'm sorry to say it. We are a doctor, and I will say something that people will kill me, but something that one doctor told me in the past. We have license to kill. As a doctor, we have license to kill. And the only one that can stop us from doing this is us. And if we are not doing it, we are killing people. And this is an example of a doctor which has 6 years of experience. 2 years of fellowship in the United States, 4 years working in my country. This is a patient, 40 years old only, have 2 children at home with this small aneurysm, which is a question to treat or not. This is only 4 millimeter. But he decided to treat because there is a kind of nipple. You can see it here somewhere. There is a nipple here. And he decided to treat it because of this nipple there. Okay? Maybe it's a right decision. I don't know. We don't have enough data to know about. We know only about size. We don't have data so much about shape. And look what happened. He's doing remodeling. And he started to push the coil. And you can see that there is pressure because the coil starts to become like a loop. and he forget. He put the catheter very distally. He put the balloon. There is no space to the coil to move. And the result is simple immediately. He's rupturing the artery. You can see that the coil size are bigger and going outside from the aneurysm. Okay? So we have this. Huge, huge bleeding. In a minute, the patient is on Plavix and aspirin because he planned to put stent. Plavix, aspirin, heparin. Rupture, it's not so simple. So let's see what he's doing. Where is the balloon? The first reaction, if you have this, is to inflate the balloon in front of the aneurysm, to pull back a little bit the catheter, and to deploy short, small coil. And not to wait and to inflate the balloon in the A1 area, far from the aneurysm, and to wait and not to do anything. Then you have this amount of blood, and the patient is dying, and he died. So with mistake of decision, mistake of plan, mistake of how you deploy his coil. And if you have a problem, you know how to react. You have to know how to react. You have to know what to do. If you don't know what to do, you are killing your patient. And this is what happened. He didn't know what to do. So he didn't inflate the balloon in the right place. He didn't put inside small coils and stop the bleeding. And the patient died. So, it's easy. Sorry to say. In our hand, it's easy to kill a patient. It takes a few seconds, no more than this. This is the rupture aneurysm in a 70 years old healthy male, but antennas 1 and fissure 2. And this is a case from 2007. And the question was how to treat it. It's not simple, because it's a small aneurysm with a nipple, wide neck. You can do remodeling, but it's not so simple, because it's not easy to hold the aneurysm, the coil inside. You can do it by taking 2x4, the first loop, you fill this, and then you pull back your catheter into the proximal loop and try to build it like this. It's not simple, it can be done. But I decided, and maybe it's a mistake, to do it with a stent. So we can see here the aneurysm. We can see the layer. And then I went through the layer, and I didn't do gelling. And why not gelling? And the reason why not to do gelling when you're treating small aneurysm, and we gel the catheter inside the small aneurysm, while you deploy the stent, the catheter inside the aneurysm moves forward. And I will show you maybe a case. This can cause a rupture. So in those cases, I prefer, if I can, to do it through the strut and not to gel. And this is the result. Complete occlusion, and the patient was cured and went home. But let's say if it was fissure 4, and I cannot put a stent because he's had a drainage, there is no other option. Or to do remodeling, or to take to surgery. 75 years old male to talk to clipping with calcified wall. It's not so simple. Small aneurysm, it's not so simple. So, but if it was a fissure 4, high amount of blood, I would do remodeling. I would take the risk and will do remodeling. So, when we speak about aneurysm, as I said, we have to decide if it's what type of aneurysm. This is a chronic fusiform dissection aneurysm of MCA. So, what is the goal? And the goal for me in this case is to cure the artery. It's not only preventing, it's to try to cure the artery. And from my point of view today, the only way to cure artery is our stent or flow diverter. So we choose, in that case, to do it simple, no balloon, one catheter aneurysm, one catheter in the M1, and we do what we call stent assist coiling and coil assist stenting. We deploy partially the coil, deploy half the stent, then completely deploy the coil, and then deploy completely the stent, this to prevent the stent from jumping into the aneurysm. And you can see the result later on. I will show you. You can see that there is very loose packing, very loose packing. If it was a rupture aneurysm, it's a different story. If it was a rupture, it's again bypass. If we can stent, if it's low grade of fissure and low mortality, but if it's rupture, it's a big problem. And one of the options will be here a bypass. Why not flow diverter? No doubt about that, flow diverter are a good tool. I use it less and less today. I'm telling you the truth. I'm afraid more and more to put flow diverter in this area. I'm afraid from the lenticular artery and from infarct, and I think that with Leo and baby Leo, this chance that will happen infarct due to branch occlusion is low. This is why I prefer to do it with this type of treatment. Maybe other will do it with flow diverter. And you can see the result. I think that nearly curing the ulnar artery. What is important, we are getting the effect by two facts. By the flow diversion effect of the strut of the baby Leo, the small pores of the baby Leo. And the second point, we are straightening the vessel, which causes the vector of the flow to be more directly to the distal M1 and not to the aneurysm itself. So treatment can be done in different way, no doubt about. In that case, balloon, from my point of view, if I would use it, can lead to vessel damage. For me, balloon is not an option in dissection aneurysm or fusiform aneurysm, only in rare occasion. So I showed this case past, but I will explain why. This is a big rupture ACA dissection aneurysm in a 30-year-old patient. So the goal was to prevent rebleeding. So how we can achieve it? From the CT angio, and we are not doing diagnostic angio before, only CT angio or MRA. We knew that this is dissection. So from the beginning, we took 2 guiding catheter. We knew that we were going to do balloon occlusion test, because for me, from my point of view, dissection aneurysm acute rupture, the best treatment, if you can, is to sacrifice the artery, if you can. If not, there is other option, bypass or stenting, as we will show in a few minutes. So you can see that there is a loose collateral system. There was no option to sacrifice the ACA, which was the best treatment, and the patient have been, there was an EVD that inserted the evening before. So what are the options, bypass or stenting? We decided the bypass is too risky. We don't have anyone that know to do it in high quality in the hospital. So the other option was stenting, and you can see what we call coil stent assisting. The coil is assisting us to deploy the stent without budging of the stent of the baby Leo into the big aneurysm. And this is the end of it. So this was a solution, and this was the result and the follow-up. And also that it's good result, we have to remember, we inserted here 3 stents, multiple stents, still risky for thrombosis. So this was still a risky treatment, which we didn't have in our hand at that time any other option. So balloon are a magnificent tool, but in this case, they doesn't have any place from my point of view. This is another case that I have in the last weeks. A 10-year-old child treated first a few months ago in another country, unruptured aneurysm. You can see that the one that what is going on? The treatment was done in another hospital, and there was a coil that was stuck, and the coil was stuck there, and they left the coil along all the carotid artery into the external carotid here. So it was not simple to go through this artery while there is a coil from other treatment. We have here a dissected segment with 4 aneurysms, 4 different aneurysms. So how we can treat it? One of the options that was advised to put a flow diversion. I don't know. I don't like to put a flow diversion in a 10-year-old child in MCA with multiple lenticular arteries there. I don't like the idea, but maybe it's the right idea. So I decided to do it with Leo and baby Leo and catheter. So with 1 catheter in the M1 and 1 catheter that I moved from one aneurysm to another, we occlude 3 aneurysms and we treat the patient. So the idea was, as you can see, we have a catheter here, another catheter in the aneurysm, deploying some coil, then deploying partially the stent until the first aneurysm, then moving the catheter, the second catheter, to another aneurysm. You can see it here. Then coiling it, moving to the third aneurysm while deploying completely the stent, and then we have all the aneurysm coiled. You can see the 3 and the stent. And so you don't need balloon for this. You can do it with, you can use the stent like a kind of balloon. You don't have to deploy all the stent immediately. You can deploy part of it, and then another part, and then the third part, and you have freedom to move your catheter and to do the job. And you don't have to do dense packing, and I'm sorry to say it. When you're using baby Leo, you don't have to do dense packing because baby Leo have a good, very good flow diverting effect. This is another case which I can show you that you can do it without balloon. This is an PCA aneurysm, P2, P3 aneurysm, fetal artery, very tiny P1. So with 2 catheters, simple 2 catheter, you can go from the carotid artery to the PCOM and then into the aneurysm and deploy the coil and the stent and finish it. Yeah, if it was a rupture aneurysm, it's a different story. Then I will choose a balloon, we'll go with the balloon to the PCA, with the catheter to the aneurysm, and do partial coiling, because this aneurysm without the stent have a high chance to reopen again. So I will do partial coiling to prevent early rebleeding, and then I will bring my patient, if he will survive the bleeding, 2-3 months later, and do the stenting. So this is example from a case from 2000 to something, 2011. At that time, we didn't have baby Leo. We have only Leo. And this is a post-coiling and clipping of an echoaneurysm regrowth. You can see that with 1 catheter, you can do T-stenting and coiling. You don't need multiple catheter. So what we did was, first of all, we went up with the Vasco 21. We put the first coil with first stent, and then we went back and go to the second branch, put another stent. This is a T-stenting, and then change it to echelon, go into the aneurysm through the strut, and put coil. So you don't need 2 balloon, 3 catheter to do a treatment. You can do it with 1 catheter if you need to change it. And it's far more simple from my point of view than to go with a 6 French, 7 French sheath with 2 balloon, 1 catheter, and put pressure on the vessel and all of it. But you know, it's my opinion. It's a way of working that I'm doing. And you can see another example. I'm sure that many here in the room will do here this case with 2 balloon, first of all, remodeling, coiling, and then deploying the stent. I have disagreement with some of them about it. I prefer to do it with 1 balloon and other 2 catheter. 1 is inside the other branch, the A2, the other inside the A2, so we can do, first of all, remodeling with 1 balloon, coiling, and then T-stenting, and finish the case like this. And you can see that the result after 1 year is not so bad. And you don't have to feel it so much. It's not dense packing, it's a little bit loose packing, but the result, as you can see downstairs there, 1 year, it's very good. So, Piotr, you have something like this I saw in the NeuroAddict. So this is one of the solutions that we use in one of our cases. This is a not fetal, completely fetal, but it's a PCOM aneurysm, big one, wide neck, involving the PCOM artery. So this is an unrupture. So when it's unrupture, I can use stent without being afraid. If it was a rupture aneurysm, it's completely different story. This case, I will use 2 balloons, 1 in the PCOM, 1 in the carotid, and I will do coiling. If it was a rupture, but this is not a rupture, so I use only 3 catheter, no balloon at all. 1 vasco in the carotid artery, 1 echelon into the PCOM, 1 echelon into the aneurysm, and then deploy first the stent in the Leo in the carotid artery, then the baby Leo. Then the baby Leo is deployed into the PCOM, into the area with connection into the, you can see it here, like a T, and then coil. And this is the way that I do it, and this is 1 year follow-up. You can see that the nature built a new road to the PCOM, but the aneurysm is protected. So without balloon, you can get this result. No doubt about if the patient was a ruptured aneurysm, this is the only way to do it with balloon. And surely with 2 balloons will be better in this case. And this is an example that I don't think that there is any place for balloon. You cannot put a balloon here. You cannot put a balloon here without rupturing the vessel if in this curve. So if it's a ruptured aneurysm, I will go with a simple catheter. We do partial coiling, and then in the future we'll bring the patient for standing. But this was an unrupture, so it was not so simple. But the way to do it was, from my point of view, to put a stent and coil without any need for balloon. So this is the way I treat. And this is another example which we can discuss. What is the best way? This is a patient with fibromuscular dysplasia. I don't like to put 8 French, 7 French guiding catheter inside the fibromuscular dysplasia vessel. I don't like it. Sorry. So what is the way? What is the easiest way from my point to do it? If I am going to do it with a flow diverter like a pipeline, I will need a Markman with 27, with a long sheath or something which should have to support me with this old curve. So I have a chance to finish this with dissection of the carotid with fibromuscular dysplasia. So from my point of view, if I can do it simple, it's to take vascular 21, echelon 10 and do it. And the way to do it is to go and with your catheter inside the echelon inside the first aneurysm, deploy the stent, fill the coils, pull back slowly and jump into the second aneurysm and fill it and finish the case like this. Yeah, it's a little bit maybe crazy, but the device are smaller, the risk that I will cause damage to the vessel, to the carotids are lower, so this is why I choose it. The simple way was to put a flow diverter here, and to finish, but I don't think, I'm not sure that it's the best way, I'm not sure. So, balloon and stent, and this maybe part of the discussion in the neuroaddict was, balloon and stent are only tool from my point of view. They are nothing more than this. And the choose of one or more you need is according to your goals. And the type of the lesion and other factor, including, and I say again, including your skills. And people forget, what you see in a meeting is not what you know to do. The guy there in the meeting is someone with 20 years of experience, have done hundreds and thousands of cases. And then you are going to do double lumen balloon treating of wide neck aneurysm by yourself? Friend, this is not 3% and not 4%, this is 20% in your hand. Be careful. You know, I was in one of those meetings and people saw their pressure cook, and one of them told me week after, he's going to treat a patient with a pressure cook technique. I asked him if he knows to treat without pressure cook. I'm not sure that he knows to do it. So friend, you know, meetings are good. We are changing knowledge. But remember, you have to use the tools according to your skill, according to your experience, and not according to what is written in the literature and what you have seen in the meeting. Thank you very much.
Dr. Maimon, thank you very much for your presentation. Maybe some colleagues have any comments or questions? Комментарии? Okay, thank you. So the next speech is about the keyhole aneurysm clipping by Dr. Park Seung from South Korea. Следующая презентация посвящена принципу keyhole в клиппировании аневризм. Доктор Парк Seung, Южная Корея.
Good morning, everyone. Can I use the microphone? Because I'd like to present over close to the screen. Thank you. Thank you. It's my great pleasure and thanks to Minjil Ki to be here. I'm going to talk about the keyhole surgery for aneurysm clipping. You see the door, and here is a keyhole. When you blink your eye, bring your eye close to the door, you can see the interior of the room. That is the concept of keyhole surgery. This is a paracella area. The neurosurgeon make wide craniotomy for approaching to this area. But the limitation is the skull base and brain itself. So small craniotomy is enough to see this area. This is concept of keyhole surgery. So keyhole surgery means make craniotomy as small as possible, and deep portion is good than the shallow. This is minimal invasive, and also it provide same surgical field like conventional surgery. And the need for this keyhole surgery is increasing in the vascular era. So there are several routes for the keyhole surgery. One is transciliary, trans-eyebrow incision, and another is mini-terional and transsylvian, and third is interhemispheric keyhole, and lateral suboccipital for posterior circulation. So today I'm talking about only supraorbital keyhole approach. As you see, the sky is very minimal in the eyebrow in here, makes small craniotomy. There are several synonyms, and transciliary, supraciliary, superciliary, all of the same. The preparation is very simple. Just painting alcohol in the eyebrow, and then wrap. Very simple. And use the scalp retraction like this. Let me show you one case. 35 male, unruptured anterior corridor aneurysm. This patient had smoke and hypertension. You see the anterior corridor artery come from the neck of the aneurysm. So my endovascular neurosurgeon don't want to make trouble, so send the patient to me. So I'm try to clip in keyhole surgery. This is an eyebrow. I'm going to make craniotomy in here. Could you please move by? Click, please. So, oh, sorry. Okay. First, incision and in eyebrow. Usually I make incision in the direct eyebrow. So you can find out a supraorbital lobe. Sometimes it's located in middle line of the craniotomy, but usually it was medially located, so it doesn't matter during the craniotomy. The craniotomy size was 1.5 to 2 centimeters, and CSF drain provide wide vision. It's the left side ICA. You can see aneurysm in here and small ductal sac in here. Anterior corridor artery come from this proximal part of the here. So dissect and then applying temporary clipping in proximal part of the aneurysm and try to clip in here. You see the cleavage line in here. Then apply Yasagil mini clip in here. There is a anterior corridor artery here. So it looks like very narrow space. So after clipping, I'd like to find out this anterior corridor artery is preserved. So during the operation, I use intraoperative monitoring. So this is a mirror, surgical mirror. Also, I can use the endoscope. Endoscope is very useful. You can see the anterior coronary artery, and then this is ICG. There is a flaw in the anterior coronary artery. Okay, this final step. So it takes 1 hour skin-to-skin operation. So this has some process, minimal invasive, simple preparation. The operation time usually 1 hour to less than 2 hours. So the patient satisfied with this minimal invasive. But there are some difficulties. It needs some learning curve. Okay. So what we can do or what we cannot do with the supraorbital approach. Good candidate is anterior circulation aneurysm of sacroiliac, short distance from the eyebrow, and the aneurysm should be within the surgical view. If the aneurysm located far from the sacroiliac or a long distance or out of the side of the projection, is you should choose another option. So for example, this is a A1, it projected to posteriorly. So the aneurysm projected to the out of the side. So you need some tool like endoscope or mirror to clarify the aneurysm. So in this case, another option to like terional approach is recommended. This is a MCA aneurysm in here. You see, the distance is short from the terion. So it's good to terion rather than supraorbital approach. So I clipped a ruptured aneurysm with a supraorbital keyhole, and also in ruptured cases, this is our hospital algorithm for the ruptured aneurysm. So I selected good grade patient as a candidate of keyhole, supraorbital or mini terion. Poor grade patient need craniectomy and clipping, sometimes coiling followed by craniectomy. I reviewed the retrospect medical record during 9 years. I performed 444 keyhole and 1.7 mini terional and decompressive craniectomy. Transciliary selection criteria is good grade patient. Sometimes I select poor grade with minimal brain swelling or hydrocephalus. This is 7-7. Outcome scale was, gross coma scale was 8. It's poor grade. CT shows ventriculomegaly due to the hydrocephalus, and there is a ruptured MCA small aneurysm. In this case, I performed keyhole surgery. This is 75, poor grade. You see small ACOM aneurysm, but there is brain swelling is very minimal. So I performed keyhole surgery in this case. So this is all demography of the aneurysm clipping. Transciliary is like, so you see all the selected group in ruptured is good grade. Only the craniectomy patient are poor grade because this is poor due to this brain swelling. The patient need a craniectomy. According to WFS grade, you see all the keyhole, supraorbital keyhole, terional keyhole are good grade. Craniectomy patient poor grade. According to size, the mean size was 5.5 and terional is 7. In unruptured cases, transciliary was 4.4 and terional is 6.6. It means I selected small aneurysm as a good candidate for transciliary approach. This is a total of the aneurysm size. And the aneurysm location in ACOM, I prefer the ACOM as a transciliary approach. In MCA aneurysm, sometimes do transciliary or sometimes do terional. And unruptured case is also same. So in ruptured aneurysm, the main important thing is only brain relaxation. So I perform ventricular puncture or laminatory is open. So as Kaufman recommended in the previously, so this is my patient. The angle of the ventricular puncture is 30 degrees. So I estimate the ventricular location with brain CT and then positioning the patient head rotation to 30 degrees like this. So let me show the ventricular puncture. This is right side keyhole. Could you? So when I open the dura, the brain looks swollen. Okay. So ventricular tap need introduced. It punctured about 5 centimeters of the surface. Then drain and aspiration of CSF amount is 50 to 60. It provide after the aspiration of the CSF, the brain select down and it provide very wide view, relaxed brain. And click, please. This is after the puncture. You can see this is a supraorbital approach in the left side optic nerve, right optic nerve, and step-by-step dissection. This is a ICA in A1. So this is ruptured cases. So it's then open the lamina terminalis. It's additional CSF drain. Also, it's like a conventional craniotomy. If you need, you can drill this ACP. This is a broad neck PCOM aneurysm. So pre-op CT shows the neck is compromised to the ACP. Okay. This is a moving file in the left side. You can see the ICA in the aneurysm. And here, actually, ACP is in here. So I could not see the proximal part of the aneurysm in here. See, it's the optic nerve. The broad neck is aneurysm. Neck portion may be in here. So it's hard to clip without any additional removal of the ACP. So it's almost the same in conventional craniotomy, intradural ACP removal with high-speed drill. And then you can see the whole neck portion of the aneurysm. Actually, it's a PCOM aneurysm, and near this is anterior choroidal artery. During the manipulation, in intraoperative unexpected rupture happen. So I keep the suction in here, then immediately apply straight clip like this. But it is not complete. So I introduce the neuroendoscope here. So you can see the remnant neck. This is initial straight clip. This is a part of the aneurysm. You can see this is suction. I retract the ICA with the suction device and see the remnant neck in here. This is anterior choroidal artery. So additionally, I use the fenestration clip like this one and clipped. So this is fine post-op CT, angiography, and DSA. Also, you can drill the sphenoid wing like a conventional craniotomy. This is MCA aneurysm. The MCA aneurysm cannot see it due to the sphenoid reach because, okay, I'm going to skip this video. Okay, so This is a 77 ruptured aneurysm in MCA in the right side. The aneurysm located behind the sphenoid ridge. So without the removal of a sphenoid ridge, it is hard to clip. This is pre-op simulation, and post-op, I remove the sphenoid ridge and clipped with this approach. This is 30 years female in the ICA aneurysm here. You saw this infundibulum opicum, and she had the anterior choroidal artery aneurysm here. So, clip please. So left anterior choroidal artery aneurysm. See, this is ICA here, is aneurysm here, the distal ICA. So anterior choroidal artery located medial part of the aneurysm. So so I applied the endoscope for clarifying which way. This is the neck of the aneurysm. This is aneurysm here. This is anterior choroidal artery here. So the anterior choroidal artery came from just neck, and then so I retract the anterior choroidal artery with the forceps medially, then apply this lateral bending clip. So anterior choroidal artery run from like this direction. So I apply the clip in parallel direction. Then check. It looks like the anterior choroidal artery compromised due to the clip. So I introduced the microscope endoscope in here, carotid optic triangle, and then you see the anterior choroidal artery is preserved. This is a aneurysm, distal part of the aneurysm clip, and anterior choroidal artery is preserved. So during the operation, I did intraoperative monitoring like MEP. There was no change, so cured. This is ACOM 52 female, and you see the superior directed small ACOM aneurysm like this. So pre-op simulation with the CT, and I'm going to skip this also. You see this is a high located ACOM aneurysm. So this is olfactory nerve, and some part of the brain is gyrus rectus is removed, and then this removal of gyrus rectus provide a wide view of the aneurysm. So I clipped like this. Okay, this is post-op. It's craniotomy in here, clipped, and brain MRI shows no damage in the brain area. So during almost 400 cases, there was no epidural or subdural hemorrhage which need wound revision. Sometimes there happens small amount of epidural, but it's good without a medical therapy. And there is a little dysaesthesia, and the main problem is this is originally subfrontal approach. It needs retraction of frontal lobe. So in early series of my cases, I suffered an olfactory dysfunction. But nowadays, I use sub-olfactory approach and preserve olfactory nerve. So the instance of olfactory dysfunction is very rare. So this is my outcome. All of these patients shows good grade. Is transciliary teriana. And in transciliary approach in ruptured cases, including MRS2 was 91% recovered. 6 patients died due to another complication like age or a cardiac problem. So this good outcome may come from the I selected good grade patient. Anyway, the surgical technique doesn't any adverse effect to the patient. And you see, according to the size, location, ACOM is favorable for this transciliary approach. And in unnotched cases, it's good to also no mortality. So with this transciliary keyhole approach, we can treat small size circle of Willis aneurysm. And unruptured aneurysm is good, and sometimes poor grade ruptured we can apply. And giant thrombosed aneurysm, in this case, I try conventional craniotomy because sometimes we need bypass or other technique. Okay. So in conclusion, transciliary clipping for ruptured small aneurysm provide favorable outcome in good grade patient. So minimal invasive approach is feasible in selected case of good grade and small aneurysm. So this is a basically subfrontal approach. So as you try as a beginner, you be careful to injury to the olfactory nerve, but it can preserve it anyway. Thank you.
Thank you for the nice presentation. Hi. Hi.
Yes?
Can I ask you a question? I'm an interventionist. If you have an intraoperative...
Вы нас можете уже вывести в зал? Картинку в зал.
Hi, can I ask you a question?
Yeah, sure.
Yeah, I'm just wondering, if you have an intraoperative rupture with a mini craniotomy, what would you do?
Yeah. I asked so many times about the intraoperative rupture. It is almost the same in conventional craniotomy because usually I already prepare the proximal control, just retraction frontal lobe, and I look around and ICA. So during these 4 ruptured in 200 cases, I only suffered from 5 intraoperative rupture. All of them are controlled. It's not different from the conventional craniotomy. And also, I selected good grade patient. The risk of, the instance of unruptured, unexpected bleeding, for example, before the opening the dura, is very rare in good grade. It's high in poor grade patient. I sometimes experience in the craniectomy patient, unexpected bleeding happen. But in my 3Gs, good grade, the instance is very low. So I don't worry about the unexpected bleeding.
So what you're saying is it's not complicated in controlling it compared to your normal approach?
Sure. It's different from the endovascular. We said, look around in unruptured situation. There are several emergency management strategies to unexpected situation. So anyway, in the operation field, I can treat and manage the aneurysm.
And can I ask you one more question?
Okay.
How do you decide between your TDN or your mini craniotomy approach versus endovascular? How do you choose?
Yeah, we have 5 vascular neurosurgeons in my hospital. I am doing open surgery, and the other 3 guys do the endovascular. So before surgery, we discuss the main as I told you, the CT angiography shows which way is good, and we discuss about the CT angiography and sometimes DSA, and decide which way is good for the patient. Usually, the younger patient do the clipping, and the older patient do the coiling.
Okay, thank you very much for
you.
questions.
Asılbek.
Now I think we have to pass to our live case. Слышно, да, Мужикунас?
Я попрошу там сделать коррекцию.
I would like to ask some correction. Yes, we hear and we see. He asks not to translate, not to show the surgeries, the theater.
Okay, now we're passing to the presentation, which is by Dr. Michel Piatin from France. Следующая презентация посвящена лечению аневризм, также доктором Мишелем Пиатином из Франции.
Good morning, everybody. So I thank you for this invitation. This is my first time in Kazakhstan. So I have measured what will be the subject of my presentation, because aneurysm treatment by endovascular means is a very broad spectrum of cases. So finally, I decided to select one of our favorite topics is the treatment of complex bifurcation aneurysm using the combination of two stents to reconstruct a bifurcation. Okay. I have to wait.
Next.
Okay. So, as you probably know, stents and microstents are used for many years now in the neuroendovascular field, and specifically to reconstruct broad neck aneurysm. But you know, sometimes bifurcation aneurysm are not always treatable only with one stent. You can use one stent in combination with balloon, or sometimes two stents. So in a retrospective manner, we wanted to assess what was the rate of success and also our complication using the combination of two stents to reconstruct bifurcation aneurysm. We selected specific cases with unfavorable anatomy, with large neck and unfavorable dome-to-neck ratio. So this is a retrospective analysis of our prospectively gathered database. We started the database in January 2002, but we focus specifically on this case from June 2006 to September 2016, so this is a 10 years experience. It's a monocentric study. It's intent to treat analysis. So usually when we do target to do reconstruction of a bifurcation with two stents, we try to target the first branch of the bifurcation, which is the most difficult to catheterize, the most angulated. And then after, when we have deposited already one stent, we do cross the first stent with a microcatheter to target the second branch and to deposit a second stent. And then after, we do catheterize the two stents with the microcatheter to put the distal part of the microcatheter inside the sac to coil. This is the way we use. We do prefer now with experience to use two open cell design. I will show you later on. So we target the first branch, which is the most angulated, and then after put the first stent, and then after cross with the microcatheter, the same microcatheter, we cross the strut of the first stent to deposit the second stent in a Y fashion or X fashion, and then after allowing the deposition of the coil. So really to understand, it is important to make the differentiation in two types of stents, two micro stents which are available on the market. You have the open cell design, where you have different crowns of strut which are connected each to other to the next one by 2 or 3 connectors, or you have the so-called closed cell stent. They can be laser cut closed cell stent, but there can also be braided stent, like the Baby Leo, for example. So there is advantage and drawbacks for the two types of stent, but it's very important to distinguish the two types. You know, the closed cell are usually less conformable. There is less wall apposition with a closed cell stent, but it increases the coverage of the vessel. There is more metal, and you can get the fluid vector effect, like Dr. Maimon told you before. The main advantage also of the closed cell stents that you can recapture them. You can partially deploy the stent, and if you're not satisfied, you can recapture. Which is not the case with the open cell. Open cell, once the first crown of the stent have been deployed, it is impossible to recapture. It's only one shot. That's the main drawback of the open cell design. But conversely to closed cell design, the wall apposition is better. There is a wonderful paper which has been published some years ago already by Götz Bendorf that was studying the advantage and pitfalls of both type of stent, showing that the main advantage of the closed cell is a vessel, the main advantage of the open cell is the vessel conformability, the conformability to the stent to apply along the wall of the vessel. But the main drawback is to have what they call the fish scaling effect at the level of the neck. Conversely, for the closed cell design, like at this time it was the Enterprise, it was the reference, they have a propensity, this closed cell design stent, to kink quite rapidly in a curve. So he tried later on with in a different paper to study what is the best combination of stent to be used in a bifurcation to have the better wall apposition. So he tried different combinations, 4 combinations, open cell versus open cell, 2 stents which are open, or closed cell and open cell and closed cell stent, versus closed cell and closed cell. And what appears to be the best, and we do confirm in our clinical settings that the best way when you want to do Y or X stenting with 2 stents to reconstruct a bifurcation is to use 2 stents that are open design, because it will be easier to cross the stent, and also one of the stents can disrupt and leave the second stent to pass through, which is not the case with the closed cell design. So, as I mentioned previously, we review our series, what we have been doing with bifurcation and Y stenting and X stenting during the last 10 years. So all the procedures have been conducted under general anesthesia, like all the cases we are doing for aneurysm treatment, we do conduct them under general anesthesia. The patients are under full anticoagulation with heparin, but also they have all dual antiplatelet therapy treated. The vast majority of them are elective cases, and we do start the dual antiplatelet treatment with clopidogrel and aspirin. We start few days, even 2 weeks before the treatment. The patient is reassessed with a Verifino system, a bedside system, is reassessed 1 week before, and if the patient is not responding well to the anti-aggregation, we increase the dose of clopidogrel, or sometimes we switch from clopidogrel to ticagrelor, because the aim is to have the best antiplatelet therapy, which has to be assessed by Verifino system. Then after, we keep on dual antiplatelet therapy with clopidogrel and aspirin for 3 months. After 3 months, we discontinue clopidogrel and we keep on at least 3 months for more aspirin. Overall, 6 months of antiplatelet therapy. So we classify the result in between complete occlusion, neck remnant, and residual sac using the Roy-Raymond classification. And we have follow-up from 6 to 42 months after the procedure in nearly all patients, 3/4 of the patient. We dichotomize the complication in between permanent or reversible. Permanent being less than 7 days, reversible, no, permanent complications are keeping on after 1 week, and reversible that disappear after 7 days, or even transient when the patient has a deficit less than 1 day. The majority of patients were women. It is reflect exactly the distribution of aneurysm among the French population, who have more women than men with aneurysm. The majority of this aneurysm which has been treated are fortuitous discovery, 82%. We have also treated recurrence, is nearly 11% of the cases with a 2-stent. And we have very few cases of cases which has been conducted after a subarachnoid hemorrhage. We don't like generally to put stent in the acute setting. We try to avoid that. But some of them were in the rupture aneurysm, treated within 2 or 4 weeks after the treatment. Only 2 cases have been treated very acutely. So majority of them been incidental. This is the distribution of the location. Majority of them are MCA bifurcation. We have only 1 ICA termination, but quite interestingly, we are nearly 50 cases of anterior communicating artery aneurysm. The vast majority of the procedure have been conducted with Y technique instead of X technique. X is really reserved to ECOM aneurysm when you have the 2 anterior cerebral arteries which are patent in the A1 segment. Stent combination, this is the main subject. We try at the beginning to do different combinations, but the better we get along with time, we choose to use open and open cells design stent. To use first an open cell and then a second one. Because we have some drawbacks with closed cell design, specifically when you have to cross the strut, and also specifically in a very acutely angulated curve. As you can see, this is a repartition also regarding the complication we have, but there is no major difference in terms of statistics. There is probably less complication with open and open cell versus close, open to close or close to close, but this is doesn't reach statistical significance. Where to deplore complication in this tricky aneurysm? We have a rate of permanent complication reaching 13%, and 6% being transient or reversible complication. This is the summation of all the complications we got. As you can see, we have 3 cases of intraparenchymal hematoma. It's totally directly linked to the use of dual antiplatelet therapy. We have delayed intraparenchymal hematoma in 2 patients remotely after 2 or 3 weeks after the patient was discharged. We have also 4 cases of permanent complication due to arterial perforation, which is probably, as Dr. Memon referred previously, that the worst complication you can get when the patient is under aspirin, clopidogrel, and heparin. We have overall 30 permanent neurological complications. The vast majority of them being peri-procedural, during the procedure or 1 or 2 days later. But as I told you, we have 4 delayed complications. At 6 months, 1 when the patient discontinued aspirin, and 2 at 3 weeks with intraparenchymal hematoma or thromboembolic due to the patient who discontinued the treatment. As you can see, this is the distribution of modified ranking scale at discharge. As you can see, we have 8% of severe complication, with the patient being more than MRS2, modified ranking scale of 2. So the vast majority of the patient being totally independent at discharge, but 8% of them were not dependent, and we have to deplore to death. This is an illustrative case of a 60-year-old female with an incidental finding of an ECOM aneurysm, and the justification of the treatment was because of the size of the sac, but also because she had high blood pressure and dyslipidemia. And she has a very irregular aneurysm, bilobulated. We decided to treat. You can see there is 2 nearly independent balls, but this is the same aneurysm, with a wide neck, nearly 6 millimeters of span. So we decided to target the 2 anterior cerebral arteries, the A2 segment. This is the working projection, as you can see here. It's very important to select the good projection. We use biplane angiography, so we can see in both planes the navigation and also the deployment of the stents. So we targeted first the right side. We have to loop inside the aneurysm with the microcatheter, and then after we deploy the first stent into the right A2 segment and right A1, and then after, once you have placed the first stent, passing through with an echelon 10 through the first stent, through the strut, and deployed a second stent. You can see the plain radiograph with the 2 stents which has been deployed, one in the right, one in the left A2 segment, and both proximal part of the 2 stents in the right A1 segment. We do like to do what we call X-per-CT or Dynacity with Siemens, depending on the brand you're using, plain CT, Conbin CT, to have a good view of the deployment of the strut, to be sure that we have a harmonious deployment of the 2 stents. As you can see, this is the drawback of the open cell of the open cell stent. There is what we call the fish scaling effect within the neck, but it's not too much a problem. As you can see, the position along the wall is very good here, with a nice neck reconstruction. Then after, we pass through the 2 stents with a microcatheter, with the same echelon, and we do coil the aneurysm. This is the final control angiogram with a good exclusion of the aneurysm and good patency of the parent vessel and the side branches. This is the 12-month follow-up. As you can see, there is a good stability. Despite the fact that the aneurysm is big, we have a large neck, 6 millimeters. We do experience, and this is confirmed in the vast literature now, that when you put stents, you increase the rate of long-term thrombosis of the sac, and you have far less recurrence. This is due to the fact that the stent may have some flow diverting effect. That's also due to the fact that stents promote the endothelization of the neck, because the stent creates a scaffold along the neck for the endothelial cell to colonize and to close the neck. And maybe there is also some other effect due to the fact that when you put stent, even only one stent, sometimes in a bifurcation, you modify the angulation of the branches. And the fact you modify the angulation, you modify the anatomy, change the forces, the wall shear stress forces within the sac, within the area of the neck, and promote long-term thrombosis. This is 12 months follow-up. Another case, this time MC aneurysm in a relatively young woman, 59-year-old woman. 59 is a young woman now in France. She's an incidental finding. You see that the neck is nearly 5 millimeters. We decided to choose this view. We take a lot of time with the 3D to choose the best working projection. We try to have two orthogonal views. We target again one of the branches, the most difficult. We stent first the first branch, which is the superior branch of the bifurcation, and then after we target the second branch to be able to create an artificial neck that allows us to safely coil the aneurysm. It's not necessary to do dense packing, as Dr. Memon said before, and also because dense packing may be dangerous when you have stent in place, because there is less possibility for the microcatheter to navigate within the sac. So don't push too much your luck and try to stay inside the sac of the aneurysm. This is the final control, epine lateral, and I think we have 1 year follow-up with a good anatomic exclusion of the aneurysm, persisting without any kind of recurrence. Another case of an ACOM aneurysm, which is very tricky because the neck is really large. The neck is 10 millimeters, and we have here the chance to have a relatively symmetric bifurcation. I think there is 2A1. So the plan now is to cross the neck with two stents and using two femoral approaches, one from the right and one from the left. Deposit first, this is a working projection, submental view here. You can see the neck is very large. So the idea is to go from the left first, from the left A1 to the right A2, put the first stent, and then after, this is the plain view after the deposition of the first stent. Then after going from the contralateral side, from the right A1 to the left A2, cross the strut of the stent and deposit a second stent in a X fashion. Then after, now you have an artificial neck that allows you to depose the coils inside the sac, not doing too much dense packing, but sufficiently dense to have a good exclusion. The result is not perfect. As you can see, we have still some remnant of the sac, as Jean Remo will call that dog ear remnant. But we have a long-term follow-up. It is very impressive to see the change of hemodynamics over time, because when you do inject the right carotid, you mainly feel the left, the contralateral anterior cerebral artery, and when you inject the left carotid, you mainly inject the right anterior cerebral artery, but both the neck and the sac are totally excluded from circulation. We have another case of MC aneurysm. You see here that the problem is the fact that we have a very strong, very steep angulation of the branching from the sac, and so the navigation is going to be difficult. Anyway, we succeeded to put two stents. We targeted the superior branch first, and then after we targeted the second branch. We were able to put two stents, and it is impressive to see the adaptation of the open cell design stent to the anatomy. You see that the bend is very, very acute, it's very steep, and despite the fact the stent is able to deploy without kinking, but we have some drawbacks, is what we call the fish scaling effect at the level of the neck, which was not too much a problem for the further treatment of the patient. You can see that with a closed cell, open cell design, that the stent is totally dismantled at the level of the bifurcation, but the parent vessels are covered and are protected for embolization. Then after, you are able to place your microcatheter, the echelon 10, for example, and deliver the coils, do a nice basket, a nice framing coil, and try to stay inside the sac. As you can see, the packing is not that dense, but sufficient enough to have a good circulatory exclusion with, at nearly 3 years, a good persisting total circulatory exclusion. We have some here, maybe on the 3D, we have maybe some small recurrence at the level of the neck, but I think this is very good, and the patient doesn't need to be retreated. A very tricky cases we did at the early beginning of our experience with extending. At this time, we didn't have open cell design stent. We used 2 closed cell enterprise stent to try to get rid of this very tricky aneurysm. In fact, there is 2 or 3 different sacs from the same pathology. We use O21 catheter at this time. We were able to reconstruct an artificial neck with 2 stents. In fact, this is a trifurcation. We were able to put the 2 stents, to cross them, to have an artificial neck, allowing us to coil separately in the same procedure the 2 sacs to obtain that. At the end of the treatment, the result is not perfect because there is some filling still inside the sac, but we were not able to do denser packing. But it's interesting to see that as we had a follow-up aneurysm is totally excluded. We have these very strange cases also. It's a patient from the South Pacific, French South Pacific, who was discovered with a partially thrombosed giant aneurysm. This is the MRI. As you can see, the vast majority of the sac is thrombosed, but we have a persisting opacification of a remnant inside the sac. We do know that if we don't put a stent, if we do coil only in this partially thrombosed aneurysm, we will have a recurrence because the coil will migrate progressively over a few weeks or few months within the thrombus. So we decided to go for a bifurcation reconstruction with two stents that we did. We had an early follow-up at 3 months. The patient is totally intact, but the patient, we were lucky, and she was even more lucky than us. The patient did thrombose the middle cerebral artery, but without any kind of symptoms, because probably the thrombose occurred progressively. And we have a good collateral flow coming from the leptomeningeal supply from the anterior cerebral artery to compensate the occlusion of the middle cerebral artery. This is at the time of the follow-up angiogram. As you can see, there is no infarct into the MCA territory. Also, this kind of reconstruction, this kind of treatment with 2 stents, are able to provide a neck when there is barely no neck. This is a case of a basilar tip, a relatively shallow aneurysm, but the sac is still 10 millimeter with a neck of 9.5 millimeter. This is an incidental discovery, and we decided to go for reconstruction, and we use an open cell design, a neuroform, and a closed cell design for this patient. It was more than 10 years ago. So we targeted the most difficult branch, which was the left P1, P2, and we were able to deploy neuroform. Then after, we used the O21 catheter, a smaller catheter, to cross the strut of the neuroform, and we were able to put a neuroform on the left side and enterprise on the right side. But it's going to be very interesting to see the XPER-CT stent, because, you know, this is the illustration of what I said before. We have the drawbacks of the 2 technologies, you know. open cell on the left side, we have the fish scaling effect, some distribution of 1 or 2 strands going into the neck. And on the contralateral side, on the right side, you have a closed cell design. And despite the fact that the curve is not that tight, the angulation is not that big, we have already a kinking. So you see the drawbacks of the two technologies are in the same patient. But anyway, we're able to reconstruct a neck, and we add this final control, which is not perfect. We still have some feeling on the lateral aspect of the sac with dog ear remnant. But we have a 4 months follow-up, and as you can see, there is drastic modification of the hemodynamics with a further thrombosis of the so-called dog ear and with total aneurysm exclusion on a short term. Also an example of a bad combination, open and closed cell. That's why I really pledge for open and open cell design stent when they have to be used in conjunction to reconstruct the artery. This is a very good illustrative case. This is a case of a 69-year-old woman, which is a heavy smoker, had dyslipidemia. She was discovered having MCA aneurysm on the left side. She has some plaques at the level of the carotid bulb. It's not too much a problem. She's a diagnostic DSA. And we decided to go for treatment because due to the risk factor and also because she has a small bleb. So the aneurysm is 7 millimeter and she has a bleb. But the neck is relatively wide. We have nearly 5 millimeter of neck. We decided to go for bifurcation reconstruction. And we use two stents. We use first a neuroform in the superior branch, and then after, because we are unable to catheterize at this time, we use a O27 catheter for the neuroform, not anymore. We are unable to catheterize the inferior branch here. So we use Elvis, which is a closed cell design. And I think it was probably an error, but anyway, we are in this situation now that where you look and you scrutinize the construction, you have a good deployment of the neuroform, but the bad opening of the Elvis, which is the closed cell design. Anyway, we were able to coil the aneurysm without problem, and we obtained this result at the end of the procedure. But interestingly is to see what happened at 6 months, and also at 2 years we have the same problem. The stent is not yet open because sometimes you can pray and have a secondary opening, but it didn't happen. And also when the patient, we stop the aspirin, the patient is making tea. She has some tickling into the contralateral arm on the right arm, and we have to keep on with antiplatelet therapy, long life for this patient, probably because we have probably some effect, hemodynamic effect or small thrombus effect in keeping with the bad opening of this second stent. So look closely at the angioarchitecture and also at the hemodynamics you can change when you put stent. We have the 1 year follow-up with the same problem. The aneurysm is totally excluded, but the stent is not open. We have another case of MCA aneurysm with two open cell design. This is the XPER-CT view. You can see we have a good opening, partial exclusion of the aneurysm, but at follow-up, at 53 months follow-up for this patient, we have a total and exclusion of the aneurysm. So what to say to sum up this presentation about why stenting and extenting? We have far more complication when you use stents than regular coiling or even balloon remodeling. We do not have in our series more complication in wide stenting versus single stenting. That means once you have taken the risk of putting the patient under dual antiplatelet therapy, the risk is here with increasing risk of bleeding, and specifically intracranial bleeding. The best combination, which appear into in vitro and also when in vivo when we do image our reconstruction, is to use, if possible, the conjunction of it's an error, best reconstruction, not closed cell, but open cell, instead of closed cell. it's very important to use open cell stent whenever you use two stents in combination. The problem, complete occlusion is delayed. You have less total complete occlusion with stents, and specifically two stents immediately after the procedure, but you promote long-term thrombosis. Roughly 45% of this aneurysm will complete thrombosis over time, within 3 to 6 months. That means 45% of the aneurysm which have been treated will progress and we have total occlusion. Roughly, we have a rate of 78 total occlusion at long-term follow-up versus at least 10%, 15% less when the patients are not treated with stents. Thank you.
Thank you very much, Dr. Piatin. So maybe someone can have some comments?
Michel, you know, the complication rate from the Y stenting is...
8.
Sorry?
8%.
Did you say 13%?
No, 13% overall complication with, with even the transient. But if you put a severe complication, it's 8%.
Okay.
We previously published for one stent reconstruction, and we have the same rate. Roughly, when you use a stent, whatever it is, a combination, only one stent or two stents, you double the rate of complication regarding simple coiling or balloon remodeling.
Absolutely, and that's a really nice presentation. But if you give that number to the surgeons, a complication rate from, if you ask the surgeon for an aneurysm, some of those aneurysms that you showed would probably be about 5-6%, probably a lot less than that. So do you think some of these aneurysms should get really clipped rather than Y stented or extended?
Yes, for the MCA bifurcation, certainly there is discussion. I'm for ACOM aneurysm, I'm not that sure, at least in France.
Agree. And you know, the ACOM that you showed, and there was one of the MCAs, we got now webs, we got lunar, contour. Do you think some of these devices probably are better rather than, or more easier than stenting?
I'm not sure in my hand it's easier, and I'm still looking forward for the long-term rate of occlusion.
But with the
But they are promising, you're right. You're right.
Okay, actually a comment. So I'm getting confused here a little. Now we're comparing an established surgery to Y stenting and saying it is better, and then we're moving forward and comparing unestablished endovascular techniques to an established technique. So I think that is there is some discrepancy here. So we should either go, okay, we're more on the surgical side, perhaps for some centers who have good surgeons, or be on the more experimental side. And I would think web and similar devices, it is kind of early to talk about long-term efficacy or complication rates.
Thank you very much for your comments.
I would like to ask you, I have seen that people are doing X stenting and Y stenting with double Elvis. I don't have any experience with this. Do you know something about what, because it's looked to be too close cell. What is going on there?
We also did that, but with expand, it seems we have more complication, and also, you know, for the problem is wall apposition. You have less wall apposition when you do X or Y stenting with closed cell like that, for sure. And the problem when you have less wall apposition, there is another paper done by Pascal Jabour and colleagues in the US showing that there is a correlation in between the poor rate of wall apposition with the downstream ischemic events, because that means that there is clot forming in between the arterial wall and the strut of the stent. So there is a big correlation.
Thank you very much. We're a little bit late for our schedule. Now we have to start the live case. Some from the OR.
Нас слышно в зале? Ага. Я буду говорить на русском, потому что...
I'm going to speak Russian because the major part of the audience are Russian speakers. A patient has suffered it's very, I don't know, hemorrhage in 0-15, and in acute period we have identified 2 aneurysms. Well, the left internal carotid artery. Both the aneurysms were embolized with the use of the balloons, balloon-assisted coiling.
Significant recanalization in left IC aneurysm. В течение 6 месяцев мы увидели
and the aneurysm of the right carotid artery was with the residual neck. After the additional embolization with these spirals, Dr. Maimon assisted us with the installment of the left stent into the left carotid artery. And the follow-up of the angiography in the space of 8 months showed stable occlusion of aneurysm of the left internal carotid artery, and the growth of aneurysm in the left internal carotid artery. Given the availability of the hemorrhage in the history and the growth of the aneurysm of the right carotid artery, we suggested the patient the following treatment plan. Stenting the right carotid artery, and embolization of the aneurysm using the spirals or coils. Currently we use microcatheter Vasco 21, is an M1 segment. To navigate, we used a Traxis microcatheter, Traxis porting microcatheter. Inside the aneurysm, there is the echelon catheter with microconductor Chekai 14.
Open the stent.
We plan to use gelling technology. As our colleagues from Neuroaddict Forum know, we have our own technology. How to identify the resistance of a patient to Plavix. And we name this technology as Kazakh thrombotest. I would like to ask Dr. Nyman the position of a stent in the middle part. Is it okay, or shall we pull it? Shall we pull it? So that was the question.
Part of the stent is okay, or I think it's a little bit distal. Okay. My man is here. Hello. We start to open Leo Plus. Yes. Leo Plus. It's a little bit below than I say bifurcation. Okay. Вот ротор слушай. В прямой проекции мы увидим, что стенд открылся дистальнее, чем мы хотели.
Direct visualization shows that it is opened a little bit more distal than we wanted. That's why we will bring down the state 5 millimeters lower. We will pull the stent. Nicholas, what do you think? This position, this stent position, is it okay?
Jump into the aneurysm, and we will replace the microcatheter. Okay. Echelon. Okay, we will do shipping with echelon.
Пока ту камеру вывести на... Да вот он просто сейчас число скажет, и я сразу же включу. Вот.
Understand? Нас слышно?
Can you hear us?
Да, okay. Хорошо. The stent is coming. Нормально. Окей. Стенд раскрыт где-то процентов на 70.
The stent is opened probably 70%.
И мы ставим таймер.
Now we are setting a timer. The timer will be for 15 minutes. If there are any problems with drug resistancy, the thrombosis will start in 7 minutes.
Торсовой нормально? Торс нормально? Мы установили первую спираль, я думаю, положение.
So we have set the first coil. I believe that the location is right, adequate. Four minutes have passed since the stand was open.
After 2 minutes, yes. Dr. Ryan asked me why I deployed the stand completely. It's our strategy. As a thrombotest, we need to wait 2 minutes more. And after that, we will deploy the stand completely. Преимущество того, что
The advantage of partial deployment of a stand is that if there are any problems with coagulation, the stand could be removed at any time. With a full deployment of stand, it could be problematic to remove the stand. So that's why we prefer to make sure that there is no thrombosis in the stand. The same principle is used when we embolize aneurysma using FD, flow divergent. And it's not because we don't have tests to define the resistance to Plavix, but because we do not trust them. So 6.5 minutes have passed since we have installed the stand. I believe we need to give a push to the echelon so that it won't go to the first coil. After 7 minutes we do control angiography. Stent is fully it's okay, fully penetratable. We can now separate the first coil. It's easily detached. Next coil is axial 2x6, because as of now, from the coils which we use, it's microvention microplex, Codman orbit, but the adequate size had only axiom. So that's why we have decided EV3 axiom coil. Tachycardia is not of the patient, but it's of the operating team, and I believe that our colleagues they are familiar with this feeling. Of a heartbeat. I believe this is the last coil, although my colleague Nurjan recommends to review an opportunity to install a third coil, but we know that Leo stent can change the flow, blood flow, and Dr. Maimon agrees with us. 9.5 minutes have passed, everything is okay with the stent, and I believe that we can separate it now. We can detach it. So we have now separated the stent. Now we remove microcatheter. We will now remove microcatheter and echelon so that it won't be in the way.
Yes, massage? Oh, okay, that's enough. Okay. Мы убрали проводник.
We have removed the conductor. Now we will do a picture with less zooming. Nicholas, what is your opinion? I believe that now it's the time for the coffee break. Thank you for your attention.
Okay.
Раз, 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 раз. Раз, раз. Раз, 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 раз. Не слышно, не слышно. Раз, раз, раз. Раз.
Раз, раз. Раз, раз. Раз, два, три, раз, два, три, раз, два, три, раз, два, три. Раз, два, три, раз, два, три, раз, два, три. Раз, 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 два, три, раз, два, три. Раз, два, три, раз, два, три. Раз, раз, раз. Раз, 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 два, три. Раз, два, три, раз, раз, раз. Раз, два, три. Раз, раз, два, три. Говорю? Я говорю. Раз, два, три, раз, раз, два, три. Раз, два, три, раз, два, три. Раз, два, три, раз, два, три, раз, раз, раз. Раз, два, три, раз, 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 раз. Раз, раз. Раз, два, три, раз. Раз, два, три, раз, два, три, раз. Раз, два, три, раз, 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 раз. Раз, два, три. Раз, два, три, раз, два, три, раз, 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 два, три, раз, два, три, раз, 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 раз. Раз, два, три, раз, 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 два, три, раз, два, три, раз, два, три. Три, два, раз, три, два, раз. Раз, два, три, раз, два, три. Раз, 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 два, раз, два, раз, два, раз, два. Раз, два, три, раз, два, три. Во, раз, два, три, раз, два, три. Еще. Раз, два, раз, два, раз, два, раз, два, раз, два. Еще раз, два, раз, два, раз, два, раз, два, раз, два. Один, один, два, один, два, один, два, один, два. Один, два, три, один, два, три. Во, вот так. Один, два, три. Раз, два, раз, два. Раз, два, три, раз, два, три. Раз, раз, раз. Раз, два, три, раз, два, три, раз. Раз, два, три, раз, раз, раз. Раз, два, раз, два. Один, два. Ау. Раз, два, три, раз, 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 раз. Раз, два, три, раз, 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 два, три, раз, два, три, раз, раз, раз. Раз, два, три, раз, два, три. Раз, 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 раз. Один, один, два, один, два. Один, два, один, два, один, два, один, два. Один, два, один, два, один, два. Один, два, два, один, 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 один. Один, два, один, два, один, два. Раз, два, три, раз, 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 раз. Раз, два, три, раз, 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 раз. Раз, два, три, раз, раз. Раз, два, три. Раз, два, три, раз, раз, два, три, раз, 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 два, три, раз, раз, два, три. Раз, два, раз, два, раз, два. Один, два, три, один, два, три. Один, один, два, два, один, два, один, два. Один, два, три, один, два, три, один, два, три, один, два, три. Один, 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 один. Один, 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 два, три, один, два, три. Один, два, три, один, два, три. Раз, два, раз, два, раз, два. О, вообще конкретно. Қатшы. Вот с этого раз, два, три, раз, два, три, раз, два, три. Раз, раз, два, три, раз, два, три, раз, раз, раз. Один, два, один, два. Один, два. Один, два, один, два, один, два. Один, два. Один, два, один, два, один, два. Один, два, три, один, 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 два. Один, два, один, 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 один. Раз, два, три, раз, два, три, раз, раз, раз. Раз, два, три, раз, два, три, раз, раз, раз. Раз, два, три, раз, два, три. Раз, два, три, раз, 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 два, три. Раз, два, три, раз, два, три. Раз, два, три, раз, два, три, раз, два, три. Один, два, три. Три, раз, два, три. Раз, 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 два, три. Раз, два, три, раз, раз, раз. Один, два, один, два, один, два. Раз, два, раз, два, раз, два, раз, два. Один, два, один, два. Раз, два, три, раз, два, три, раз, два, три. Раз, раз, два, два. Один, два, один, два. Один, два, один, два, один, два. Два, два, один, один. Один, один, два, два. Раз, два, раз, два. Нет, нету. Раз, два, три, раз. Если впритык держать, то вот тебе, вот теперь. Раз, два, раз, два. Раз, два, три, раз, два, три, раз, 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 два, три, раз, два, три, раз, два, три, раз, два, три. Нет, погромче надо еще. Раз, два, три. О, вот так, вот, вот, все, все, нормально. Раз, два, три. Вот это нормально, вот. Нету. А вот появился. Раз, два, раз, два, раз. Вот так. Нет, чуть потише. Раз, два, раз, два. Да, вот, нормально. Вот так нормально. Раз, два, три. Раз, два, три. Раз, раз. Раз, два, раз, два, раз, два. Раз, два, три, раз, два, три. Один, два, три, один, два, три, один, два, три. Один, два, три, один, два, три. Чуть-чуть можно, чуть-чуть поднять. Да? Не, нормально. Но если вот так буду держать, надо чуть-чуть поближе. Надо объяснить потом. Раз, два, раз, два, раз, два, три. Раз, два, три, раз, два, три, раз, раз, два, раз, два. Непонятно. Раз, два, раз, раз. Раз, два. Раз, два. Один, один, один. Один, два, один, два. Раз, два. Раз, раз, раз. Это второй. Раз, два, раз. Один, два. Один, один, два. Один, два. Один, два, один, 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 два. Один, два, один, два. Один, 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 два. Раз, 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 раз. Раз, два, три, раз, 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 два, раз, два, раз, раз, раз. Раз, 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 два, раз, 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 раз. Один, два, один, два. Один, два, три. Раз, 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 раз. Второй вот еще. Раз, два, раз, два, раз, два, раз, два. Один, два. Iki udah betul mah? Oh. Да, да, понял, понял. Раз, два, раз. Один, два, один, два, один, два, один, два. Раз, раз. Раз, два, раз, два, раз, два, раз, раз, раз. Один, два, один, два, один, два. Один, два, один, два. Раз, два, раз, 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 раз. Один, один, два. Один, один, два, один, два. Один, один, два, один, два, один, два, один, один, два. Два, один, два, один, 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 два. Раз, 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 два, раз, два, раз, два. Раз, два, раз, два. Раз, два, раз, два, раз, два, раз, два, раз, два. Полма, маки? С трибуны. Раз, два, раз, два, раз, раз, два. Один, два. Один, один, два, один, два, один, два. Раз, два, три. Раз, два. Раз, два, три, раз, два, три, раз, два, три. Раз, два, раз, два, раз, два. Надо чуть-чуть. Раз, два, раз, два, раз, два, раз, 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 два. Раз, два, раз, два, раз, два. Раз, два, три, раз, два, три, раз. Раз, два, три, раз, два, три. Раз, два, три, раз, два, три. Чуть-чуть прибавьте, чуть-чуть. Раз, два, три, раз, два, три. Раз, два, раз, два, раз, два. Один, два, три, один, два, три, один, два, три. Раз, раз, два. Вот, нормально. Один, два, три, один, два, три. Один, один, два, три. Раз, два, раз, два. Раз, раз, два, раз, два, раз, два. Раз, два, раз, два, раз, два, раз, два. Раз, два, раз, два. Раз, два, раз, два. Раз, два, раз, раз, два. Раз, два. Раз, два, раз, два, раз. Один, один, два, один, один, два, один, два, один, два. Раз, два. Раз, два, три, раз, два, три, раз, два, три. Один, два, три. Один, один, два, три. Да, нормально вот так. Я вот тихо говорю, тихо. Раз, два, три, раз. Раз, два, три, раз, раз, два, три, раз, два, три. Раз, раз, два, три. Раз, раз, два, три, раз, раз, раз. Один, два, один, два, один, два. Раз, два, три. Раз, два, три. Раз, два, три, раз, два, три.
Раз, раз, раз. Раз, раз, раз.
Good afternoon and welcome back. Delayed, but before we do that, I think I have to congratulate Manjulki. In the last 10 years, we have seen that what giant steps that he has taken. And congratulations, you are doing very well. And not just for yourself, but the entire neuroaddicts group. I think this is a great example that you have set in. And thank you very much. And this guy is a superman. And he has received everyone on the airports. He hardly sleeps. And he was there till midnight last night and first thing in the morning here. So I have to talk about the basilar complex aneurysms. I call it kaleidoscope. Because that's the way that the complex aneurysms behave. It is difficult to pick one from the other. Once you have seen them all, and I think in 20 years practice, we have seen them all, it's difficult to predict which one of them is going to behave well and which one of them is really going to put you or your patient in trouble. So we start from the top, and from the top we go towards the bottom of the vertebro-basilar system. As you can see over there, all of them are really giant, dissecting, dirty, partially thrombosed, fusiform, troublemaking aneurysms. We start from the top. Now, there's nothing that I want to talk to you about giant P2 aneurysms. We have known for a long time that the collaterals for the PCA exist between the PCA and MCA and between the choroidal system and P2. So when you are faced with a giant aneurysm in a P2 segment, mostly with or without a balloon test occlusion, we would just go ahead and knock the giant aneurysm with coils. We call it inside out, means coils within the aneurysm occluding the P2 segment. And it's a straightforward treatment. It's very, very easy to get in. And once you have done so, then you can see that after the occlusion of the P2 and the aneurysm, the collaterals do come from ACA and from MCA. This is the occlusion of the aneurysm with coils and proximally into the proximal P2. And after you have achieved that, of course it does not fill through the basilar artery, but it does fill through the carotid system. You can see this is an almost complete recanalization of the PCA, almost complete recanalization of the PCA, right till the aneurysm. It's an extremely safe treatment. We have known it for a long time. And even today, if we are faced with a giant P2 aneurysm, we will do exactly the same. So from P2, we move a little backwards, a little inferiorly. We move towards P1. Now, P1 is the same strategy. Only thing is that in P1, we have an advantage that it's on the P1 segment. So we will have a PCOM assisting our collateral circulation. So the strategy is exactly the same. Seldom do they bleed, but most of them will have some thrombus. Some of them do have some edema around it, and patient will have symptoms because of it, because all of it is in close contact with the brainstem. You can see that the contrast swirls around, and after swirling, it goes into the PCA. For a novice or for someone who is beginning his practice of neurointervention, this can be a deterring factor, that how can I occlude something when the distal artery is completely dependent on this aneurysm? The answer to that is that you can occlude it very safely because one, the pile collaterals will take over, and two, this is a P1 segment, so the PCOM is already free. You have to take care not to occlude the segment, the P1, P2 junction, which communicates with the PCOM. And once you do that, you expect exactly the same thing, occlusion of the giant aneurysm. And what's this? This is, of course, the PCOM. We knew it right from the beginning that once you occlude and once you do not compromise on the PCOM, then the PCOM is on P1-2 junction, which is distal to the level of your occlusion, and the P2 and the PCA is filling antegrade. Zero risk in doing this. But when you talk like this, there's zero risk in something and no risk in my hands, you get a patient which is exactly the same. This is the coil mass, giant P1 aneurysm, and you get another P1 aneurysm, which is, if you look at the scan, it's slightly different. It's different because it's partially thrombosed and it's indenting onto the brainstem. We nevertheless treat him the same way. We go inside, we occlude it, and at the end of the treatment, what do we have? At the end of the treatment, we have occlusion of the aneurysm, occlusion of the PCA, the collaterals are good, the guy is young, and there is no problem. So this is how we had finished his treatment. And everything was good. As you can see, the PCA is formed fully. There is no ischemia here. The guy is well. Now, what happened? What happened after 4 months later? This is what makes some of these aneurysms complex. It's not at the time of your treatment. It's not your immediate follow-up of 1 month or 3 months. This happened 4 months later. We knew that there was something neurologically severely going wrong with this guy. And so when we perform the scan, what do we see? Isn't it a surprise? Not now, but during those days it was. That in spite of the occlusion of the aneurysm in the lumen, the aneurysm overall still growing, and there is some significant edema, and maybe the wall hematoma is happening when there is no filling of the aneurysm sac from the circulation. And this is something which can happen. And so I'm just going to show you most of the cases like this. One treated the same way as the other, and one will have very good outcome, and the other unpredictable. Now we know this. Initially, a few years ago, maybe a decade or more so ago, we did not know all this. Now we know that it's actually a disease in the wall, and Pierre Lajonias, our teacher, has taught us that for a long, long time. And some of those aneurysms, in spite of the treatment that you would do, would continue to do this, and some of your patients will have a complication despite a normal-looking angiogram months later. So let's go to the next one. After P1 and P2, let's go to the basilar-top. Basilar-top, I'm going to show you again the same thing. One is a kid, a small kid, with a partially thrombosed giant basilar-top aneurysm. His basic problem is not neurological. His basic problem is because of the hydrocephalus, which is caused by mass effect of this giant aneurysm. And so he would require treatment by us, occluding the aneurysm. And as I said, in sacrificing not just aneurysm, it will recur a few months later. So we sacrificed his aneurysm along with the basilar-top, simply because he was a small kid and he had very, very good collaterals coming in from the pile circulation to both the PCAs. So this is what we did. The aneurysm, the giant aneurysm, you can see that the carotids are already supplying the pile circulation. And so we have knocked off his basilar-top, the entire basilar-top, with the aneurysm intentionally with both P1s. At the end, we have full recanalization of the PCAs. And when you have that, there is again no risk of him deteriorating neurologically. He did require a further procedure, but that was not by us. He required a further procedure because his hydrocephalus worsened and his shunt had to be reversed. But aneurysm or endovascular-wise, that was a good procedure to do. And we have been doing this. Look at this case. Again, we decided if the collaterals are good, we would try and occlude the basilar-top because these aneurysms are giant, partially thrombosed, and they recur. They recur if you do not treat them with sacrifice of the segment and or a stent or a flow diverter. What we did here, because that time it was a ruptured aneurysm, we inflated a balloon not inside either of the P1. We inflated the balloon coming from the basilar-top down into the P1 and into the superior cerebellar artery. So you can see that the balloon is actually coming down into the superior cerebellar artery, covering the neck, and then again the PCOM takes care of the PCAs. The balloon is placed like this from the basilar-top, covering the neck, and the wire is actually into the SCA, superior cerebellar artery, which was coming from the P1. And then, with intention, we sacrificed the basilar-top. Again, feeling very smug about it, that what we had, as Shimon said some time ago in the morning, that you have to have a plan in the beginning. So you have a plan, you execute the plan, and you feel good. You feel good for some time. This patient was well for some time, and 2 years later she had another neurological symptom, for which a scan was done. And what is happening here? It's almost the same thing that we saw a couple of patients earlier. The aneurysm is growing, the coils are haywire, and repeat angiography shows this. It's not completely unexpected. Some of these aneurysms do that. And so when she came again for treatment, this time we put more coils, and this time we actually went ahead treating that recurrence at the neck by bridging the PCA to the basilar using a flow diverter. Usage of flow diverter in posterior circulation is getting lesser, especially on the top of the artery, but sometimes you do not have a choice, then it will give you a good result on a long term. This is what we did, more coils inside and a flow diverter coming in from the PCA into the basilar. You may use that, or you may use a Leo Plus, but whatever, the stent should have a flow diverting effect. This is the follow-up, and she also required a shunt because of the hydrocephalus. Let's go to the next one. The next is now a basilar trunk aneurysm. Basilar trunk aneurysm, especially the one on the left, it's the worst nightmare that anyone can have, surgically, endovascularly, or if you want to conserve it, how is the patient going to do? So this was one of the luckier ones. As I said, I'm going to show you one patient who has done well and one's not so well. So we went ahead with overlapping pipes, right, coming from the PCA to the basilar, entire 3 or 4 pipelines coming in. And either we were lucky or the patient was lucky. After overlapping pipelines, the aneurysm remodeled, and over a period of next few months, the whole thing, you can see that the whole thing has actually shrunk. And this has happened because there was no thrombus inside this aneurysm. It was a completely fusiform dilatation, and the angiography looks good, and for a change, her imaging also looked good. And this was from the time that we started, when we treated, and the control. What about another one? Almost similar, basilar trunk, and this was unfortunately at the time where the flow diverters were not there. We nevertheless tried to make a flow diverter by overlapping the stents that we had available, and 2 or 3 stents that were placed over there, overlapping. And in that era, we were not sure about what we were doing, so actually you will see that we had conserved him, thinking that he's doing very well. And after conservative management, in 2 years' time, he came back again. This time he came back because his carotid had got occluded, simultaneous. Maybe this is a wall disease, a collagen vascular disease, but he had problems in his vessels. You can see that the carotid is gone and a giant aneurysm on the basilar, and this time it was troubling him because it is indenting on the brainstem big time. So we went ahead and treated him, no flow diverter then, so we put to this aneurysm, we put overlapping long stents. Everything looked good, especially this sign when later on became very popular because of the flow diversion. And that time when we saw this, we knew that we had treated him. And again, feeling good. Feeling good, the earlier patients, good for a few months, for a few years. This patient, we were feeling good for only 6 hours. He was good, woke up well from anesthesia. CT scan was very good. The stent patent, no bleed, no ischemia. 6 hours later, he had a significant neurological problem. And to that problem, we did his angiography, and this was an acute stent occlusion. This is what can happen if you overlap the stents. As I'm saying, similar looking aneurysms, similar looking strategy and plan, but sometimes the results on one way are completely contrary to the other. Collateral circulation is not bad on top of the circulation, but he did have permanent neurological deficit, from which this is an immediate MR, and a couple of weeks later, the mass effect is a little less, but nevertheless, he did have permanent neurological deficit because of this. Let's go to the next one. Now, proximal basilar aneurysms. Look at this aneurysm and look at this aneurysm. They are slightly same but different. Here, we went inside, we coiled because this patient had a small bleed, and this was one of our exceptional cases of using a stent or a flow diverter in an early subarachnoid hemorrhage. We used the coils and we used a flow diverter coming in from the basilar into the right vertebral artery, and we did not occlude the left vertebral artery simply because here you can see that there is no pica on either side, And here you have the ICA-PICA trunk. When this happens, the perforators, when there is no pica, they come in from the intradural vertebral artery. And so we did not occlude it, but we went ahead and coiled it. Again, loose packing, as we have been talking about since morning, and then an FD with a stable result. Take another one, proximal basilar aneurysm. Here also, this patient is unruptured, partially thrombosed. We used an FD as a single device, no coils inside. FD, technically, there's no problem, everything looks good, except you'd say that what happened to all these branches? But we will see that later. But as we waited, as we should, over 15 or 20 minutes, it started to give problems. And when problems happened, we went ahead inside and did an angioplasty with a balloon. As you can see here, balloon inside. And after the balloon, the stent open, the artery flowing. But, hey, what happened here? Where are all the branches, which is the basilar is looking, the proximal basilar is looking bald. So I was wondering, what was the situation here? Till we took the left vertebral artery shoot, and you can see the left vertebral artery is filling all of the circulation of the left cerebellar hemisphere, which is outside the flow diverter. And for the time being, he did not have any neurological deficit whatsoever. And on follow-up, his MRI is looking good. But the angiography was slightly scary. We thought that we lost all his perforators there. From proximal basilar, we come to something that we have been doing for a very, very long time, of which the first case I have shared on NeuroAddicts Forum a few months or maybe years, wherever, that we treated her. She was an 11-year-old girl with a large proximal basilar aneurysm. We did not want to put a stent or a flow diverter in her, even though they came in from another country, so that the flow diverter could be put in her. We refused, and what we did a simple balloon test occlusion, which was fantastic. She was a kid, the balloon test occlusion was full, and so we managed to get the aneurysm along with proximal vertebral arteries, saving her ICA on the top and pica beneath. And this is what we have here, complete flow reversal, which we have practiced for a long, long time, learning from our Professor Moray. And here, it's a flow reversal, ICA is patent, and the pica is filling from down, and patient had no neurological event. Another patient, an adult patient, an unruptured patient, and here also we told him exactly the same thing, that your aneurysm is proximal, your balloon test occlusion is fantastic, you should occlude, or we should occlude your aneurysm. He did not believe us because it's a destructive treatment. He didn't believe us, and so he went elsewhere to get, that time we had only one flow diverter, I guess, but he did want pipelines, so he went elsewhere to get the treatment, and to the capacity of the neurointerventionist, it was done very, very well. Unfortunately, the disease always does not recognize the talent in neurointervention. The disease goes by itself. It was beautifully done. Coils in the aneurysm, flow diverter in the basilar. The angio is going to look perfect, superb. But is the patient perfect? Patient is not perfect. The other vertebral artery was also occluded. So whatever that had to be done was done. Unfortunately, the patient is not doing well at all, and the scans are looking terrible. And this is what happens. It's like on one side, you have similar looking aneurysms with completely different results. Coming back to the last part of my talk, we have seen that the proximal ruptured dissecting vertebral artery aneurysms need sacrifice, and there's not too much to talk about this. When you have that, even though the other vertebral artery is small, again, an initial practicing neurointerventionist or a novice would say that how can I occlude the dominant vertebral artery when the other artery is so small? But you can do that, and you can do that safely, as we did in this patient. There was no problem. We have also done, before the flow diverting era, another set of patients who have had dissecting fusiform aneurysms like these. And these, we have reconstructed those arteries, again, a controversial kind of treatment. Not anyone practices that anymore, including us. What we did was, we actually coiled the aneurysm. So if you coil the aneurysm, there is no neck. It's a fusiform nature of the aneurysm. The coils are inside the vessel. But we also had a stent, a catheter of the stent, which was placed inside. And after we put coils, surround coils along the stent, we opened the stent. So that way we have a surround effect of the coils which are outside the stent, and there is a stent which is keeping the artery patent, and after whatever 5-6 months control, this aneurysm responded very well. As I said, we don't practice it anymore because we have better tools to deal with this. Last one that I'm going to ask you now, that what will you do? Aneurysms like these, it's not like last couple of months that we have treated. It was treated some time back. It's a dirty looking aneurysm in, again, an 11-year-old girl. So we went ahead. It's partially thrombosed, massive, giant. She has neurological deficit, but that deficit is only the top of the brainstem signs, the eye size. We treated her. Collaterals were superb. And so we treated her blocking the vertebro-basilar system with effect that we thought that is going to be a good option for her. Amongst all these, what would you do today? Today we have flow diversion available. Overlapping stents were present then. Sacrifice is what I thought, a kid. Flow reversal, like the same thing, or conserve. It's a difficult choice, right? Even today. But I'll show you what we did. This is what we did. It's a flow reversal in a kid with proximal basilar branches, the cerebellar branches pulling the blood through. Over one day, everything is under control, the aneurysm is smaller, and we were again fooled by what happened in the initial time, but later on, she had a neurological event with quadriparesis. This is what she ended up with. Just to finish the talk, last two cases, we have had some complex-looking cases, some of them because of our location, geographical location. It was an infective aneurysm, a mycotic aneurysm, which we have classically gone inside and treated with sometimes coil, sometimes glue. I think this was a small drop of glue with occlusion of the aneurysm. And of course, there's not too much that we have to talk. This is a special case, the last one in the presentation. And this is special because, you know, it's a mid-basilar dissecting aneurysm. We can see that. So what's so special about it? What's so special is that this is in a 6-week-old child. So in all probability, this happened during the forceps delivery that the child was born with. So it's actually an injury to the basilar artery because of birth, and he came in with subarachnoid hemorrhage. Because of what we have seen over the last 20 minutes or so, we just went ahead inside, kept his proximal basilar intact. The distal basilar and the basilar top were all getting collaterals from carotid. And of course, the child has done very well. That was a few years ago, maybe 15 years ago, but is growing up well. In conclusion, what I want to show is that we have the tools to deal with the situations today. But we can never be overconfident and say that, oh, we have the things now and I have 20 years experience, so I will do a good job for you. We try and do good to every single patient. I tried to show you examples that in spite of almost the same kind of planning and treatment, some of your patients will have problems simply because this is posterior circulation, it is giant and complex. So it was formidable 20 years ago, and at least for some of us, it still remains formidable. Thank you for your attention.
Any questions? Okay. Mehmet? Mehmet. Okay. Michel has a question.
Thank you, Dave, for this tremendous presentation, because we can see this accumulation of a lot of experience and cases. But for the audience, I think it's very difficult to retain guidelines. I would say that your presentation encompassed a different pathology. You have the true saxiform or fusiform aneurysm in the young patient, where there is no thrombus, which I think are the best cases for cure. Personally, we have a long series also, but always the same typology of patient, 60, 70 years old, male, high blood pressure, smoker with giant partial thrombosed fusiform aneurysm of the basilar. And these guys, they never ever had PCOM because we do test occlusion. And we did pipeline them, silk them, whatever, even conservative management with statin, beta blockers. And in our series, about 30 cases, around 30 cases, whatever the treatment we did, when they start to be symptomatic, they die within 1 year. It's very frustrating. Have you got the same experience?
I mean, as you said, this was just an attempt to say exactly what you have just said. That some of them, the disease is looking the same, maybe on the scan or on the angiogram, but actually you go deeper into it, as you rightly said. Sometimes you have causes that older, hypertension, smoker, etc. And sometimes they just behave oddly. So this is what I just wanted to point out, that there is no science. There's science behind it, but you cannot form rules or generalizations.
Michel, did you say that you did 30 cases of partially thrombosed? Is that what you're saying, or without the thrombus?
No, I say roughly it's a 30, short series of 30-something cases. We did try to do something, pipeline, silk, or even no treatment, only medical treatment, because we had experience with flow diverters. They all died within a few months. So we tried medical treatment, and we changed nothing. I do not think that the flow diverter is a key solution for this aneurysm. But it's not all giant aneurysm of the basilar. It's a specific findings of the fusiform partial thrombosed giant aneurysm of the basilar, which are terrible. They grow like a tumor.
I think, Shimon, you had come to do a case with me, the partially thrombosed aneurysm, the one we put 3 Leo stents. That patient also did well for some time, but eventually, like other patients, they all have slowly declined, and that patient also died in 2 years' time.
Yeah, I mean, as all of you are saying the same, if you could realize that none of those patients are actually included in this. No. Because we know this for some time now, that those patients you treat, you don't treat, you do laser cut stents, overlap stents, or flow diverters, or conserve, all of them do not do well. So, I did not include any of those inside this series. This is still...
Uday, a lot of your cases, where you had a deconstructive treatment. Yes. Do you have a long-term follow-up in some of them with angiogram? Did you see any other problems in the rest of the vessels? Did you see anything else that you can tell us?
Yeah, I mean, I'm luckily or unluckily, these cases in which the deconstructive or flow reversal kind of treatment was done, the number is not great. The number is maybe less than 20 overall, out of which I shared with you the problems that we have had. So those patients have not done well. And I cannot say that the number of patients who have had complications is under 10%. I would say that the complication rate in these kind of aneurysms is like 20 or 25%. So every 1 of 4 patients who have had problems. Unfortunately, I won't be able to say that the guys who did well initially for the first 1 year or so, I don't have a follow-up on them over the last 5 or 10 years, because most of them were done really early in our experience. So I won't be able to say that over a period of 10 years or 20 years in their lives, they have done well, except a couple of them, young guys, who are leading their lives normally till now. But yeah, it's not a very, 1 or 2 is not a big number.
Mehmet will show Istanbul experience in low-profile stents.
Thank you. Good afternoon to everybody. I am Mehmet Barbaroğlu. I am from Istanbul University, Istanbul Faculty of Medicine. I am doing this presentation on behalf of my mentor, Professor Kubilay Aydın. He wanted me to tell you how sorry he is for not being here because of some private issues. Today, it is a pleasure for me to be here and share our experience about Leo baby stents, use Leo baby stents in endovascular treatment of intracranial aneurysms. As you all know, stents have been used for endovascular treatment in last 20 years. Stents used for we use stents for wide neck and complex aneurysms. Stents, we create a metallic scaffold to prevent stent coil protrusion in the parent artery. And sorry, to prevent coil protruding in the parent artery. Beyond their mechanical effect, stents have flow diverter and biological effects. Okay. Have biological effects. Leo baby plus stents. Leo baby stents are self-expandable, braided nitrilone stents. They are very low profile compared to standard intracranial stents. We can deliver they through microcatheters 1.7 French diameter, like Vasco-10, Headway 17 or Echelon 10. Can be deployed them with a very small arteries, internal diameter down to 1.4 or 3 millimeter. It's a big advantage of Leo baby stents. You can resheet them up to 90-95% of their length. We investigated safety and efficacy of Leo baby stents in among our patients, 80 patients, 80 wide-necked aneurysms. Leo baby stents assisted coiling. Our technical success rate was 97.5%. No mortality and permanent procedural complication was 3.8%, thromboembolic complication. Now I will show some cases. The complexity of the cases and aneurysms will increase as slight progress. This is a ACOM aneurysm. It is wide neck aneurysm. We coil it with singles Leo baby stent assisted coiling. We deployed one Leo baby from the right A2 to A1. We jailed a microcatheter into the aneurysm sac and we coiled it. This is the final angiogram. This is another ACOM aneurysm, 47 years old male. He had subarachnoid hemorrhage due to this shallow small aneurysm. He had a failed surgery in another hospital and referred to our center for endovascular treatment. 2 millimeter anterior communicant artery aneurysm. We jailed a microcatheter and with another catheter we deployed one Leo stent from the left A2 to left A1. This is the final angiogram. This is another patient, left wide neck, complex middle cerebral artery bifurcation aneurysm. the superior trunk was originating from the aneurysm. We could treat it with one Leo baby stent. We deployed one Leo baby from the superior trunk to left M1, and we coiled it from the gelled microcatheter. This is the final angiogram. Another patient, this is 47 years old female, unruptured distal MCA aneurysm, relatively wide neck aneurysm. We coiled it single Leo baby assisted coiling. We deploy one Leo baby in the this side branch and coil it with gelled microcatheter. This branch diameter was 1.8 millimeter. 44 years old female, has a recurrent anterior cerebral artery aneurysm on orbitofrontal branch of A2. We retreat her with single Leo stent assisted coiling. This is another patient, 44 years old female, distal anterior cerebral artery aneurysm located on the frontopolar artery. This patient had a failed surgery in another institution. You can see here the surgery clip. We gelled a microcatheter and deployed one single stent. This is the final angiogram. This is another patient, have a wide neck complex ACOM aneurysm. It's below macrolobulated. The both of A2 originating from the neck of the aneurysm. We put one, we gelled one micro stent into aneurysm from the left side, and the stent catheter come from the right side. We deployed one Leo baby stent, and with one single stent we can cover the aneurysm neck and coil it the aneurysm safely. This is another patient, 53 years old female, had a right MCA bifurcation aneurysm located on temporal branch of MCA. We deployed one Leo baby into the temporal branch to M1 segment, and we gelled one catheter, we coiled it. This is the final angiogram. 62 years old female, another patient, has a shallow small aneurysm located on the superior trunk origin. We deployed only one stent into the superior trunk. Half T stent assisted coiling, we call this technique. We gelled one catheter into the aneurysm, and the stent ended here into the MCA inferior trunk origin, near the inferior trunk origin. This is the final angiogram. Another patient, 57 years old. There was a 6 millimeter aneurysm on the communicant segment of internal carotid artery. The posterior cerebral artery was fetal type origin. We deployed one stent, Leo baby stent, into the posterior cerebral artery. and it ended just next to aneurysm, and coiled the aneurysm. This is the final angiogram. This only a superposition. It is macrolobulated aneurysm. In the working angiogram, there isn't in the internal carotid artery any coil protrusion. This is another single stent assisted coiling patient, a 44 years old female, ruptured right pica aneurysm. Here the CT, there is hemorrhage in the interpeduncular cistern. Sorry. It was very difficult to catheterize right pica from the ipsilateral vertebral artery. So we catheterized pica from the contralateral vertebral artery. This is an illustration of the case. And from the ipsilateral vertebral artery, we jailed a microcatheter. This is the final angiogram. We could coil it safely. Dual stent assisted coiling. Some cases have very wide and complex aneurysm. We can't treat they with single stent deployment. So we have to use sometimes 2 stents or more, or try another techniques. We put these double stents with various configurations such as Y, X, T, half T, or parallel stenting. This is a left internal carotid artery bifurcation aneurysm. 6 weeks ago, this female had a subarachnoid hemorrhage due to this aneurysm. We deployed one Leo baby stent into the anterior cerebral artery from to A1 to internal carotid artery and jailed microcatheter. We start to coiling it with single stent, but we show the stents protrude into the left middle cerebral artery. So we changed our strategy and take another microcatheter and pass through the Leo baby into the left middle cerebral artery. And we deployed another stent into the middle cerebral artery and coiling it with Y stent assisted coiling. This is another patient, has a big wide neck anterior communicating artery aneurysm. We treat this patient with X stent assisted coiling. We deployed with X configuration stents. From the right, we deployed left A2, from the left A2 to right A1. From the left side, we deployed from right A2 to left A1 Leo baby stents and jailed a microcatheter from the left. We coiled the aneurysm safely. This is from the jailed catheter, right to left. This is the final angiogram, right injection and left injection. The aneurysm occluded. There is a superposition on the anterior communicant artery. And this patient was have 2 aneurysm on the left internal carotid artery supraclinoid segment. We deployed one silky stent for these aneurysms treatment. at the end of the procedure. This is another patient, has a shallow anterior echo aneurysm, bilobulated aneurysm. He had a failed surgery in another hospital and referred to our institute for endovascular treatment. At first, we tried to treat with single Leo baby assisted coiling. We partially deployed from the right A2 to left A1 one stent, and we start to coil from the jail catheter, but the coils start to protrude into the left A2, so we changed our strategy, and we catheterized both A2 from the ipsilateral sides, from the right to right A2, left to left A2. We do parallel stenting and coil the aneurysm. This is the final angiogram. This is another patient, 63 years old male patient, no hemorrhage, anterior communication ecom aneurysm, wide neck, involved both A2 origin. We coiled T-stent assisted. We performed T-stent assisted coiling. There is a. Sorry, I will look to. The slides. Okay, I will speak about T-stent coiling at first, and then show the cases. T-stent assisted coiling, we published our patients about our experience, 31 patients. In 2000, when we published this paper, there was 24 patients only. Now we have 31 patients. We changed the rates. Our total occlusion rates was 88%, and our complication rates was 3.2%. There was progressive occlusion rate 40%, conversion of partial occlusion to total occlusion during follow-up. Now I will show. Yes, this is the first case for T-stenting, anterior ecom aneurysm. We catheterized 2A2 with echelon 10 catheter and jailed one into the aneurysm. We partially opened the Leo stents at first and start to coiling the aneurysm. When we create a sufficient coil mesh into the aneurysm to support the stents, we fully deployed the stents. We deployed the left one at first, and the shorter one ended just the neck of the aneurysm. Here we can see, this is a T-stent assist coiling. This is the final angiogram. And this is the 18 months follow-up. There is a stable occlusion. At the final angiogram, there was a remnant neck, but at the 18 months follow-up, we showed the total occlusion of the aneurysm, and the stents were patent. This is another patient, 38 years old male patient, has headache, right middle cerebral artery bifurcation aneurysm. Involved both trunks. We treat with T-stanting, deployed 3 catheter into superior inferior trunk and 1 into the aneurysm. And we opened at first partially the stents and then start to coiling. When we create a sufficient coil mesh, we to support the stents, we deployed the stents fully deployed. This is the angiogram and vaso-CT finally angiograms. Here the short stent and the long one extend to M1. This is another case, right middle MCA bifurcation aneurysm. It is a complex aneurysm involved both trunk and there is a bad angle between the M1 and M2 trunks. We catheterized with 3 catheter echelon and at first we deployed the this is illustration, the inferior trunk stent, we deployed it totally and then we coiled the aneurysm. When we create a sufficient coil mesh, we deployed the superior trunk and it support the aneurysm and prevent the migration of the stent into the aneurysm. This is finally angiogram of the procedure and this is 9-month follow-up. There is a mild instant stenosis, but the stents and the stents patent and the aneurysm stable occluded. This is another patient, right MCA bifurcation aneurysm, bilobulated wide neck aneurysm, no subarachnoid hemorrhage. We coiled it with the stent assisting coiling. This is the short one and the long one we from the superior trunk extend to M1 and coil the aneurysm. 24-month follow-up, stable occlusion and the stents open. This is another patient, left internal carotid artery bifurcation aneurysm. 62 years old female, no subarachnoid hemorrhage. We treated with T-stanting again and 3 microcatheter, 1 into M1, 1 into the A1 and J-lit. This is the final angiogram. This is a basilar tip aneurysm, 41 years old female. We treated with T-stent coiling, T-stent assisted coiling. This is the short arm. Here it ended just the neck aneurysm. This is another internal carotid bifurcation aneurysm. We deployed 3 catheter, 1 jailed in the aneurysm and 1 into the A2, 1 into the M1. At first we tried to coil it with single stent assisted coiling. We deployed the MCA stent and coiled the aneurysm, but at the end, the coil, end of the coil part protrude into the anterior cerebral artery. So we deployed the second stent. This is the final angiogram. This is the coil loop protrude. At the end of my speech, I will mention about stent monotherapy. Leo baby stents has a relatively high flow diversion capacity. stent monotherapy sometimes be a good option for dissecting or uncoilable saccular aneurysm. We can deploy single or telescopic implantation. And we can perform early follow-ups with MR angiogram. This is a right A1 aneurysm, small shallow aneurysm. This patient had a left middle MCA bifurcation aneurysm and treated with surgery clipping. We treat his right A1 aneurysm. We deployed only single Leo baby stent into A1 segment. And this is the 6-month follow-up MR angiogram. The stent thrombosed. The aneurysm is occluded totally. Stent is open. This is another patient has an unruptured ventriculostriate aneurysm. We deployed telescopically 2 Leo baby stents into the M1 segment of middle cerebral artery. This is 9th month follow-up. It is reconstructed. The ventriculostriate artery is patent, but the aneurysm is thrombozoid. This is a right pica aneurysm. We deployed 2 Leo baby stents telescopically. 6-month follow-up. The stents open. Here there is a mild stenosis, but the aneurysm is totally occluded. Here the CT angiography. This is a last patient. Has a pica dissecting aneurysm. We catheterized the pica cortical branch with a microcatheter. We turn into the aneurysm to catheterize the cortical branch. We deployed 1 single Leo baby stent. At 1 year's follow-up, the aneurysm is occluded and the stent is patent. Conclusion is using low-profile stent-assisted coiling is feasible, effective, and relatively safe endovascular method to treat wide neck and complex intracranial aneurysm. Thank you for your attention.
Thank you, Dr. Mehmet. Maybe somebody has questions or comments? Thank you very much again. And next speech is about aneurysm treatment by Dr. Anil Arat from Turkey.
As the computer is getting ready, I would like to thank Munjil for organizing this meeting. This meeting is peculiar in one aspect that, to my knowledge, it is one of the rare meetings in our specialty, which is born out of a a social media forum, the Neuro Addicts. I'd like to thank Jackie from BALT for starting up this forum, and Munjil for keeping it alive. And one thing that is important in this forum is that it is a supportive environment, and thanks to the big shots, I'll call, if you don't mind, like Dr. Chapeau, Michel Piotin, and I see Tufail, and I also see other friends contributing. And we need such forums, and perhaps this goes on, and I hope that this is the first meeting of the forum. Anyway, today I'll have to turn my back to you because I'll have to present from my computer. I'll talk something, I wanted to show something different, and I said, what do I have? And I said, perhaps I should talk about Back to the Future in aneurysm treatment, very briefly, couple cases. So for those who are old enough as I am, we started with the balloons, detachable balloons, but by Dr. Serbinienko, then came the coils, and then came the balloon-assisted coiling in about 2000s. Once upon a time, it was very fashionable to inject onyx into the aneurysms, and then came stents, and finally the flow diverters. This one? Oops, this one. Okay. And once we had the flow diverters, we had the positive results, but we had an unexpected complication, which was aneurysmal bleed soon after embolization. And also a second problem was that we had this delayed intraparenchymal hemorrhages. These were new complications for us. And a group of physicians started coiling the aneurysms together with putting flow diverters. And in a recent review, it ranged from 0 to 59% of all aneurysms treated by different authors by coiling. The first publication, major publication, was from New York, and then they claimed that there were fever retreatments with flow diverters plus coils, and this was later on supported by different groups talking about delayed recurrences being late in, lower in coiled group, and this is the very recent article about it. There's one registry saying there is no difference. And there are some colleagues trying to put some science behind it through flow diversion, dynamic studies. Now, are coils the only option to assist flow diverters? That's my question. And then, is there a way back to the future? So I'm going to talk about briefly 12 cases in which we used other stuff except coils or with coils to occlude the aneurysms, and I'm going to show you why we did them. 10 of them are aneurysms, and almost all except one are large aneurysms. One is a gunshot wound injury, the small one, and it was a pseudoaneurysm acute. That's why we used a different technique. And we either treated them, all of them received flow diverters plus some supportive devices, mainly stents, to oppose them. Plus, intrasaccularly, we delivered balloons or squid, and in one case, onyx. And finally, I'm going to show you, as a matter of fact, a Leo baby stent. In follow-up, we have, in all except one, we have short follow-up, but almost all of them, except the two that don't have the follow-up, are occluded. One has a very small residual, which you'll see that the residual is probably going to go away in an early follow-up in 6 months. We have one complication, which again you're going to see. That was a delayed intraparenchymal hemorrhage, and I'm going to ask your opinion as to why it may have happened. So this case is a supraclinoid aneurysm, 12 millimeter in diameter. We have these two guiding catheters in the ICA. We first bypassed the aneurysm, deployed the flow diverter partially, and then navigated the balloon in the aneurysm. And this is the detachable balloon by Balt. All of them detachable balloons are from Balt, and we only unfortunately have the 7 by 20 millimeter balloon, so that's the only one we can use. Basically, we inflated the balloon and then deployed fully the flow diverter. And here you see us pulling the balloon and detaching it. And as actually, this is how we started, this is how we end. We actually corked the balloon into the orifice of the aneurysm. It acts like a cork. Here you see, if I can make it move, and then we used the Atlas stent directly through, oh, I'm sorry, here we go. We used the Atlas stent directly through the surpass stent without any exchange or anything. And then this is the final picture of the deployed stents and the deployed balloon. And this is the post-treatment angiogram, just to show you how the balloon may affect the flow in the aneurysm. It changes it so that there is an obstacle on top of the flow diverter to the flow. And this is the 1.5 month, 1.5 month follow-up CT angiogram showing the balloon is still partially inflated, and then there is no evidence of intra-aneurysmal flow. The aneurysm is gone. The next patient is a ruptured aneurysm, which is about 20 millimeters in size. It's 25 millimeters in size. It is a giant aneurysm. It was quite hard to bypass the aneurysm. Actually, we had to go through the aneurysm distally. This is the navigation of the balloon. Now, in contrast to what we used to have before, you see that the balloon is interacting with the catheter of the flow diverter, but you can manipulate the balloon and the other catheter consequentially to be able to get the balloon inside. As usual, the balloon goes into the bleb first, but if you inflate it and play it back and forth, you can place it in the aneurysm. Here is the balloon at the tip of the aneurysm, and on the right side you see it inflated. And again, I'm going to play this. This is stagnation of the aneurysm as we're pulling on the balloon to detach. Now it detached, and then you see the flow, again going into the aneurysm. One problem is that, as you see it here, this is just before detachment, and as it detached, it leaked, so it became smaller. Because balloon is old technology and there may be problems. Here you see the end of the procedure on the oblique view. There is extreme stagnation in the aneurysm, and this is, I think, 3 days later. We treated the other side, the aneurysms on the other side. You see the aneurysm deflated more. I mean, the balloon deflated more. And this is the 2-month follow-up. As you'll see, there is very sluggish flow in the aneurysm where the balloon had deflated. And the rest looks okay. We think that by 6 months this will have gone away. Another patient who came directly from the OR, she was having transsphenoidal surgery, and then they lacerated the artery, oblique and lateral projections, some weird-looking pseudoaneurysm, and the patient was intermittently and actively bleeding, as you see it on the lateral. You see the dissected segment and the aneurysm over here. Unfortunately, the patient didn't have a cross flow on cross compression. So again, what we did, we bypassed the aneurysm with a surpass device. We jailed a catheter, microcatheter into the aneurysm. We partially, actually then fully deployed the flow diverter. And as we do the injection here, she was bleeding intermittently. As I mentioned briefly, you see that the patient started bleeding again. And then we did a very gentle injection within the aneurysm. You see the patient is extravasating. So we directly inflated our balloon, and we said we're going to inject some squid into it, the fastest way probably. This is after we inject the squid and we're deflating the balloon. Over here you'll see that the balloon will deflate and the cast will stay as it is. And on the bottom you'll see again the injection of squid with the balloon inflated. This is, the video is running, I'm gonna let it run just to show you how slow the injection is, and this is the final cast at the neck of the aneurysm. This is at the end of the aneurysm. There is some filling of the pseudoaneurysm, quite a good immediate result. As you see, the cast is by the flow diverter, and there's also a stent inside the flow diverter. This is at 10 days when the surgeons decided to take away the nasal packing. As you see, the PCOM has already diminished in size. There is no residual aneurysm at all. Just one little finding is that the cast had moved away slightly from the stent construct. And then we put the balloon up just in case, as they were removing all the nasal packaging, but it was safe, there was no problems. They actually did, it's them here with their instruments, they did some more tumor removal. And unfortunately that patient died because that was a huge tumor, and she died because of the consequences of the malignant tumor. But the aneurysm was totally obliterated as of 10 days. In this patient, again, from here to here, the aneurysm measures about 20 millimeters. We deployed, this time it's a Derivo stent, we ballooned it into the aneurysm after jailing the microcatheter. We put a couple coils, not too much, and then we started injecting squid. This is the single lumen balloon catheter. And then we did the angioplasty as we were coming out. This is the end of the procedure. This is the inflated stent. This is the cast, very close to the balloon of squid inside the aneurysm. On the top row is the immediate post-procedure injection, and at the bottom it is the, I believe in this patient, it is a three-month follow-up angiogram showing no residual aneurysm. Another supraclinoid aneurysm, again 20 millimeters in size. What we did in this patient was similar to what we have shown. Again, the balloon is coming up. This time, because it was a little bit tortuous, so we first came up with the balloon, inflating and deflating the balloon, as you see over here, and then oops, it just jumps into the aneurysm. Partially deployed a flow diverter, inflated our balloon. And in this movie, you're going to see, it's a bit nerve-wracking to pull the balloon. We're not used to pulling balloons against stents, but now it's going to pop out here. Oops, popped out. And here is the balloon and the stent construct again. So this is immediately post-procedure showing the stagnation. This is pre-procedure for comparison, and this is the fast imaging showing how the balloon was corked again at the orifice of the aneurysm. And this is, now I believe in this patient, this is the 5-month angio follow-up. The balloon had almost deflated totally, but it had done its job. So it's, in a way, the balloon is like a boyfriend or girlfriend. You need him or her when he's over there when you need him or her, and then later he's gone or she's gone, which is good. This is a direct CC fistula. Again, to make a long story short, we deployed the balloon. We tried to cork it at this junction of the vein and the artery. We pulled it, but it would not come back. It would stay over there. So we started coiling. The good thing is that once we did that, the flow anteriorly had diminished. Only there was flow through here. We first tried to do balloon coiling, but as you see, the coils are popping out. So we put a couple coils in this area, but the final coils were coming out. So we put our flow diverter again, and finished coiling through the transvenous side. This is the end of the procedure. The patient is doing very well at this point, awaiting for follow-up. This is the patient with an unfavorable outcome.
This patient has aneurysms all throughout his body. The presumptive diagnosis was Marfan's, but some of the rheumatology colleagues did not believe that was the case. He had a previous rupture of an SMA aneurysm. All medium-sized arteries in this patient, in this young patient, had aneurysms on them. This patient's aneurysm on the left vertebral was causing him agonizing pains in the left neck. So we decided to treat the left side. The right side was similar but asymptomatic, so that was not planned for a treatment. So again, we put the balloon up, we put the flow diverter in, and just to show you the difference, this is after the flow diverter, and you see over here the jet of the contrast coming in, and on the right side you see that the jet is different. I don't know if that means something, but it is more shallow, and here is the shadow of the balloon in place. This is the CT angiogram, I guess three days later, and this is the angiogram immediately after the procedure, just before we close the groin. This is the MRI study, the regular follow-up MRI study done 2 days later. The patient didn't have any symptoms, and we saw this tiny dot. We didn't know what it was, but it looked pretty innocent. And the patient had an outside angiogram about 4 months ago, which looked okay. There was nothing over here. The patient has well-developed anterior and posterior temporal, middle and posterior temporal arteries, all originating from the right-sided carotid circulation, which we did not even do the angiogram of. And then 1 day later, this is post-operative day 3, the patient developed a big hematoma around that spot that I was showing to you. We don't know what it is. The patient's family declined an autopsy, and we lost the patient because of this hematoma. At that point, the aneurysm distally was obliterated. Proximally, it was filling a little, and there was no problem with the flow in the construct. It remains to be known what caused the bleeding and what was that white spot. And the final patient is an old patient with a large MCA aneurysm. The plan was to first put 2 Leo baby stents and coil the aneurysm, but we're not as good as the colleagues in Istanbul. So as we're coiling it, we caught the stent. Obviously, the landing zone was not good enough, but we were kind of too confident in ourselves that saying it was going to be enough. And this is the catching of the stent, and oops, as we're coiling it, we're trying to put the first coil in, the stent migrated from the distal segment. So after thinking about it and thinking that we will not be able to go through the stent again, we decided to push the stent into the aneurysm. So we pushed the stent into the aneurysm and deployed a silk stent. So here's the construct. This is an intra-aneurysmal flow diverter, sort of say. And this is the regular flow diverter. Now, this is the 6-month angiogram showing no change in flow. I'm sorry, this is the immediate post-procedure. This is the 6-month, no major change in flow, straightening off the artery a little bit. Here's the patent superior trunk. And over here, at the bottom, you see, here is the stent, and here is the aneurysm. So it was patent. Fortunately, this is an outside CTA of the patient. The patient refuses to come back for a follow-up angiogram, but the superior trunk went away without any problems at about 1.5 years, and the inferior trunk is patent. So just to summarize it up, balloons may be an alternative for coils, detachable balloons. I hope BALT comes up with a newer generation balloon which may be DMSO compatible as well. They're cost effective, time effective, they enable CTA follow-up, they have mass effect only temporarily, and as I said, they're there only when you need them. After 1 month, they just deflate away.
And it is this first 1 month that you have the risk for, the highest risk for delayed bleeding of the aneurysm. Squid has the ability to immediately occlude a higher percentage of the volume of the aneurysm. It is cost effective and time effective. And braided stents as intraaneurysmal embolic agent those are not to be used intentionally with a sober mind as intraaneurysmal devices, but I think you can use them as bailout devices. Thank you.
Спасибо, доктор Амил. У кого-то, может, есть вопросы?
Any questions?
Okay, Anil, all three of us decided that we want to ask you questions. So it's just that I'm sitting in front, so I'm the first. Okay. Now, you know what I'm going to ask you. And so, given the novelty of using a balloon or reintroducing the balloon as the intrasaccular device, it was the first intrasaccular device ever.
Yes.
Like 30 years, 40 years ago. So, you know what, looking at those pictures, you said whatever advantage that they are, and you were candid enough in saying what you actually felt when you detached the balloon or deflation of the balloon. But, you know, we are not still convinced. So we gave up balloons because of exactly those problems that you mentioned. So the pictures that you showed, it's good that you did not have any complication, and I hope that you never do with this technique. But the pictures that you showed, it made me worry that these are exactly what you don't want to see when you're treating a medium-sized aneurysm with a flow diverter. Because now the balloon that you have, okay, it's occupying space inside the aneurysm, but it is not exactly breaking the soft thrombus in the aneurysm as a coil or multiple coils would do, number one. Number two is that it may act as a trap door, and a trap door, it is not really allowing contrast not to enter, blood not to enter the aneurysm, but it may actually act as a trap door that the contrast of the blood does not exit the aneurysm. So, as I said already, that I'm happy that you did not have any ruptures there, but it does make me worry a little.
Okay, so for the first question, now, and also the second question, we don't know what makes the aneurysm rupture after, I'm talking about delayed ruptures. One of them may be that the ball valve effect, maybe, as you mentioned, and the second one of them is the thrombus theory. Those are the two main theories. Now, in terms of the balloon, why I thought about using a balloon in these cases was, number one, those little balloons, as you saw them, actually I had a slide, but it was going to be too long. In all those aneurysms, they occupied about 25% to 33, 1/3 of the volume of the aneurysm. I actually have a calculation of that. Now, if you would coil the aneurysm, that's the amount of volume coverage you would get. So, in terms of the thrombus volume theory, I think we're in the same ballpark with the coils. All I'm going to say now is about coiling plus flow diverters. Now, if you say coiling or balloons are not necessary, that's another debate, and that may be right as well. I don't know. Now, if you go for the first theory about the inflow effect, now, when you do coiling, you also block the outflow of the aneurysm. You have done loose coiling, but there is no definition of a loose coiling to my knowledge. So what is a loose coiling? And how do you make sure you don't have enough coil loops at the neck of the aneurysm doing what you told as reverse ball valve mechanism, that the systolic flow goes in, the diastolic flow cannot come out. So I'm not sure if there is a real difference in between those two, at least in the current time and in theory, about the risk of rupture of an aneurysm. There was another third question anyhow, so I don't know if I could answer your questions.
Anil, you showed some nice results, but we all were trying to understand the rationale of putting a balloon which has gone out of business for a valid reason. You were very lucky and that's great. But I'm trying to understand, if I have to do a balloon now with a flow diverter, whether we know flow diverter works very well, and some of your aneurysms you may have got away without a coil. It's a question about delayed ruptures, what happens, should we put, should we not put? It's a different question. How do you consent your patient? When you're putting a balloon in an aneurysm with a flow diverter, what risks and what complication risk you tell the patient?
The same complication risk I would give for, say, a Web Plus flow diverter. Now, I don't know how many of...
But you're doing a balloon.
Let me finish first. I don't know how many people here have used balloons in their lifetime. And they have gone out of business because they had a major drawback of recurrence. But actually, it's very easy to use an aneurysm. It's very quick. And a balloon in an aneurysm is very quick as well. In terms of the risk, I don't know how you consent your patient if you put him extra risk, if you give him extra risk when you coil and flow divert an aneurysm, or if you do Web plus flow diversion. Going back to balloons with these cases, it was really very interesting for me to realize how actually easy it was to navigate a balloon. To put it up, the risk of rupture of the aneurysm, I'm not talking about the inflation, but the navigation was quite straightforward. Now, why would I do that? Now, the basic question is why I would do that. The reason is that on top of the cost issue, the reason I had was, I said, we're putting all these coils in the aneurysm, trying to decrease the rupture rate. The problem is we need the coils at the beginning, but actually we don't need that's a burden. The coils are a burden after we're done with the aneurysm, say 6 months later, when the risk of rupture is minimal. Delayed rupture is minimal. So I said, there's got to be a temporary solution for that. And the whole thing about the balloon that brought it to my mind was that it is a temporary measure. Now, again, having said that, I think there's a symbiotic relation between a balloon and a flow diverter. That whenever the balloon fails, which is later or in the subacute period, the flow diverter takes over. And as I told you, in the meantime, it is occupying volume. So whatever metalloproteinase theory there is, it is decreasing that rupture risk. And again, we thought, and in this very limited handful of cases, that it would also help block the inflow of the aneurysm, because one of another theory, I think Grunwald was talking about it, is that the jet into the aneurysm that is partially blocked is causing the rupture. So we thought, okay, this might be a good solution, and the gadget was already over there and very cheap.
And can I ask you another question?
Go ahead, please.
In the first case that you showed, where you put a surpass, you put a balloon, and then you put an atlas through the surpass, which is one of the benefits of surpass. Why did you put the atlas in?
We use stents in flow diverters very liberally, not for these cases only, for better apposition. We have, in terms of surpass atlas, you saw only, I think, 1 or 2 in this presentation, but we have 25 cases already. The outcome, angiographic outcome, is very good. Actually, it is one out of 25 patients has in 6 months residual aneurysm, and that was partially unopposed. Now, having said that, surpass is infamous about full apposition, as you know, so we do it more in surpass, but we are doing it more and more for others as well. Say Derivo, we use a neuroform stent with Derivo very liberally, perhaps in 1/3 to 40% of patients.
So you are putting a flow diverter and then you put a
stent
inside that. It's interesting concept.
So if you look in the literature, no, not in Turkey. Not in Turkey. Yeah, so okay, so if you look in the literature, there are several papers, including preclinical papers, talking about wall apposition. So you may think that the apposition of the stent to the wall is good, even if you do a vaso-CT or dyna-CT, but they're not. So what we have seen as we did that, number one, we had problems with the fish mouthing. That doesn't occur. And number two, the results are better. We first started off doing that to prevent fish mouthing, and then realized that actually the aneurysms were occluded much better. So we are liberal in it. I'm not saying you should put stents in all flow diverters.
But there is a special stent, there is special flow diverters that need it more from your point of view?
I would think so, yes.
What?
It's the Surpass I told you.
This means that the device is not good. So
just a minute. What is a good device?
If you said that the device not oppose the wall correctly, this means that it doesn't fit to the wall. This means there is some technical problem with the device. So you are going now and putting another device in the device to improve it. I understand exactly what you do. René's doing it with balloon. René, every stent that is deployed, you go inside and inflate the balloon to oppose the stent in the wall. This is why you explained it, and it's correct from this point of view. The same idea. So what we are doing now, we are putting two devices in the same artery. We are putting a lot of metal, which I don't understand. How does it not cause thrombosis, and how does the vessel do not occlude more? It surprised me because, you know, if you are speaking about Surpass, it's a lot of metal inside, and this is
let me do some corrections. In Surpass, the metal is not more. It's exactly the same. It's about 35% wall coverage. The problem with the Surpass is that the wall apposition in our hands is not as good. On the other hand, its pore density is higher. So its mesh is tighter despite the same wall coverage. Now, I'm surprised that you guys didn't ask me, but nobody asked me about the squid. So I use Surpass specifically in those cases because I thought for the balloons, it is, once you open it up, it's more sturdier, it won't give away. For the squid, you know, I thought there's a risk of distal migration. In the aneurysm, I'm using regular squid. Tell me about your experience.
No,
I mean, how comfortable would you guys be injecting squid in an aneurysm?
You know, one of our friend Jack was doing a lot with onyx for many years, and then stopped.
But that's a different onyx.
I know, it's not so different. Squid, it's 12 or 18. It's a matter of the organization of material. It's not so different. I'm sorry, I will speak about AVM. It's not a revolution. It's some changes in the amount of the MSO, in the size of the tantalum, in the organization of the materials. It's not. I don't speak about it because I'm not sure. It could be that we are going to face again the idea of putting squid, onyx, or something.
Or even glue.
With a flow diversion. Not what Moray was doing with coronary stent, which have very big pore and maybe not the right one. So this I also think about it. I'm not sure that we can do it so easy. We'll have to find a way to explain why we are doing it, because it's not a real usual treatment. We will have to check it. But this is the idea that I accept, and this is why I didn't ask you, because it's for me. It's no doubt about will be one of the future treatment.
I'm surprised that you guys are against the balloon, but not against squid. I would think squid is much more dangerous to do than the balloon.
I'm not against the balloon. I think that only few people in the world now know to use balloon. If you go and check how many people know to use balloon and to go from the carotid artery to internal into the peak home, I think that there is few people still in the world that know to use balloon. Few.
I think I didn't get it right. We are not against balloon. I'm just trying to understand so that, you have a different idea, you brought a different concept, and we're just trying to understand the concept. Squid, I don't know, again, it's something different. You would not be allowed in UK to inject because at the moment there is no real evidence to do that. So I work in a very different environment than the environment probably you work in. So we are limited in what we can do, but it's a nice concept. I mean, maybe like what Shimon is saying, in 10 years we may be doing something completely different. The only question I wanted to ask you, you said you have a lot of experience in Surpass, right?
Well, some experience, yes.
Yeah. My experience with Surpass is a very difficult stent to get up, and we have now a lot of better stents that we can track up. My experience Surpass opens well. If you can get it up there, it opens well. The fish mouthing is a problem, but you say that you find wall opposition a problem? Because that's not my experience has been. I probably have done about 25 Surpass.
Okay, so I have 3 comments. Now, first, your questions are coming with a comment embedded in them, so I'll try to address both the comment and the question. First of all, about the environment, I would think that you can do the same thing as I do, because those are all approved devices. There is no unapproved device in the presentation you have seen. It's just a matter of being stupid enough or courageous enough or lucky enough or just choosing the good patient. It may be all of them that we have done. The second issue was that, you said there are better devices. Well, that was the comment embedded in the question, but I don't know what are better devices because the Surpass, I use 3 kind of flow diverters: Silk, Surpass, and Derivo recently. Now the Surpass comes with drawbacks and pluses. The plus with the Surpass is that it has a high mesh density, and it enables, we have seen it, and others have seen it, and others have shown it and written about it. It means better occlusion rates. Now, the downside is that it is stiff. That's no secret. Now, this was a second comment. And for the question, well, it's not only our experience, but it's only the experience of, it's also the experience of Dr. Macho. And I think you were in that meeting, that he showed a bunch of unopposed stents, especially with the larger diameters, that there is a tendency for fish mouthing. But that doesn't mean that it's a bad device. We have to play around to make it even better. I choose it because in the balloon cases that I have done, I look at the case, I say, can I get a Surpass up there? If I can, I'll use a Surpass. If not, I'll use a Silk or a Derivo. That it is sturdier, and I'm thinking that I can pull the balloon more confidently on the stent. In the squid cases, I've used it because the higher mesh density, I'm scared of the agent flying away, so that's why I used it.
Did you have a balloon inside as well? When you were injecting squid, I think you had a balloon, right? Inside the stent.
For the CC fistula, that I didn't show it, it was too long. I didn't have a balloon. I didn't need it because the flow was distal. But for the others, yes, I had a balloon. And as a matter of fact, just to give you a small hint, if I may, that I do the DMSO and washing and everything without the balloon inflated, because I don't want to inject with the balloon inflated in the aneurysm. And actually, you may kind of do partial wall coverage, that you may inflate the balloon distal, a little bit distal in the aneurysm, so that it won't fly, forward. But in the meantime, it will have some space for the DMSO to get out at the bottom.
Thank you.
Marcus was having a question.
Stent or flow diverter. I think of course there's some physical differences, but to my opinion, every stent can get some fish mouthing. It's more dependent where your landing positions are, distal on land. So if you have a change of caliber, kind of close to the end of the stand, it's more likely to happen. And if the vessel changes directions where you end the stand. So for me, to avoid fish mauling, the best tool would be kind of having a proper range of lengths of stands available so that you can do precise planning about your landing.
Yeah. As a matter of fact, I'm going to wake Nicholas up. Hello, Nicholas. As far as I remember, you guys did to prevent fish mouthing, the outward flare. Fish mouthing is, to my knowledge, inherent defect of the braided stand technology. So there is no one stand that doesn't have it. You know, I've seen it in Silk, I've seen it in Derivo, I have seen it in Surpass, and I have seen reports of pipelines doing it. I don't know about Fred, perhaps it's different. Yes. Which comes inherent too, especially at the siphon, as he's saying. So we published on your stand the tapered, but even the tapered wants to do that every now and then.
Anil, did you made the sequential imaging after balloon during few days or few weeks to see how quick the balloon disinflate?
So it's a handful of cases, but the first case I show you, I have a 3-day CT angiogram before discharge. The balloon didn't deflate. At 1.5 months, it was partially deflated. Then I showed you one case with the lady, the 20 millimeter supraclinoid. No, the gentleman, it was the gentleman, I'm sorry, the giant supraclinoid. Because of the contralateral side, there were aneurysms and it was ruptured. We didn't know which one, probably this one had ruptured, but so we treated the small aneurysms in, I think, in a couple days, 5 days, 4 days. That balloon had deflated a little more. And then one balloon took about 4 months to deflate, as far as I remember. The one I didn't show you, it was on the list.
So there is a big, a wide range of variation.
Because that's very interesting to me and to you guys. But did you notice something different in terms of speed of thrombosis inside the aneurysm? Because the balloon is made of latex, which is a very highly thrombogenic material. So it disappears with time, indeed, but it should theoretically, and I don't know if you've seen that, create a more fast thrombosis inside the remaining part of the circulating part of the aneurysm.
Well, the answer is yes. I didn't think about that, but yes. I showed you the results, and actually the aneurysms thrombosed quite fast, actually. Now my question is it because some of them were treated with Surpass? I don't know. Or is it because there were stents in them? I don't know.
I meant compared to your usual observation of stented or flow diverted.
Yeah, it was faster. It was definitely faster. I showed you in the slides with the cases.
Последний доклад перед обедом мой, поэтому.
The last presentation before lunchtime. This is my presentation. That's why I will try to be quick. First of all, I would like to thank Major Salauch and the organizational committee for the possibility to take the floor at such a venue. I would like to share the experience of treating complex UC aneurysms with a bypass. What should be done is if there is no flow diverter or the vessel does not fit for the situation. I think that the majority of you do know that complex aneurysms are very complex things. We are gonna deal with carotid artery, with gigantic, and with well. Uh, with clots inside the vessels. Everybody knows what could happen if these aneurysms are not treated. Before I start dealing with this problem, we studied some literature, reviewed some literature, and there were all data, new data, which also speak about high rate of complications. Of course, in recent days, well, flow diverging stents play a very important role, and the analysis of gigantic aneurysms shows that they make up 22%. In 08016, we had 26 patients with UC treated with combination of methods using bypass and ligation. They were the treatment lasted for 15 months. Clinical manifestation included headache, rupture, different kind of function violation, and the majority of them were cavernous. Probably the distribution between the location were was approximately the same. Bypass and this simple vessel ligation was you see approximately like that. BCA made up 17 and the rest were much less. Singular anastomosis, 19, double anastomosis in one case, and high flow anastomosis in 6 cases. In 23 cases, we deployed anastomosis in advance, and in some cases we had to do emergent anastomosis. So based on our moderate experience, what should be done? And you have angiography, then and you do not know any other device. How can you evaluate the blood flow if there are anterior and posterior connection? I use vessels like M1, M2. If there is no a delay of the phase, no elevation or compression of some elements during you see balloon. If it is a cavernous section, you can do whatever. In the vascular, you may ligate it. If it is a parasuper section, there is a risk of blood will you see insurge into the aneurysm. We have to take into account M1 to M2, the delay of the venous phase, and then if the balloon test is passed, you may use either endovascular procedure. If the balloon doesn't go, that means that you have to switch out anastomosis. After that, you may use any procedure. If the collateral is missing, if we have to use only one, you see, you see, one circulation, then we can use only one procedure. If not, then any other procedure. So if it is a gigantic aneurysm of the left carotid artery, after we have checked collaterally, it turned out that there is neither the anterior nor posterior UC arteries. That's why we decided that we have to use the to use the circulation, overlapping circulation. Well, the gigantic aneurysms, well, partially thrombolized. The blood circulation is compromised, and the patient complained of the vision problem. That's why we installed anastomosis and occlusion of the carotid artery. This is in 2 years. Now, one more example. Why we wanted to give you this example, because there are cases mentioned in the literature when the stroke problems emerge after the even after the patients pass the balloon-based tests. We also have used anastomosis, protection anastomosis. These are control images before, well, in 2 years after the surgery, and then 3 years. So you can see the considerable reduction of aneurysm, well, of cavernous section. You see here the left hemisphere is based on the only carotid artery covers the anterior and the middle carotid artery sections. So we have to try not to occlude the, oh well, you see, the artery. There is no purified area. Well, our protective decision was bypass and FD. Before the surgery, this is the bypass. Bypass was deployed, and we installed the flow diverter. The logic issue: why we need bypass then flow diverter? Well, if I have a case in future, I will show. This is bifurcation aneurysm, a young patient. This is one of our first experience with aplasia. No lateral bilateral blood flow. I want to mention that this is our early experience in treating such patients. That's why, well, having very sad experience, we decided to deploy bypass and flow diverter. This is how the double bypass looks like. This is the control image in 5 years. I want to mention here that the distance of the stent is quite right. There is no hyperdysplasia, and at the same time, this bypass is working. The next patient, again, no collateral. So after the balloon test and after compression, what we see, we decided given that we have to cover 2 well, circulations, we decided to use bypass. And if you see, there are no problems, technical problems after the deployment of the flow diverter. In 6 months, we observed the stent thrombosis, but the anastomosis saved the patient. But she herself mentioned that she well, observed all the fulfilled all the prescriptions. She took Plavix and etc., but it didn't save her. So we had to interfere again. In this case, we deploy anastomosis. Why? Because after test, based on the test, balloon test, we found out that she failed, and now, that's why we had to use anastomosis. And you see well, you see spiral the coils in the aneurysm. This is the patient that arrived with huge, gigantic aneurysm. She has passed through the standard balloon test, and we decided to get the vessel in 6 hours. We observed imperasis, and that's why we have deployed bypass on the left. After the deficit has regressed, and this is the angiogram after anastomosis.
After 6 years, we see that bypass is functioning. The patient has a normal lifestyle, enjoying her life, partially thrombosis of a giant aneurysm. So the patient undergo balloon test. After legging, we see neurological deficiency, lack of circulation. Post factum, anatomically, we see that there is hypoplasia A1 if we compare with contralateral part, and we thought that perhaps this was the reason for the lack of circulation. We have a urgent anastomosis, and the patient, after 4 years, anastomosis does exist, and aneurysm is not contrasted. Our results: occlusion of 96% of aneurysm. In one case, there was the outer arteria. The regress of neurology is 80%, and early anastomosis occlusion was 7.5%. We had no mortality. Complications were 11%. So the strategy of treating such aneurysms is proposed, but this should be not only isolated surgically, but there should be multidisciplinary team. So the occlusion of a current vessel without bypass is an effective method for complex aneurysma that cannot be clipped directly or treated endovascularly. The combined approach allows to decrease complication rate and mortality, and despite of the complications, despite of the development of endovascular technique, bypass is one of the effective options to treat this pathology. Thank you so much for your attention.
No, occlusion is 7.5. Yes, this is the occlusion of bypass. Thank you very much. I think this is time for dinner.
Раз, 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 раз. Раз, два, три, раз, два, три. Раз, два, три, четыре, пять, пять. Раз, два, три. Раз, два, три, четыре, пять. Раз, 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 раз. Раз, два, три, четыре, пять. Пять, шесть, семь, восемь. Пять, шесть, семь, восемь. Раз, два, три. Ты знаешь, где там добавляется? Раз, 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 раз. Раз, два, три, четыре, пять, шесть, семь. Раз, два, три, четыре, пять. Пять, шесть. Пять, шесть. Нормально. Сможешь там подняться, добавить? Спасибо. Раз, раз, раз. Раз, 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 раз. А? Пойдет? Раз, два, три, четыре, пять. Что-то колонка как-то. Раз, два, три. Раз, раз, два, три, четыре, пять. Раз, два, три, четыре, пять. Раз, два, три, четыре, пять. Раз, раз, раз.
Слышно нас? Слышно, да? Следующий у нас пациент, какой год был? 50 лет, вот, перенесла паренхематозное кровоизлияние из артерии венозной мальформации.
The next patient, 50 years old, she has surgery back in '94. With parenchymatose aneurysm, she has problems with headaches. She takes painkillers. She had MRI and it revealed arteriovenous malformation. Before that, they did carotid angiography. It was back in 1994, and it was then when malformation was confirmed. We performed diagnostic angiography and also detected arteriovenous malformation that is filled in from the posterior and medial artery. Also, the median artery on the right, there is the AFD, aneurysm due to AFD. I believe that you do see the picture. Do you have the picture? Our plan to catheterize posterior cerebral and medium cerebral artery. We will deploy two catheter into the medium cerebral artery and one in the posterior cerebral artery. We will check the venous, you see, outflow. If there is only one venous outflow, then we will make a decision on one stage occlusion of arterial malformation. If there is a risk of early venous occlusion, we have devised a hyperglide balloon, and in case of necessity, we'll inflate it. The only question, which artery should it be deployed? We have prepared two conductors, microconductors from the balloon expedient, and a Chekai conductor. Chekai 8, number 8. We have confused them in terms of the location. Because the torque of both the conductors is the same. So everything was okay. This is in order to improve your mood after the lunch, or to bring up your inspiration. If you pay attention to the table, then on the right you can see a catheter vestibular 8 French vestibular type. And as you know, we like this wire connector configuration when we will arrange them like you see under certain angle, as you see them. This allows us to use 3 devices at the same time, not to waste or to lose any fluid alongside this micro device. So we have devised hyperlight, and this is just in case. In the posterior circulation, we will use a microcomputer Sonic, a Sonic 1.5, well, the length 25. This is our personal feeling, but we believe that in case of Onyx 34 use, Sonic 1.5 behaves like micro catheter. Sonic 1 and 2, when using a thicker onyx, may close up. But this is our personal feeling, and you may not agree with it. Okay, we will start. I see that from the medial cerebral artery and from the posterior cerebral artery, we can see very well you see in the proximal segment, and we can control aneurysm. We apologize for our device. Its stack slows down from time to time. Inside the Sonic microcatheter, there is a microconductor hybrid. It is included into the set, into the complex of that device. Microcatheter Apollo is combined with hybrid 008. We do not use any heparin while embolizing the venous malformation, but in our wash-through system, we have hematop inside the 8 French catheter. We started using after we familiarized with the experience of Professor Shepard back in 012, and beginning with 012 we use hematop. And we started using big catheters. After the visit to Essen City, where the professor works. So we navigate the posterior cerebral artery. Basal artery. Half of it has a different color because there is a contralateral cerebral artery. If you do not want to enter the artery, into the vertebral artery, you always get exactly where you don't want it. We will deploy it here for the start. Then we'll take the side projection in order to know exactly where we are. So we have gone, we actually passed through aneurysm. Unfortunately, our system is monoplane, and that's why our navigation in case of artery malformations is somewhat difficult. So mark that the microconductor Chekai compared to microconductor Nirash keeps its form for a longer period of time, and when you deploy it into the distal vessels, it doesn't lose its shape or change its shape. The same could be said about hybrid conductor. And the upper part of the malformation is being filled in. The vein that goes upwards. Shall we see the more proximal part? So the vein is filled in. The vein going downwards is filled in. In other words, we have two veins. One drains the sagittal sinus, and the second vein that drains cross-section sinus. Now we are going to install to deploy the second catheter apolar. Pull the conductor slightly back. The inconvenience of the system is that each time you have to change the position of the system. We are in no position to use smart mask. With other systems and with smart mask possibility, we use these smart masks to navigate, and we do not change, if we do not change the position of the instrument, or we do not change the position of the head, that smart mask may change roadmap very well. And to some extent it's even better. But unfortunately, all the things are inaccessible to us or unaffordable to us. We are interested in the branch which goes downwards. This is the posterior part of the malformation. Yes, the branch is separate a bit earlier. it diverges a bit earlier. You see how, to what extent the Chikai is manageable in this UC system, in this situation. I believe that we can do an injection.
This branch feels lower part. It's possible laterally. Now we will check the posterior circulation. The upper branch, which goes to the visceral, it's collateral. There are a lot of cerebral normal tissue. The lower branch should most probably go to the malformation. Now we will compare the general image and what we have done from the microcatheter. We have a small branch which goes to towards malformation. We will make a catheter there, catheterize there. Hybrid. In this point we have this theta branch. We need to change the tube.
You need to change the angulation of the microwire.
I'm not sure whether you can see the thin microconductor, but you can see it on the screen. Two Apollo, which we have chosen, it's 3 centimeters in distal part. And Sonic is 2.5 centimeters. As soon as we have changed the angle of the tip point of the tip, so this branch we should enter. Although no, this is lateral. Perhaps this is a collateral branch. Perhaps I'm mistaken. Yes, this is collateral branch. We will try to use the inferior branch, the lower branch. Sometimes the camera does not show the device, but we are getting used to this. Now you can see very clearly two microconductors in the body. This branch fills fistula, if I understand correctly, and it goes to the lower part of the drainage vein. Right now 3 microcatheters have been installed.
Now we need to decide which part of the area would be first occluded. I think this part.
This is the lower catheter. Now we will check this. Sonic is in place, stands good. Now we need to change where to place this branch or that branch. This is collateral branch. It looks like these are different parts of ultravenous malformation. We need to move distally. We have a referent image. It's quite far, but microconductor is still being managed, can be controlled. This is not the main branch. But in any case, we will try to pass it. So we will have this for control. I believe from the superior branch, we will choose the inferior. We will come to the inferior. Although these two branches, they go toward, they merge at one point. So we will go higher. will go upper. So let's use hybrid and see how it behaves in this anatomy. We have a reference image and we see where is our tool is located. This is a smaller branch. We will choose a bigger branch. There is a small angle. This branch continues further. So let's look at the direct projection. This is the superior. This is middle. And that is the posterior cerebral artery. This part. This part. And that part. We have a very diffusal malformation. A question to my colleagues. Do we need to go a little bit further in front, to go ahead? Is it possible here? Here? Most probably we should go here. Here probably no. Probably the very lower, the very first branch. Here we will go to the malformation.
Any other comment? Okay. From this we also have this branch for the control. for the case of unexpected event. And from this branch, we will start fill. Okay, let's go.
So let us start. Most probably not all microcatheters will be used to introduce embolizer. We will start from the top.
This branch looks like compared from the lower division of that bifurcation. Так, давай Оникс там быстрее. Оникс.
We will start from the posterior cerebral artery. We will introduce Onyx 34. Then, depending on the circumstances, we will make a decision whether we'll be using squid at a later stage or not. Or is it enough to close the fistulas? Dexamethasone, 12 milligram.
I think that we are on time, 20 minutes more, and probably we will finish if everything goes well.
Аласар squid. Bir fil dash koyasınız.
Fil açayım mı?
Evet.
Onun orada?
Evet.
Fil de Allah'ın ismini yapacak. Ben ötümü bırakıyorum.
He said it doesn't, you're not saying it.
Oh?
It looks like there are some other branch going in parallel.
is injection from the vertebral. Вот видно, что нижняя часть.
We can see that the low part is not filled in, and that's why collateral branches are remaining. We can control using microcatheter the situation in the lower part, lower section. It's still filled in. Squid 12. Squid 12. This is the drainage vein.
Looks like arterial collision. Squid. Если посмотреть,
If to look properly, then onyx and squid, they change slightly. Squid is blacker or darker. And it has its own specific odor. smell. I compared this other with the French cheese commander. It reminds me the other the commander cheese, but the secret of this other smelled only Nichols knows.
It looks like connecting part with the arteries from behind. We will do control. No stagnation. Напряжение в моем шприце самое минимальное. Я не надавливаю на шприц. И это шприц специально от сквида, из набора сквида. Вот. По ощущениям он очень сильно отличается от шприца, который идет в комплекте с Сониксом. Вот. Скорее всего, это дренажная вена. It looks like draining vein.
Most probably this is the drainage vein.
And now we will start with fill in upper branch. Мы начнем вводить фил. Фил достаточно долго не был в Казахстане, ну, больше полугода, наверное. Я ловлю. Фил. Фил, уникабар. Уникабар, фил. И учитывая, что пациентка уже имеет гемианопсию,
given that the patient already has hymenexia and taking into account the feeling characteristics, I think that this point of feeling is the most optimal.
I see. Micronation changed the syringe. Yes, tip of the syringe is different than before. We need to be continue with squid to prevent stacking. Sometimes it looks like bleeding, rupture. It looks like rupture in that vessel. We will stop with sonic, and now we will continue with upper Apollo. And now squid is coming. Fill is coming. Still the reflux. We will retrieve this. Okay, we will retrieve sonic. Okay, we'll leave it more. No problem. We have 5 minutes more before start presentations. Мы видим, как фил идет вперед.
We see how the feeling goes on. The reflux is over. Maybe it's just a small reflux is still there. Let's try to change feel for squid. So the sonic is separated now. No, it's not. Еще не отделился.
Как скрипали? Да, у нас есть небольшой рефлюкс.
Here we have a small reflux. I think we can continue. So we close the proximal branch with the malformation. Now we'll have to wait. Let's see the lower part. I think that the lower microcatheter is not the main one. That's why we can put it into the deploy it into the middle middle of the above artery. Yes, we have reflux, we have some time, or we can replace the micro catheter into the middle branch that goes up from here. So we have a roadmap. Well, that is arranged as microcatheter. And somewhere there should be the branch, that branch. Okay, let's see where we are, how far we have reached. But before that, we have to decide some issue.
Okay, I'm taking you extra 5 or 6 minutes. So sorry. It's a big branch. Подожди. Микрокатетер. I will have reflex. Okay. We can see this result. Now we will use 100 for destabilization. Any any comments from auditorium? Dr. Maimon? Or Hyrule? Hyrule, do you have any comment? Ah, we are going somewhere inside the Onyx, inside the squid. Okay, like this. Okay, no progression. Ah, now it's okay. Too distant. Okay. Let's see where we are. Demaso. It looks like we are close to the draining vein. Still reflex. Okay. Do we need to take Apollo a little bit back, or it's okay? Там в колонках что-нибудь слышно? В колонках...
Do you hear anything in the speakers? Do people comment?
I think we need to take Apollo a little bit back.
Dear
Like this, I
Majalenka.
think it's okay.
Dear Majalenka. Majalenka, do you hear me?
Onyx 34.
Majalenka, do you hear me?
34.
No, it doesn't hear me. Majalenka?
There is a big onyx cast, and I'm scared to couldn't see any material.
Majalenka.
34. 34. Демосол.
34, Demosol.
I think the upper branch is not full. Okay, we will start this third branch and we'll change to the presentations. Mix. Do you have any questions? I think it's a reflux. It's a reflux. Oh.
Вы нас слышите? Do you hear us?
We'll stop with upper branch and we'll continue with lower branch. I think another 3-4 minute injection because reflux is coming. And please, Asselbeck, could you ask next presenter to start the presentation because I take your time, 12 minutes. Okay, see you in the auditorium. I will take upper Apollo. Okay.
Pointer.
This next.
Yes, next. This is good. Malaysia, yeah.
Следующая презентация. Хайрул Азми из Малайзии.
Presentation is Hairul Azmi from Malaysia, dissecting cerebral aneurysm treatment. Добрый день, большое спасибо, что пригласили меня на ваше совещание. Я думаю, что Нейроаддикт очень важное мероприятие для всего мира, особенно для практиков из стран, которые могут встретиться с практиками мирового класса и обсудить самые трудные случаи, поделиться новыми методами в лечении эндоваскулярной аневризмы и эндоваскулярных лизий в мозге. Я говорю о диссекции в этой 30-минутной лекции. Я из Куала-Лумпура. Это вот мой госпиталь в Куала-Лумпур, который был основан в 60-х годах. Сейчас у нас уже большой комплекс на 1015 коек. Итак, диссекция аневризма – это внезапное пережим артериальной стенки с последующим приливом циркулирующей крови, которая может вызвать ишемию, ишемический цитроз, а также вызвать разрыв и кровотечение и соответствующие симптомы. И если аневризма не разорвана, то выводится компрессия. Здесь вы видите классическая анатомия сосуда. Вот здесь при дисрапции происходит сужение сосудов, стенки сосудов, и происходит разрыв. Вот эта диссекция вызывает эту проблему, и тогда вся часть этого сосуда может быть подвержена заболеванию, и что усложняет лечение. Есть некоторые факторы, есть внешние и внутренние факторы или различные дефекты внутри механизмов. Есть повышенное давление, курение, это воспалительное заболевание, генетическое предрасположение, фибромускулярная дисплазия. И понимая эти факторы, мы можем сократить риски при лечении пациента, и мы можем лечить пациента консервативно для того, чтобы снизить риск и факторы риска. Что касается лечения, мы можем говорить о разорвавшихся аневризмах и не разорвавшихся, для того, чтобы избежать повторного кровотечения. У нас есть много инструментов. Все, что у нас есть на рынке, делает эту процедуру более легкой. Тем не менее, при внезапном кровотечении у нас есть модальность до 50%, есть смертность до 50%, заболеваемость. Да. И есть у нас определенное руководство по лечению. Вот эта корейская команда опубликовала протокол лечения, которым мы можем поделиться, не разорвавшихся аневризм. В случае, если мы лечим по клиническим симптомам, и здесь они показывают, что если у более 15 лет продолжительность жизни, и если размер аневризма более 5 миллиметров, и когда не разорвавшаяся аневризма становится симптоматической, и мы увеличиваем размер, и если происходит внезапное кровотечение, в аневризме увеличивается размер, меняется морфология, и пациенты, которые менее 50 лет, у них много сопутствующих заболеваний. И другой критерий – это то, что есть высокое соотношение высоты к ширине шейки. И пациенты также нужно учитывать, у которых есть депрессия если у них был разрыв аневризмы. Мы можем лечить эндоваскулярно, хирургически или медицинским путем. По разобравшимся аневризмам, особенно при диссекции, нам нужно избежать повторного кровотечения. И, конечно, когда у пациента мы проводим диссекцию аневризмы, и она разрывается, мы постараемся сохранить сосуд, используя стенд. И нам нужно дать пациенту тракостомию в процессе восстановления. Иногда у нас есть такие простые моменты, когда мы можем использовать разные методы. И в каждой стране есть хорошие универсальные системы, которые следует использовать. Например, в данном случае есть дистальная М2 аневризма, ее диссекция, которая очень сложно сохранить здесь сосуд, поэтому мы используем окклюзию родительской артерии. Можно здесь использовать клей, либо другую жидкость для того, чтобы этот сегмент изолировать. И что я хочу показать, нам нужно помнить, что некоторые случаи, когда пациенты с такой плохой степени и при диссекции разорвавшейся аневризмы, здесь происходит спазм, и пациент в плохом состоянии, он может иметь проблемы с коагуляцией. И здесь можно использовать простой...
Because the vessel is distal to the pica, and also we cannot really can preserve this vessel. Even though we managed to occlude the aneurysm, and actually there's a good crossover flow from the right pica, but the patient is not doing very well. Patient died after a few weeks because of ARDS, owing the rupture of aneurysm. Again, we have two cases, up and lower. This patient presented with dissecting distal M2 segment and M3 segment. They have presented with, it's not really a sinus hemorrhage, they present with parenchymal hemorrhage. So the simple thing, we difficult to establish whether there's a good balloon occlusion test, but we hope there's got good peer and peer collateral in this case. Yes, we managed to deploy the coil this part, and you can see there's no significant infarct in this patient because this is the coil area. Because maybe there's good peer and peer collateral, especially at the peripheral vessel. On the lower part, we can see almost the same, but this is more peripheral, presented also with parenchymal bleed. This is not mycotic. We occlude, but you can see there's infarct, but there's no significant neurological deficit in this patient. Again, we have two different cases and two different techniques. We have on top, we have a dissecting aneurysm at the petrous part. Even though this extracranial, but when you do CT and MR, you can see that the higher part, the dome of the aneurysm, actually already compressing, eroding into the middle temporal lobe. And the patient have very severe headache, and we decide to do treatment. And we do balloon occlusion test with EEG monitoring. There's a good crossover, and we use a detachable balloon for this patient. Another patient who have dissecting aneurysm in the distal, in the cavernous segment, but you can see here they have ophthalmoplegia, painful eyes, and if difficult to navigate this vessel for reconstructing, being with the vessel very narrow, we do balloon occlusion test. In balloon occlusion test in my practice, I always after 15 minutes occlusion with the balloon, we will try to drop the blood pressure, about 30% of the systolic blood pressure. But this patient, we can't manage to drop the blood pressure because because start ECG changes of the heart. So we managed to detach the balloon. However, during recovery in the observation treatment, the patient suddenly developed a heart attack, and the blood pressure dropped, and the consequences is patient have MCA infarct, and patient die of this infarct, even though we after decompression craniotomy. So now we have revitalized treatment. We have stent to help in order to preserve the vessel. It's important for us to try to preserve the vessel rather than just maybe gambling whether this patient need to be occluded the vessel, and the patient, and also we make feel very happy to have this less. We can preserve the vessel. It's our aim. We try to don't occlude the vessel unnecessary. But of course, we have some issue of this thromboembolic, but now it's less. But we still have kind of risk factor, about 7-8% of complication doing all these things. The symptom can be like just compression to the brainstem, and we just can deploy across the aneurysm. We no need to put any stent or not put any coil. Sorry. So on follow up, you can see the reconstruction of the vessel. Another thing we have to remember that the dissecting aneurysm, they can also heal spontaneously. We have an example for this case, but sorry. They have dissecting aneurysm of the ICA. You can see here presented with intraventricular hemorrhage and hydrocephalus. It's very difficult to reconstruct this vessel, to put stent and everything. But this is actually the diagnostic angiogram. In this case, we don't do case at on the same sitting. And we decided to call the patient the next day for the treatment. And you can see there is a complete thrombosis. I'm very happy for not doing anything, but if you see clearly here, actually this part is not secure. And after 1 week, the patient rebleed again. I think this is a rupture. It's not completely thrombosed. However, I have another case that I follow up already now. From 2006 until now is 2017, is this young man presented with lobulated dissecting distal left SCA aneurysm with tinnitus. He is a very bright student. During that time, presentation just like tinnitus, there is no bleed. We decided to follow up this patient because we are worried about this young, highly potential artist have developed neurological deficit from the procedure. And you can see over the time, the aneurysm is getting smaller without doing anything. For me, the risk of the patient developing bleed is much less compared to occlusion. But if the body adapts slowly with this kind of thing, they can have a good collateral. So in life, we must understand that not doing anything, we also can be a part of the treatment modalities. This is example of the dissection. Features we can have flap, and this patient presented with stroke. Again, this patient we don't stand, we treat medically, and the vessel open up in the follow-up. In conclusion, for dissecting intracranial aneurysm, it's important to how to treat this aneurysm is the same. We prevent the bleeding. Whether we can preserve the vessel or we need to occlude is depending how the patient be able to cope with the occlusion. If the small distal vessel occlusion is no problem to have a periatrial occlusion. If you have to make a major vessel, make sure they have good evaluation like below occlusion test, and maybe you have to discuss your neurosurgical patient for the bypass, and Another thing, when dealing with unruptured, we must have that kind of criteria in evaluation of the patient, whether this need to be treated or untreated, and discuss the patient, what is the risk, and use the toy wisely. Don't treat image, treat patient. Thank you very much.
Any questions, comment?
Carol, hi. You know the case that you showed where there was the pica aneurysm which had bled, and then you did an angiogram the next day and it was not seen, but that stub of that vessel was still abnormal. Do you think now retrospectively you should have just gone there and closed that segment, because you have that patient had a subarach and that potentially was risk that that could bleed? Do you think now, if you think back, you would have gone and closed that segment? Or I don't know what Shimon thinks. Uday? I think if you have a subarach and it's a dissecting aneurysm, you've got to get it sorted because it's not going to go away on its own. That's my opinion. I don't know. What do you think?
I agree with Tufa. So it's easy to know looking backwards, but it was not too close to the brainstem. So going distally and sacrificing the final segment would have been maybe the safest.
Dr. Maiman, no questions? Yes, thank you. Следующая презентация из России, доктор.
Next presentation, Dr. Ivaz Ishvadze, Russian. We also would like to express gratitude to Dr. Ivaz Kadze for the procedure. Dear organizer, I would like to thank the participants of the forum for a very interesting conference, and I would like to share our results and keyhole UC axis. We are going to talk about supra and transorbital keyhole axis. I'm sorry in advance because we will see very many pictures, and I will talk standing with my back with you. This methodology is not new. It was started somewhere in the previous century. The key people wrote in 1937, the first surgery regarding aneurysm. But pay attention to the fact that each of this stage and the follow-up stages, when was heavy and off with craniotomy for different pathologies, but the methods of diagnostics were are not pretty much advanced, and there was no possibility to use state-of-the-art instruments and microscopes. And what's more important, during the last century, keyhole access is very much promoted, and it is very well formulated. We can operate with the use of small craniotomy with small access. The concomitant damage is minimized. This concept has been developed a number of years ago. and it implies creating a certain corridor for our patients. How are we to treat our patients? We have to reduce the number of days in the hospital. We have to reduce the number of associated complications, and we have to ensure the satisfaction of the patients. That's why the goal of minimal invasive surgery is the best cosmetic effect, reduction of blood loss, and minimizing all those side effects that I mentioned here. And what's most important, we are not only to reduce trauma of soft tissue, but minimize the trauma of brain, which is very often the case of refractory traumas. Well, for example, when crossing the temple muscle during craniotomy, this is the atrophy, a scar formation, well, damage to the forage branch, and the poor, you see, quality of life of these patients may dramatically reduce. Not in all the cases, but we have the possibility to minimize these traumas. Well, we are not to say that surgery is indicated for all the patients, but supraorbital trans, you see, cranial, well, keyhole access to surgery. It starts through, you see, adequate brain relaxation. We need to get access for resection. We need to be able to use the entire plane for resection. Sometimes we may see such bulging brain and understand that in this situation it's a little bit difficult to work, but after some relaxation we have more space for manipulation with micro instruments. Then we use the dynamic restriction of brain tissue. Given that surgery itself is, in terms of time, is shorter than traditional access, drainage is not used. After the reconstruction, you see how this bone looks like. Pre-operational planning is very important. What you're planning to do? What would be the bone anatomy? What would be the done with the aneurysm? What could be the hemorrhage? We have to plan very thoroughly everything, and any bone structures that we may see should be immediately planned for resection, but extradural things or intradural should be well, decided later on. So the classical keyhole is used here. Well, it is important to have access to supraorbital nerve and use the skin flap of about 2 centimeters. We can use a dissection, well, cross well, the skin resection, cross-cutaneous resection, and the surgeon pulls apart the margins because the craniotomy will not allow us to operate either aneurysm or whatever. So this access takes 10-12 minutes depending upon the individual anatomy, bone anatomy, and the necessity to use more aggressive resection of bone structures. This is the aneurysm of the middle segment. Well, the lateral part is more affected, so we relax brain, and in case there is a necessity to open up the terminal part of the third ventricle, we do all this. We open up all these sections. So this is done in order to ensure proximal control. Over
At this point, when the aneurysm, the AVM was filled from the lower branch in MCA. This is a draining vein. This is two branches which was occluded. And then we continued. This is a site from the PCA, the collateral cortical pile supply. And we continued to inject a squid in combination with film. And now you can see we get to the lower branch. Onyx get to the lower branch. Squid get to the lower branch and fill the pile supply. And then we went to the vein. At the time we went to the vein, we placed our balloon, hyperglide, which was prepared before. You can see the expedion in P2, P3. We inflated balloon and then continued to inject the onyx, the squid. And now you can see we occluded totally the AVM. Now there is no supply, there is no filling of the draining vein. We did control angiography from MCA and from vertebral basilar also. There is no AVM. Okay. The aneurysm still here, but the flow will change, and hope aneurysm will disappear. And in one case, we showed the experience of squid, onyx, fill combination, Apollo and sonic experience, and also the role of the balloon assistance in such kind of multi-feeder brain AVM. Thank you so much. I will join you in 5 minutes in the auditorium. Thank you.
Да, коллеги, продолжаем. Colleagues, let us continue. If we look through keyhole access using conventional surgical technique, and the view from microscope is identical, and it's quite important because the whole concept, although the trepanation window is less, the concept is the same. The aneurysma, there is a conventional access. There is the neck is visualized, and there is dissection of the proximal departments. There was a eye-moving nerve aneurysm and clipping aneurysm with a subsequent control using ICG, which makes surgery easier, and it allows to control the aneurysm occlusion and proximal. You see how much the brain is relaxed. Also, we do keyhole access in certain situation in the early or ultra early period after the hemorrhage, and all the acute hemorrhage tasks could be performed if we select the patient right, if he is in compensated state, if it's an early surgery while there are no angiosperm and the brain swelling. Here we can relax the brain. We use A2 segment for clipping, for the neck aneurysm. Dissection and aneurysm is
blocked, and we do additional control using ICG, and we can visualize adequate clipping, and A2 segment is not stigmatized. So using certain skills, this surgery is used more widely. It's the same situation, we just have a more focused access. We can use proximal control, we can clip and reposition clips. The only reason could be unveiled, so we have a small bleeding here, small hemorrhage, small blood flow. So we have the same possibilities as during conventional access. So that's why some are asking, how can you do something through the keyhole access? So the sac is opened, and there is the neck modeling, and extra clips are removed. Keyhole access planning. On this slide, you can see how you can plan a small craniotomy. You have proximal, distal control, arachnoidal dissection, and drainage of spinal cerebral liquid fluid. There is a conventional technique, and that's I will just fast forward the video to save time. So what can you provide as a media material, and during the acute period, the terminal is opened, terminal plate is opened, one is set on a dura, and there is enough space to visualize the neck, to put the clips, and to achieve all the objectives of a surgical intervention. There are clips, additional ICG control. Aneurysm is out of the blood. This is supraorbital craniotomy. The patients believe the results are perfect. There could be some complications if there are some failures. Transorbital access. You see transillar, palpebral is using the upper. This is minio-orbitozygomatic craniotomy. There is a flap, and that expands the surgical window. You can operate deeper at difficult to access lesions. The assistant is helping. I will fast forward, and then we are breaking there, and then there is access. There is a resection of the. You should be very cautious about the orbital tissue, sacrotal anatomical aneurysm. It's behind the dura, but if we change the attack by microscope angle, we see the performing artery. So all of the conventional surgery tasks could be performed, could be achieved here. So if this is aneurysm without rupture, we use more aggressive access. We use endoscoping assistancy to plan clipping. This video starts from the extradural resection of the front dural, and that carotid triangle helps to visualize the artery we see the lateral eye moving nerve. And this is localized by 2 clips with ICG control. So we are comparing this to conventional craniosacectomy. The giant aneurysms, in some cases we use transorbital axis with A2 trifurcation, the same technique, brain relaxation, accessing aneurysm and aneurysm without rupture, and subsequent clipping with clips reposition, controlling the perforating arteria, controlling A2 segments. And of course it's very important. I'm not saying that we should do keyhole access for all. The keyhole access possibility could be always could be only achieved after having skills of conventional access, but in some situations when the patients are selected in the right way, this could be achieved. So it's very important to have an adequate selection of patients with right anatomic conditions, that there should be no brain swelling, and all these details are quite important. ICG control, we visualize aneurysm, transorbital. We have no conflict with supraorbital nerve and distal branches of a facial nerve. The functional cosmetic effect is superb. If the patients after supraorbital they have some complaints, here the patients they recover very fast. There is an upper wall of the orbit. We're very gentle about this orbital, the brow section. We should be very cautious about the soft tissues, very accurate, and then that wall is broken, and craniotomy is ready. The access, this is patient with aneurysm. We first plan before the patient is in the operation theater. There is a natural fold of the skin at the brow level, and the key point, we are dissecting the dura more than a week after hemorrhage. And we are using the same technique, nothing new, dissection of that hole using the arteries, dissection of neck departments, clipping of aneurysm by mini clips. And in this situation it's enough to use, it's quite important to adequately select patients. It cannot be recommended to all patients. This is post-operative effect. You see clips with minimal craniotomy and effect after transorbital access. Patients were pictured during different time, but if we compare this to conventional surgery, we have less trauma for the patients. We visualize bifurcation of main artery. Aneurysm is contains in the dura. We do endoscopic control. Subsequent endoscopic control, one more clip, and the neck is glued with keyhole. Disadvantages is less lightening of that area. This can be resolved by choosing right patients. interoperation risks I cannot show because usually we manage, but here there was a mistake. There is distal clips, proximal clips is removed, and during that we had an interoperative hemorrhage. But since it's conventional technique, we have proximal control. We can manage the situation and do repositioning or additional clipping. So if what happens during interoperational rupture? You were using aspirator and temporal clipping. The unruptured aneurysm, it's a compensated stage, at least 100 operations. Intracerebral hypertension. As we assess our results, we see that keyhole surgery could be of use while employing other conventional methods. What kind of emphasis are? It allows to focus on the operation goal. We are saving time for access, could be successfully used for unruptured and for subarachidal SAH, and it allows for fast recovery. However, we have to prove that it's superior to conventional surgery. We now need to optimize the indications for keyhole access surgery and treatment. Any questions, comments? Next presentation is also from Russia. Vitaly Kiselov, endovascular treatment of aneurysm with flow diverting devices.
I understand that you are tight. I will be so quickly. I have a small presentation. I don't know how better to read it. I think I will read it in Russia, but everything you will see in English inside the slides, inside the text. In Novosibirsk, in Federal Neurosurgical Center. I am a neurosurgeon. This is our team for physicians. So let's start.
Endovascular coiling. One of the disadvantages is that radical endovascular operation is lower than micro clipping, and the new devices is to increase radicality and not to so this is not a stent, but this is a stent-like devices, flow diverters, which are used in the endovascular treatment of aneurysm. Conceptually, flow diverters allow changing of the flow inside of the aneurysm, which leads to lower recanalization. So that's why there are two basic principles in aneurysm treatment. The first principle is based on the change of flow inside of the aneurysm and creating conditions, favorable conditions for aneurysm thrombing and covering and endothelization of stent at the aneurysm neck, which leads to its lower recanalization by the materials which we use. Let me share our materials for 2016 at our department. We have operated 64 patients. Why we used only 2016? It's because before 2016 in Russia we could use only two stents, silk and pipeline. Now we have a new stent, Fred, and we can use all flow diverters which were registered, and unfortunately now we don't have the experience of distal results. We can only share our first impressions. The women were mostly dominant. For average age is 60. Localization for flow diverters, this is internal carotid artery, and we did not use aneurysm for flow diverters while treating bifurcation aneurysm. As for the size, most aneurysms were less than 15 millimeters. The large and giant aneurysms were only a third of our observations. Main manifestation was headaches, unruptured aneurysms. We also had some hemorrhage and ischemic aneurysms and cranial. One of the last conditions which we used was evaluation of patients' MRS before treatment, so that we could compare how well our treatment undergo. So most patients were in good grade, only 3 patients were in poor grade. The stents, most of them were pipeline, and the same number of silk and thread stents. The technical characteristics: pipeline stent is a cobalt chromium stent, which has 65-70% mesh, and it's available for 2.5 millimeters diameters. And as a flow diverter, it is compacted 2.5 times, and it has 27-inch inner diameter. That's the diameter. So that's the external picture. Cobalt chrome can visualize the diverter. We can see it very well. The mesh is quite thick, and there are some clinical results. It's a large aneurysm setting the flow diverter of pipeline, and control angiography. There is no contrast for this aneurysm.
One more example, carinose aneurysm. Also, the pipeline has been implanted. It's 6-month control. This aneurysm is not contrasted. Technical characteristics of silk. This is a stent that is characterized by less penetration, formation. It basically is used with the catheter Vasca 21 with adequate size, and silk as usual is set is placed through its own catheter that goes in one pack with the stent, and the stent opening is 95%. Externally, it differs from the pipeline because it has the nitinol structure. There are oval fibers. that could be contrasted at their X-ray, but they are not quite visible at their rentgenoscopy. That's why additional threads are needed. This is example with the use of silk stent. These forms of aneurysm, internal carotid artery, and the communicating section of the internal carotid artery. So silk stent was implanted into aneurysm, and after we switched off the communicating section simultaneously with spirals. You see, aneurysm is not contrasted in 6 months. Why we had to operate? Well, one of the clinical manifestations was transitory ischemic, you see, attacks and strokes of the middle cerebral artery. They repeat threat we started using widely now, in my opinion. It is one of the simplest in terms of implantation stents. In the slide, you can see its structure: double combined stent, which is equipped with assisting part and also FD part. It is presented in different sizes, maximum diameter 5 millimeters. It could be reimplanted, it could be assembled, and one of the minuses of thread implantation is more complex microcatheter you see use after its thread implantation, because it somehow gets stacked with the internal components of the stent, but it could be resolved. We can you see push a little bit its wall. Visually, it looks like that. This is the assisting part of the stent, and this is the FD part of the stent, and we can see it like that: assisting part 3 millimeters, and then FD part of the stent. It makes it possible to more firmly fix in the distal part, and the stent in the true minimal stent displacement. This is one of the example of thread stent dissecting aneurysm in vertebral artery. You see how the stent is implanted. This is mark assisting part, and it covers aneurysm completely. You can see the contrasting contrast very clearly in this part. And in 6 months, we see that aneurysm is not completely contrasted. What are the indications that we found as of today? And there are no clear indications in the literature when the FD stents should be used. However, we have identified key indicators for ourselves when we use FD stents. First of all, this is the multiple lesion of the one segment when we have 2, 3, or 4 aneurysm on the one and the same segment. These you see the ophthalmic segment of aneurysm. In this case, we have to use you see this kind of stent. Gigantic aneurysm create very dangerous effect. That's why it could be closed with the use of FD stents. The you see the breaking, if the breaking early aneurysm could be also treated with the help of this methodology. If there is a certain Raman 2 degree, we can insert spiral inside the aneurysm. Is not possible, then we can use this method. All the patients can get clopidogrel prior to surgery in the space of 5 days, then aspirin 100 milligrams for 5 days before procedures and 12 months after procedure. We do control tests for thrombocytes, platelet aggregation. If there is an indication for Plavix, then we prescribe ticagrelor 180 milligrams or to or change to clopidogrel. If the arteries are direct, we use the Shipiron catheter 6F microvention company. In case we have some viral sort of we have the you see waving artery, then we use different catheter. This is one of the examples within the system of we give much attention to proximal support. That's why before implanting stent, you see the wavy shape of the carotid artery. The catheter is deployed very high, Fargamax. It goes very well through this. You see through these coils, and you can see it very well in the bifurcation area. You can see the middle cerebral artery. This is the aneurysm in the area of bifurcation. Here you can see a cysteine stent. Initially, a cysteine stent with micro coils, a bit lower or below this fork. This is the combination of microspiral with the AFD stent. You see the stagnation of contrasting diaphragm, and the control angiography in 6 months shows that the aneurysm is not contrasted, but all the trunk vessels are quite good. It's better to use more time for you see establishing coaxial system rather than to have problems with the stent during its installation. What were the difference in FD during implantation? We do not open you see pipeline before implantation. New construction of pipeline does not make it possible. There are plastic you see steps here that which risk the closure of stent inside the catheter. They are open outside the you see the patient, we wash them through with heparin, and only after that they take upwards shortening of the distal part. We saw very rarely such things. We normally would pull the stent downwards and then would open up. But we very often saw the shortening of proximal part in silk and very rarely in thread. Twisting, stent twisting was no. Only Fred didn't twist, but the rest of the stents twisted in certain conditions. For pipelines, it was specific. In the area of carotid, you see ophthalmic segment and silk in the area of the front cerebral artery, which was straightened up during balloon implantation. The result We used only FD stent, and very rarely we used with microspirals with the coils. It was rare. When assessing the results in 6 months, we have assessed 58% of patients. Among them, we've got such indicates in 6 months after stent implantation. The Fred stents had the best results. Maybe that was due to a very small group, because we have only started implanting pipeline, had very high results, and Silk had the highest results. What tactics do we use if we see feeling of the aneurysm? First of all, the patient stops taking clopidogrel. Then we do control angiography in 3 months. After the exchange of disaggregant therapy, we see the feeling of aneurysm in the same volume. Then we deploy the second FD, and if we see the reduction of the feeling after the challenge of disaggregated therapy, and so the aneurysm is filled in less and less, we wait for 3 more months and then do angiography in 3 months. We do not implant stent until we see that the process is checked, and until we see the adequate thrombolysis of the stent. We analyzed the time of the surgery. In case we didn't have any technical problems, then the length of the surgery made up from 40 to 60 minutes. That was adequate time for the you see, deployment of FD stent. If we had problems, and the problems were related to twisting, to atherosclerosis, to complexity of navigating the conducted, we identified a certain group of any aneurysm based on the time of the surgery, because all the surgeries have been performed, practically speaking, by the same people. That's why we could actually say that the time of surgery was an effective indicator. What were the complications? There were 3 cases. First, it was a hemorrhage, SAH hemorrhage, when we tried to go through the A1 segment during approach, and in 2 cases ischemic complications. In one, it was thrombosis of the stent. In the second, thrombosis of the perforated arteries. For us, at this point of time, this is the most complex topic from all the topics, because we refuse from treatment. Today, if we are able to separate the carotid artery into 3 parts, we may say that we can treat distal part, proximal part, and we even can come all the way to the place of detachment of arteries. But as far as the middle part of artery is concerned, then all the treatment results are very poor. But sometimes we do want to help the patients, and we you see took this case. This is the complication, thrombosis perforated arteries. We have deployed 3 stents. We see the margins of the first, the second, and the third stent with the contralateral occlusion of the vertebral artery. With the follow-up, preservation of the blood flow, the patient will rehabilitate first. in 4 hours the patient developed tetraplegia, and the patient was treated quite long. He was released in very severe condition, but if we compare the results before and after the surgery, then in this group we didn't have any worsening of the situation, a very small change in the patients that had some neurological deficit prior to the surgery. Another example, aneurysm is a little below. We can manage very complex aneurysm. Here you can see that a low posterior brain part, where we used the stent. I think that each surgeon has some results that are good in this series, but as of today, the results that we've got specifically, the share of the hectic aneurysms show that the frequency of complication is very high, and lethality, decent lethality may reach 60–70%. That's why today this issue is not resolved. As a conclusion, I can say that regardless the complication, the use of FD stents is very effective method of treatment. Our experience shows that in many instances the frequency of severe complications depends on the experience of the surgeons. So, well, as for the surgery for the main artery stem, how to do the surgery, we didn't find an answer so far. Thank you for your attention.
Any questions?
Спасибо за интересный доклад. Я хотел узнать...
Thank you for a very interesting presentation. I wanted to find out, in what case you have to combine with the coils, FD stent with the coils. Thank you very much for your question. This is a very interesting question.
Coils with flow diverters. And one of our colleague, my friend Charbel Manaye, one time told me that he analyzed all publications in literature, and bleeding he met only in cases where the size of aneurysm was more than 20 millimeters. And so his decision was to put coils in all aneurysm which size more than 20 millimeters. We didn't use this rule in our work. How I showed you, in the most cases, we use only flow diverters, and we had a good result, and have good result. So I don't know in what cases we need to use coils. Of course, in acute stage, if you want to treat aneurysm with flow diverters, I think coils will be a good decision. So, but when you treat unruptured aneurysm, I don't know where it's correct to use coils. But we need to remember that today flow diverters is the last step in the treatment of aneurysm, because you couldn't put more coils inside the aneurysm if you use the flow diverter. So you may put just only the second flow diverter inside the stent which you deployed before. So maybe maybe if you're afraid that this aneurysm can fill in, after flow diverter you need to use coils. But it's opinion of each surgeon. So I think so.
Спасибо за хороший доклад.
Thank you very much for a very good presentation. Tell me, please, you give much attention in your presentation to pipelines. Basically, they are used in case of gigantic aneurysms. I have a question. In your clinic, you use a bypass, yeah, right? And what are the indications? Well, the use of bypass, well, in complex with other things like FD. Thank you for your question.
There are no indications for using flow diverters. And this is right, because we may use flow diverters in many cases. Today, together with our colleagues from the Mishalkin Institute in Novosibirsk, we start a new program to compare high flow anastomosis and flow diverters. Because if you go to guideline, if you go to the different literature, you never find a compare between these two methods. So nobody tried to compare it. For today, it's only my opinion. Flow diverters is easy. It's more easy procedure than high flow anastomosis. I think the rate of complication, if we have excellent surgeon, I think the rate of complication may be the same with flow diverters. If the indication to take the patient for high flow anastomosis were correct. So if, but today my opinion that all giant aneurysm of cavernous of ICA, I think whole ICA, it's indication for flow diverters because the mean time is 30-40 minutes. It's very simple, it's very easy, it's very high rate of occlusion, it's very low rate of recanalization. You may use coils and your rate of recanalization will be lower than if you will use the flow diverter alone. So I think it's more simple procedure. And when we did some master classes, so and we did a procedure with high flow anastomosis, we didn't find any indication to treat a patient with high flow anastomosis. I think it will be maybe 2-3% of population who will have indication for high flow anastomosis, but I'm not sure. I'm not sure that it's right, and in my mind, I prefer flow diverters. Maybe somebody have another opinion. So.
Thank you. One more question, please. Спасибо. Next speech about using web device in the treatment of aneurysms, Dr. Marcos.
We started 5 years ago using only a few cases a year. With increasing confidence, it's now a permanent tool in our portfolio. We implanted now in total more than 100 web devices. And I have to say that the predominant use of the web device in our use is in acute cases. I think now, if I look today, it's about 80% of the web we use in acute cases and only 20% in elective cases. So why to use an intrasaccular device with these wide neck bifurcation aneurysms? There's quite a big range of bifurcation tools now available. There's P-Conus, P-Canvas from like baffle cone stand. Then there would be Contour, is a web-like device, not yet available. The Pulse Rider is also bifurcation covering device. And well, we've seen this morning a lot of remodeling tools. So then go just skip the videos and present it from that one. No, something happening? You still have the presentation on that one? So the videos didn't work on the other computer, so that's why I tried the MacBook. That doesn't work at all, so we switched back to the other presentation computer. Sorry about that. So now you see also an image of the web. Yeah, I just skipped through my sequence. This I told already. And so I think in classical bifurcation aneurysm, the web targets the pathology. I'm not talking about dysplastic vessels, but about classic bifurcation aneurysm. Delivery and deployment, to our experience, is fast and safe. It enables to treat ruptured wide-necked aneurysms without need for dual antiplatelets. And still you're not put on a one-way road like if you place a flow diverter across an aneurysm. You have still all tools available, for rescue or additional treatments. So complication management is like in conventional coiling or balloon remodeling. And you can even retrieve the device after the detachment if you need to. Long-term expectation, the device is not prone to compaction like coils. There we experience some little disappointment. If the web is undersized, it can actually compact. The device is less prone to migration into thrombus and partial thrombosed aneurysms. And while there was a presentation from Joe Bhattacharya, and he said the web is not suitable for partial thrombosed aneurysms. I don't share this opinion. I think there's no ideal tool for partially thrombosed aneurysms, but still the web, to my opinion, is a better option for those aneurysms. Yeah, growing evidence, and the device is further developed. So for the small sizes now is even a 17 catheter available for deployment. Yeah, the bigger sizes you still have to use a 27 microcatheter, and the biggest one you need a 33 catheter. But with triaxial access, usually it's not a problem. The most appealing thing for the web device, it can cover a bifurcation, even a wide neck, and you don't need to pass the aneurysm in difficult maneuvers. You just follow the blood into the aneurysm. So these have been the techniques alternatively presented this morning already in extent. These are the other devices, Pulse Rider, Eclipse, mentioned extrasaccular devices. Trispan was an intrasaccular bifurcation device or a wide neck device. Medina RTs just started, is not yet available. The next stent. I think where we have to be aware of in the placement of a VAP is the VAP, depending on the proper sizing, you have this configuration, a little bit more oversized, more lateral compression, you might get that the recessus is not conforming, or you get a deep recessus. All three of the options are not an issue. This is just appearing differently in the imaging. Yeah, so I think this is image cosmetic. As long as you have a result like that, you're quite fine. I think the recessus problem is just in very big aneurysms, for example, basilar tip. Here in the AP view, it looks like a perfect occlusion. In the lateral view, however, so when the artery widens, there remain two corners on each side of this below the VAP, which still belong to the neck of the aneurysm, which can be addressed by balloon remodeling or stent remodeling in a better way, because the coils go also down into that recessus. The intrinsic stability of the VAP is increased by lateral compression, so the VAP has a radial force, but it's not a strong radial force, and if you just make it fit to the aneurysm without that it has a good apposition to the lateral wall with some compression, then it might compact over time. The initial result might look fine, so you have to make sure that your diameter of the VAP is 1 meter larger than the measured diameter of the aneurysm, and thus you have a good compression of the device and make it stable in the long term. In doubt, sometimes you find yourself in sizing, is this size or is the next size? It is always better to choose the bigger size, because the bigger size is also easier retrievable because it didn't form the recessus yet. But this is only side mark. Two web devices. I started with two web devices not because I thought it's fancy, but because this is basilar tip aneurysm with a straightforward access. The geometry is not too difficult, and the plan was there, and I had a competent proctor at my side who helped me. So I got the experience putting two webs. You see this is a dual layer, the earlier version, and good flow retention, but wouldn't advise that in the first place. And in total I placed 5 webs to get this result. The first one was no problem, and the lower one had to be exchanged twice too big, once too small, and the final one fitted. So we should have done, after placement of the first VAP device, we should have done a second 3D run to get a proper measurement and not just guessing what would be the next size. This is the result after the treatment. 10 minutes after detachment, we had a complete flow disruption. You might get the impression that there's maybe a narrowing here at the origin of the left P1. That's why we kept the patient on dual antiplatelets just for safety reasons. There was never an issue. The flow was always good and not delayed in this territory. And the 6 months follow-up image shows just the same. No inflow, no recurrency. And this is a 12 months follow-up where we did an MR. However, MR usually looks better than reality. Because of the proximal marker of the VAP gives an artifact which doesn't allow you to really assess the 2 millimeters around the proximal marker. So MR wouldn't allow to detect a minor recurrency or neck remnant here. This is one partial thrombosed huge aneurysm at the proximal M2 branch coming out. And we decided to place a VAP device here. I was very happy about the initial result. I placed the VAP here, immediate flow arrest, but I didn't pay attention here. If you follow that in the late arterial phase here, there's like a slight rim of contrast going around the VAP. And so 6 months follow-up, it almost looks unchanged. So the VAP went deeper in here. This is the proximal part of the VAP. This is the dynasty, after which you see the huge aneurysm with calcified wall. And we placed a second VAP. The next recannulation was less. The patient is in her 70s. She's fine. The outer diameters of the aneurysm didn't change, so there's no further treatment planned. This is another partial thrombosed aneurysm, just to give you a different outcome using the web. This is a 68-year-old female, at least at the time point of rupture. This was this basal tip aneurysm, a small SCA aneurysm too. Coiling was performed using a solitaire stand in a waffle cone fashion with a reasonable good result, we thought. A big recurrency after 1 year. You see the space occupying effect here in the brainstem, in the mesencephalon. And so we took the measurements. This is just the inflow zone on the 3D. And here you see stepwise the deployment of the web. Here there are the 3 markers of the previous placed solitaire stands, which served then as a waffle cone stand for the coils. Now we place the web on top of those, and so the final run shows almost complete flow disruption, a flow contrast retention. If you go back here, you see, the oversizing of the web gives so much compression that creating the recessus is unnaturally deep, but the aneurysm itself is covered. So this is just filling of the recessus with contrast. You see the web contours here around, so there's no contact of blood or contrast with the aneurysm wall. The 15 months follow-up, if you take a look at the MR, there's a decrease in size. We have to admit there's a growing recessus here, but after 31 months, the size of the aneurysm decreased further on, and this woman is now also above her 70s without any clinical symptoms or other problems. She won't be retreated. We also stopped the follow-up. You can implant the web also in kind of oblique shapes, yeah. So when, here you could expect if you move a catheter up this way and deploy a web that the web might take another position. So right from the beginning I was worried that the web wouldn't sit correctly, and that was actually the case. And so I resheeted the web, placed the already prepared balloon into the left P1, inflated the balloon, and with the inflated balloon I blocked that angle for the web, and finally the web could be deployed. And also here we had a good post-procedural result with contrast retention and almost complete flow disruption. Here it's all looked quite straightforward. Also this looks straightforward, and probably everybody would say, why do a web in this case? Yeah, so you're right, definitely. And I was wrong with the sizing too. I put a web device which was too big. I couldn't get it in. I didn't notice anything. Usually I take a balloon just in case up as well. So I didn't even inflate the balloon. I made a new roadmap and found that the contrast outside of in the subordinate space. But I had the SLS4 already on the way up then. And so I think these are the videos not working, so you have to believe me, there was no further hemorrhage. Yeah, there's some slight bulging of the web proximal into the parent vessel, which I rather have it this way than accepting the neck remnant. And we gave aspirin afterwards. This is the position of the web here. This was the initial SAH, very little. This was the dynacity after the procedure where the perforation occurred, and this is the CT scan 24 hours afterwards. Unfavorable angle, so the videos don't work, but there's an image here of carotid T aneurysm with a pseudoaneurysm. The patient has also a hematoma here around the corner, and the angle of the carotid artery going in is a little bit unfortunate. So, and because of the angle, and I had to use a 27 catheter, the 27 didn't follow the microwire without force. I didn't want to use force, so I had to use the balloon. This is a 6 months follow-up of the patient who fortunately recovered completely, also from an interparenchymal hematoma, and the carotid T is nicely remodeled here without recurrency. Can also have less common locations here. This was a Hunter has 3 bleeding and a superior cerebellar aneurysm, and I was thinking that I probably would have problems to completely occlude it only with balloon remodeling. I didn't want to use a stent, at least I want to avoid it in the acute setting. And I measured it for VAP, however the proper size would have been 1 millimeter less in height. This was gone, so I tried to fix it in with help of a balloon still, but that didn't work. I have to show you. There's another picture later on. Without the videos, it doesn't work properly. So this was the initial result after deployment of the VAP in the SCA with the recessus here at the origin of the right SCA. However, the VAP itself bulges here in the basilar tip and narrows the P1 segment, or the origin of the P1 segment significantly. At the moment there was no flow problem, but with a Hunter Head 3 patient I was worried that would cause a problem, so reluctantly I finally placed Elvis Jr. stand and placed an extra coil into that recessus. Without the narrowing and without the stand I wouldn't have coiled that recessus in the acute setting. This is 6 months follow-up, but she has a clear Doppler remnant here, but if this stays this size, we wouldn't go for retreatment here. Distal pica aneurysm, this is not a typical location for the aneurysm, but that angle of that pica and the size looks quite feasible for that location, and remodeling of that pica aneurysm with this weird angle and or low profile stand would have been difficult. Yeah, come. Further. The video is loading. Can you skip that? This is not working anyway. Well, I had problems actually with the 27 catheter, following the 14 wire, and I placed the 16 wire, and then I had a smooth movement of the microcatheter into the center of the aneurysm and could deploy a VAP without problems. Maybe skip the, go this here. So this is the 3D of the VAP after deployment. Also here, immediate flow disruption, and this is a 6 months follow-up with good MRS here. This is, you see the proximal recessus of the VAP, no refilling of the aneurysm. A ruptured ACOM here as with a little bit multilobular shape here. In total you find like 3 small lobules and a bleb here in the thing, but the base of the aneurysm has a more suitable geometry. If you disregard the irregular tip, you can place a VAP here inside, and this is placement. So this is the 3D run after deployment. You see still some inflow into the device, but the aneurysm itself is not filling anymore. This is quite common finding sometimes that there's a remaining inflow initially into the aneurysm, but the inflow is only restricted to the device itself and doesn't have a direct contact anymore with the aneurysm wall. This is a follow-up also without a recurrency. It's not that we don't have recurrencies, yeah, so I think we have at least something like 10% recurrencies. And this is other follow-up here with a bit more device. This was a more challenging case, serious subnode hemorrhage, and the patient has bilateral occluded internal carotid arteries. So the brain supply only runs via this artery, and there's a dysplastic basilar tip with this aneurysm, a huge pseudoaneurysm here. The neck relatively wide. You could have called that also with balloon remodeling and coils in the same way, but this was pretty straightforward, moving just the web inside here, detaching it, and no long manipulations and no balloon occlusion. This is the only brain supplying vessel. Acute SCA aneurysms, this is also an uncommon location. This is the 3D is not perfect. You see it's not filled completely. The app which comes with, which you can download free, is usually quite well for sizing. This time it doesn't work because the webs are not, you don't get them higher than wide. So in this case I decided not 1 millimeter above the width, but 2 millimeter above the width with the SLS 6, and also got here a nice, fast, successful result. A different use of the web. This is an aneurysm which is too big for a web device. This is 13 millimeter. Yeah, you should have a web which is 14 millimeter to get enough lateral compression to fill that. But the other problem is this branching vessel is coming out of the sac. So if I put in a balloon here, I can't cover the neck, protect the neck when I put in coils here through my microcatheter. So in this situation, I used the biggest SLS web I had and pulled in, after jailing in a microcatheter here, deployed the web. Then I pulled the web back, so the web was with one edge lying in front of that branch, deployed the first coils, so that here there was a proper coil frame, and then I moved the web back, just give it a slight push, and this way was blocked for the other coils, could fill the rest, and had this result. The pseudoaneurysm lab is not filling anymore. Here you see still some minor contrast filling of the web device into the aneurysm. But the branch here of the superior cerebellar artery is patent. Yeah, that's another aneurysm, but incidental. The weird shaped, wide neck, kind of a strong pica here, and I thought, how should I treat this aneurysm? So I had different scenarios. Maybe you can place a web here, jailing a microcatheter before, and so preventing the web sliding upwards. Or I could come from the other side, place a stent across and just coil it. Or I could try balloon remodeling either this way, ipsilateral or contralateral going to the pica. And I was kind of fixated on this approach and did that, but it was not very funny. Retrospectively, I think the stent remodeling or balloon remodeling version would have been more straightforward, because so I could put in the web, but only with the balloon remodeling, otherwise it would slide down immediately. And deflating the balloon, the web came down immediately, and when so I decided to place this Elvis Jr. stand. Regarding the follow-up of 20 ruptured cases where we have consecutive cases with good follow-up, our results match in average the data from the webcast studies, but we have kind of 10% dog ears, and one patient lost to follow-up. I don't know if she rebled, but she was in a critical state. Initially she was transferred to a secondary hospital, still on ICU, and I was told she was diseased with their concomitant problems. But there's no proof that she didn't rebleed. Antiplatelet medication, there's unruptured elective cases. There's a proposal from Spell and Liebig where they you should pre-treat them with aspirin. Unruptured should have also, with complex wide necks, should have maybe clopidogrel, so you're also prepared for stenting. In ruptured cases, you shouldn't use aspirin. However, if I have the aneurysm treated and I have flow disruption, I give aspirin right afterwards to prevent any thrombus formation, even in ruptured cases. So this is just summed it up. So our standard treatment anyway, in all coiled aneurysms, they get aspirin for 2 months afterwards. We do the same with elective webs, yeah, and that is with the ruptured case, yeah. But if protrusion of the web into the parent vessel and flow disruption, you should definitely give at least 500 milligrams aspirin at the end of the procedure, yeah. I'm a fan of always using a long sheet, and with the web, especially the 27 and 33 size, you need to use a distal access catheter, I think. Depending on the complexity of the anatomy, I like to use the Navian or the Sophia. The Sophia is much more agile but less stable. So when you're used to bimanual technique deploying stent or web or coils, the Sophia moves much more, and so you need to readjust it much more often, yeah? I always rely on 3D measurements, cross-checking on 2D, adequate sizing. I mentioned that these 2 big devices are easier resheetable, so, but you shouldn't undersize, then you have a risk for recurrency. So if you're at the verge of deciding for the next size, then try the next size. Remodeling ballon is sometimes a quite helpful tool. Aspirin IV is recommended, especially when retention is showing. No procedural aspirin when no complete stasis in ruptured cases, yeah. In our experience, especially, and we see in the ruptured cases, more often the fast and immediate flow disruption, more than we see in elective cases, yeah. In 2 cases where I had a minor hemorrhage after during placement, the deployment of the web provided immediate stasis, so there was no further leakage of contrast to be seen and no hematoma development or serious submural hemorrhage. Deployment of the web SL and SLS using with the vias, they don't change too much the shape. The microcatheter tip lies stable inside the aneurysm, and there's no unexpected movements of the microcatheter tip when advancing the device inside the catheter. The same is when you deploy and advance the web to the aneurysm. EV stands for enhanced visibility. That was the change which was done to the web from the initial generation to get a better visibility. And this made me change my strategy to use it also in ruptured cases. So then I have a reliable visibility around the neck. Thank you for your attention.
Thank you. Questions, please?
Now it's 6:20. In minus 20 minutes, we had to go to the Galadine. I think Marcus and Tufail will discuss on the table with vodka. Yes. We have 2 more presentations. Еще 2 презентации. Предлагаем или продолжить, или на утро оставить. На ваше усмотрение. Но перед этим Туфайл.
Shall we continue, or shall we postpone the presentation for tomorrow? But Hill will. Shall we continue or what?
I had 4 cases with partially thrombosed aneurysm, which we have recently published in AJNR. 2 of them the web compacted, and both of them, the web was in the thrombus, and they both had a bleed. They were both, all four were unruptured. Two did very well, which had a baby Leo cross there, and maybe it was a baby Leo which was a cross, which made the difference. But the other two patients both presented with a bleed and died. So we have in our, I have done 65 plus webs. I have quite a few partially thrombosed aneurysm, but the two of the four which I published, two had a bleed. So I have two, I don't put now webs in partially thrombosed aneurysms unless I can cover the neck with a stent. So that's my own personal experience.
What's your cue about why did they bleed when the web has compacted? So then the web is not more like a compacted coil. Why would the web be responsible for the bleeding?
Both the cases, one of the cases the web he presented with a bleed, and the first web was right at the top. It had gone into the clot. And even the second one also she presented with a bleed, and again the web was literally far away. The aneurysm had recanalized, and it was oversized web on both of them. But
it occurred with the web, but donors is different than with flow diverters, where we change the flow and thrombus changes. So we know that if you put coils in, the coils migrate, you find them somewhere else.
Sure.
So I think it's premature to say that maybe the web is responsible for that these patients came in with a bleed. I think the crucial thing so that the web is maybe successful in partial trombosed aneurysm is if you manage to get a kind of circular endothelial connection around the neck so that it's really a plug, and then you disrupt the flow there. And maybe you should, I agree, supplementary stent treatment is quite good.
I think they made, probably because in partially thrombosed aneurysm, the clot can change, and even if you have put a big web, if the clot has changed and your inflow is not controlled, and maybe my inflow in those two aneurysms was not controlled, and that's why the web went in. It's possible, but I'm just saying that I had two cases where I have put web and reasonably big size webs. One was 11 and still caused a problem. So
good comment anyway, so I keep that in mind.
And the other thing I wanted to ask you this, because your practice has changed, hasn't it? You use more acute than elective cases. Why is that? I mean, why is the because when we started, we were doing a lot of elective cases.
So I think in the main reason is that I don't think I do less elective cases, but I do more ruptured cases because I can avoid stenting, even if I have to, in some situation, accept the neck remnant or so. But I have a fast, to my opinion, safe treatment with the immediate flow disruption without need for antiplatelets. In some wide neck aneurysm, before changing my strategy, I did more acute stenting in these wide neck aneurysms than I did now.
So you're webbing them more?
Not all, a lot.
It's not a question or a comment. This is, some of us have always been, like I have always been in a situation where new products come, we see them in conferences, we wait till we get our hands on them, and the products which are not worth it, they die before, and we don't get them. I'm intrigued by the fact that this has been going on for many, many years, and there isn't any real push to get the intrasaccular devices to all the world. So do you think that, I'm sure that you have good results and you have to present your good results because you believe in it, but why, it's just a general question, it's not only about web. Why hasn't it really caught on? Like, most of the other devices, there's a real push to get it worldwide.
Well, I think it's also a little bit to do with the size of the company. So now I'm kind of evaluating the 17 web. So, and to produce the 17 web, they have to stop the production of the 21 and the other big web devices because they're braiding machines. They don't have enough braiding machine yet. So now I think it's implanted are 4,000 webs or plus 4,000, but they're careful with going out into the world too much, because then they will just be confronted with back orders. And then, of course, it's a little bit, every country has different financial and health reimbursement regulations, so depending on how difficult the country market is, that might be another issue. The device is quite expensive. With what we pay about like 10,500 euro for one, but we only pay the implanted one. So if, like the first case, I use 5 to end up with 2 implanted, I only pay 2.
But that might change with microvention, because Sequent had an interest in getting the device, but microvention is now not necessary.
When microvention changes this policy, I won't implant webs anymore, I think, because it's important not to be happy with the suboptimal result, where we're prone to have a recurrency. When it's safe to retrieve the web and implant the better one, the physician shouldn't be forced because of financial issues to do that. If the company makes that, I won't implant web. So there are other bifurcation devices on all these other remodeling techniques. So then it's more a bailout device for me. So I wouldn't. So if for some reason it's the only device which can help the patient, of course I would use it. But I would get serious problems with microvention if they would behave that way.
I think microvention will get web in India soon, I think.
Следующая презентация Вера Ивановна.
The next presentation, Vera Ivanovna, St. Petersburg. So anesthesia in case of Good afternoon, dear colleagues. It's not quite the conclusion of our very interesting and very busy day. So the view on the you see the view of the aneurysm of you see cerebral anesthesia of you see vessels and the use of anesthesia, whether it is simple or complex. So I ask these questions because very often we hear from anesthesiologists that there is nothing complex, the same equipment, the same drugs. Well, they keep on saying that until it comes to practice. Without any exaggeration, I can say that success of any complex surgery, be that intracranial or endovascular, much depends upon the quality of anesthesia. And given that there are lots of specific features of anesthesia, the goal of anesthesia is to ensure blood-free intervention on cerebral vessels, and whether this is open or basal intervention, an anesthesiologist should know the anatomy of the surgery area and the practice that the surgeon is supposed to implement, and coordinate the surgery type with the surgeon. Anesthesia includes several components. Of course, this is a pre-surgery assessment of the patient condition, the volume of anesthesia and the immediate period, immediate after surgery period. failure to implement some of the procedures by the surgeon is impermissible. Pre-operational assessment, correct assessment of the severity of the patient from the practical, from the legal point of view is very important. And while evaluating a patient, a surgeon should evaluate two aspects. First of all, the severity of the cerebral ear and the severity of the patient himself. The severity of the patient may vary from moderate, this is 1 or 2 class, to severe and extremely severe condition. These are the patients of the 4th and 5th class, according to the Hess scale. Happily, these patients are really operated. There should be additional information available. This is the linear blood velocity, somatic status of the patients is characterized by the lesion of some organs and systems and development of specific syndromes, types of the type cerebral salt losing syndrome. Very often, some of them are functional nature. From respiratory system side, there could be aspirational pneumonia, which is very rare, neurogenic lung edema, which is a poor prognostic side, and very often these patients develop electrolyte you see problems, underestimated or wrongly evaluated information at this stage may result in a number of unwanted, you see, incidents during the surgery and immediately after surgery period. Apart from neurogenic lung edema, all these shifts are not contraindications for early surgical interventions. The premedication in patients could be used in acute period of, you see, SH, of class 1 and 2, and it should be based on respiratory functions.
Induction is one of the most difficult and most complicated issues because too deep anesthesia leads to depression of blood pressure, or superficial anesthesia may lead to aneurysm rupture, and that affects the quality of treatment. Most often the practical scheme is benzodiazepine plus hypnotic and narcotical analgesics. In our hospital, most patients are used premedication, fentanyl and propofol. The propofol to all patients is done by 20 milligrams until the entropy figures goes to 40, 60 in this range, and that allows us to hypotension during the anesthesia induction. To summarize what I have said, during the anesthesia induction, pressure reactions are not allowed because the main danger is aneurysm rupture, so analgesia should be adequate and medicamentosus sleep should be adequate. Depolarizing myorelaxants are not recommended. However, if an anesthesiologist is not experienced in intubation, what will be worse for the patient to have a long traumatical intubation attempt and hypoxia state. Invasion monitoring of blood pressure is recommended. There are no absolute recommendations for invasive blood pressure. However, if it's not stable patients, if vasoactive medications is used, hypertension, then invasive blood pressure is more is better, because you can see how much the figures could be changed if they are measured invasively and not invasively. And for some patients, the slowness in making a decision by anesthesian may lead to grievous results. All the pain stimulus should be blocked adequately, and if the narcotic analgesic has expired, there should be repeated analgesic injected prior to manipulation. As for the direct surgical intervention, the anesthesia there is different, and the methodology depends on the volume of planned intervention and on the state of patient and on the time of extubation, because droperidol may not allow us to extubate a patient after the end of the surgery due to the pharmacokinetics of droperidol. That's why the neurolepta analgesics are very rarely used now. Total intravenous anesthesia is mostly widely used, using propofol and analgesic. All the drugs should be injected by infusomatic to keep the target concentration of medication without leading to blood pressure changes. There should be some inhalation anesthesia using sevoflurane and desflurane if the patient does not have any signs of intracranial blood pressure increase. It's not metabolized by the body. It allows to reach the target concentration in the patient, and using pharmacokinetic, this can be used to wake the patient after the end of operative intervention. The inhalation anesthesia may provide for the dosage and control of anesthetics, and using automated control systems, this allows for more opportunities for the patients. Our clinic, to use anesthesia, we use anesthesia IASIS equipment, and auto control allows us to maintain automatically the concentration, and intraoperative monitoring is done by CareScape B650. Intraoperative monitoring for every patient is individual, and it depends on this amount of operative intervention and the state of the patient. But I believe that intraoperative monitoring should include assessment of all components of anesthesia, including a hypnotical component, analgesic component SPI, indicate a neuromuscular conductivity, and the control of anesthetics concentration with the hypnotic component allows us to use inhalation anesthetics at a minimal dosage, which is 0.607 Mac. Inhalation anesthetics in this concentration provides minimum influence on the intracranial pressure, according to the literature. While doing artificial hyperventilation, it is not used due to high risk of aneurysm rupture. At the end of anesthesia, the first and second class patients, if no contraindications, could be extubated after the end of the surgery. In all the other cases, the decision is made by the team depending on the clinical picture and volume of operative intervention. In the direct surgery, that's where the anesthesia can help a neurosurgeon. As for endovascular surgery, this is the surgery where the anesthesia must coordinate the type of anesthesia with the operating surgeon. The main objectives of anesthesia is to maintain stable physiological indicators and to provide the patient's immobility and hemodynamics, as well as acute therapy in complications. The anesthesiology support varies from sedation with spontaneous breathing to general anesthesia. The selection of anesthesia method is the same as in open surgery. In our clinics, we mostly use inhalation anesthesia because inhalation anesthesia allows us to wake all the patients in the surgery room without any reactions for intubation tube. Of course, while in the surgery room, the anesthesia should keep watch on the angiography data and know what to do in case of any catastrophe. Anesthesia in these kinds of interventions is regarded as a minor, but it requires the anesthesia to be vigilant. And summing up everything that we have said, whether anesthesia is easy or difficult, there is no such classification whether anesthesia is small or big. I believe that knowledge and experience, when you always master these skills, allows us to do from a complex anesthesia illusion of a simple anesthesia and allow the surgeon to do his work in comfort conditions without being distracted by the patient stage, because we always should remember that a team works in the surgical theater to achieve the goal. Thank you so much for your attention. This is our center in St. Petersburg. Any questions, comments?
Philips angiography systems in endovascular neurosurgery.
Добрый вечер. Я постараюсь.
Hello. I'll try to be brief, as gala dinner is in front of us, is upon us. I will talk about the Philips view of neurosurgery. I will browse through the slides. I will have lots of pictures. This is a wonderful surgery room. The same kind of surgery room I launched in Baku. Hybrid operational table. It allows to convert the RX surgery room into a conventional surgery room. Large monitors, 58 inches, without RX zooming. It allows to put the image on the screen, and 3D station and other monitors that you may need. But the only thing it lacks, it's quite a big detector. It doesn't have the second biplane tube. I believe that for neurosurgery there should be second tube, and Philips offers such a solution. Frontal 20 and 15 inches detectors, 16-bit detectors, and there is no liquid cooling, and makes the system more reliable. It has replaced the previous system when there were two large detectors. This was inconvenient. At this picture you can see that the lateral detector, side detector, may come directly to the head of the patient, not touching the shoulder and minimizing the radiation and dosage at the lateral view. There is also a large monitor, 8 pixels, and you will have the maximum resolution picture in front of you, and a neuro pillow, neuro headrest. Detectors could be different. This detector, 15 inches at the lateral view, is the best one. This is a neuro headrest. This allows to minimize artifacts of patient's movement. If the patient is not under anesthesia, it allows for the full immobilization of the patient. You can position it by height, you can set different angles, and it's a RX translucent headrest. This is as for the hardware, but as for the software, it's equally important. Philips has a lot of applications which have a neuro package, neuro suite for this application. You see there are different applications: 2D perfusion, 3D navigation, and CT-like tomography and aneurysm flow. 2D perfusion was invented for the perfusion assessment of a cerebral brain. The number of diffusion includes functions and morphology of the cerebral brain, and there are two brain hemispheres. Comparison before and after operation. One of the examples, using this method of 2D perfusion prior and after myotop insertion. This is time to peak. This can be evaluated at every zone. This is symmetrical area at two equal areas of patient before and after, and you can see the contrast area. This methodology could be used not only to assess the perfusion, but to localize different tumors while operating for the diabetic feet and leg or foot vessels. 3D navigation is it's quite good, but 3D navigation allows you online to reduce the RX radiation and the contrast liquid dosage. So a reliable picture can be used for surgical tools.
Мы тогда пропустим просто ее. Следующий слайд. Я понял. Что там вообще завис? Ага.
Now the video, one of the examples when 3D navigation allows to do diagnostic, to insert diagnostic or treatment tools. You can raise the patient, you can lower the patient. The image will move simultaneously, as it is linked to anatomic indicators, anatomic signs. The CT and MRI roadmap overlay allows to increase diagnostics and the time to decision, and minimize X-ray radiation and the contrast liquid inserted in the patient. Expect CT dual. It's another hardware software technology which allows to do CT-like image in angio. This is a rotational. Yeah. This is liver, but the technology is rotation is done in two directions. This allows to assess arterial phase and bronchiomatous phase later. This was invented for the liver, also is used for cranial or brain for operations. Based on this conical expect CT, another method was developed which uses extra resolution VASA CT, which allows to proximal vessels.
Thus, substituting the necessity of using CT during the surgery. It also allows to reserve stents, and the technology you suggest the choice depending upon the clinical condition of the contrast drug introduction, either intravenously or intraarterially. Let's keep that. Two methods, intravenous and intraarterial. Intravenous could be used for diagnostic, intraarterial could be used during surgery. And if you have a look at the dilution of the contrast for intraarterial injection is 90%. In fact, the contrast is not used actually. So the possibilities for of visualization of this method, you can see very well all the structures with good resolution. I'm just finishing one of the most latest devices method suggested by Philips. This is aneurysm flow method, which allows in the real-time mode to reflect the blood flow in aneurysm and in the feeding vessels. That makes it possible to change the blood flow after surgery and installation of FD, and it makes it possible to assess not only visually but in this very nice option that you can see, and then through qualitative analysis of the average blood flow Murphy coefficient that has been used in the global Philips centers all over the world, and this is how it is deciphered. Murphy coefficient is mean aneurysm flow amplitude. And this is how you see it. Three red 3D measurement, which is analyzed in the area of aneurysm and feeding vessels. So the volume and the blood flow and also direction are measured before and after surgery. Some clinical example: a woman 35 years, carotid artery aneurysm. She was deployed FD, and the comparison of amplitude prior and after 0.59 speaks that the number of you see blood going through aneurysm is less in half a year. You can see the complete occlusion of aneurysm. The next example, a male, 67 years, FD deployment in 012, the coefficient above 1, control in 6 months, incomplete occlusion, angiography in 2 years also showed some remaining aneurysm and additional treatment necessity and deployment of additional devices. I promised to say a couple of words about those before. I found very interesting information on the MAGAT site. If we analyze all the images of the theoretical images, then we will see that the dose used is very high. What Philips company invented? It invented a clarity you see methodology that allows to reduce the dose by 3-4-fold for the patients. That means that the quality is the same, and the dose that both the dose and the patient and the doctors get becomes less. This is how this image looks. Why is it becomes better? Here the technology implies the displacement of mass images in real-time mode. In case the patient changes the image, you see shifts accordingly, and there is no you see and this ensures the clarity of the vision. In conclusion, I would like to say that all this is very well, but this is a mechanism, this is a device in your hands. But once again, I would like to thank the organizers and tell that quite a high level of today's presentations, and I believe that you deserve a very good device, both you and your patient. Thank you very much.
Thank you, Pavel. We really hope that in the nearest time we'll be able to have this Philips UC angiograph, most probably. Well, the best should be the best, for the best. Thank you very much. Well, the official part of the first day is over. I believe you agree. We have 3 buses awaiting us. We travel to Koktubye area. There are 2 options to. Well, one option is to well, go on the top via funicular, and the second option, we come all the way to the you see, to the turnover, and then we will have to change the buses for the vehicles, smaller vehicles. So what is your choice? So now let's go all together. Thank you.
Можно будет 3-минутное видео? Short video from yesterday. Your attention. Ваше внимание. 3-минутное видео.
This is what we had yesterday, Professor Prague.
Это вот было клипирование вчера. Ревас Семенович совместно выполнили клипирование аневризмы с средней мозговой артерии. Ну, закончили в полночь. Пациент в палате довольны. Спасибо. Спасибо за внимание.